Good afternoon, Dr. Gujral, Dr.
Good
Meena.
afternoon. Yeah, how are you? I can't see you. I can hear your voice. And we were in the panel together, so I can recognize your voice.
I don't know. I can also not see myself. I can only see you. Now I can see.
No, I wish Dr. Meena Samad lagao sir.
Now I've got, yeah.
No, I can't see you still.
And ma'am, your name is not showing. It is just showing faculty. To rename.
Please rename. गुजरात लिखा था ना गुरुकुल है वो देखो तुम क्या करती हो आ गया कोर्स तो नहीं बनेगा I'm not taking the case now. Oh. Please. Yes, it is. क्या हो गया Nikki can never start in time now. वैसे क्या फायदा हुआ इस लेटर ज़्यादा स्टूडेंट्स का अब आएगा रुको नहीं रुको Where is रेणुका माला को ऑन करो सुन नहीं रहा है
हेलो
Yeah, now we can hear you.
5 मिनट के बाद ही हम शुरू करेंगे
So
क्योंकि हम केस प्रेजेंटेशन 2 बजे से पहले नहीं स्टार्ट कर सकते ना मैम
that's fine, that's okay, no need. You can go on talking.
Hello. Good
Hi.
afternoon, ma'am. Good afternoon.
Good
to all.
afternoon. Hi, how are you, Renuka?
Hanji, ma'am,
Long
fine.
time no
PG.
see. No, busy.
Hanji, ma'am.
Yeah, I not heard from you for a long time. You know.
Yes,
Getting
ma'am.
ready to come back.
Yes, ma'am. Joining soon.
Yeah, you have to join every first. You have a friend
Hanji,
now
ma'am.
with you, so you got one consultant more.
Hmm.
That's good.
Yes, ma'am.
There's one more. Dr. Vidya has to join.
Dr. Vidya, she has not joined. Dr. Mala ne call kiya, I think. She'll join us.
Hello, Mr. Alo, can we start?
Yes, ma'am.
Join कर लिया लोगों ने?
Not two yet. No.
मैम डॉक्टर विद्या तो अभी मैम ने भी ज्वाइन नहीं किया.
नहीं अभी 2 भी नहीं
उन्होंने कहा
बजे.
मैं ज्वाइन कर लूंगी.
ओके.
To start at 2, no? So it's not yet 2.
Yeah. So we just give 1 or 2 minutes of introduction and then we start off.
Yeah.
I think that's good now.
You can give a chance to any participant to speak something if they have logged in. Somebody wants to say something. Only we've been saying, no?
Mr. Alok, आप खोल दो.
Although participant go, we can
हाँ.
take some feedback from the participants
Yes.
before we start.
Yeah. I think
that'd
that's
be
a good
better.
suggestion, madam.
It's allowed, ma'am.
It's allowed. So Mala, ask any participant.
Yeah. So we are audible, no?
Yes, ma'am.
Okay, nahi, for the audience. Mr. Alok, are we audible for the audience?
Yes, ma'am.
Okay, so good afternoon. Today is the second day for the Gurukul classes that we are having since yesterday. I'm sure all of you enjoyed the case presentations as well as the didactic lectures that we have by Dr. Shobha Gudi as well as Dr. Ashok Kumar and Dr. Chanchal. Any participant has any feedback to give or any comment to make, will be very happy. But first of all, it's my pleasure to invite our guest of honor, Dr. Kamal Gujral, who is the head chairperson, Institute of Obst and Gynae, Sir Gangaram Hospital. Madam is the chairperson of the Fetal Medicine Society, as well as Madam had been the president of the NARCHI, and Madam is very, very academically oriented, and she helps us and guides us in all the academic activity that we do in the department. Over to you, Madam, for your
Thank
input.
you, Mala, for those kind words. We are missing Professor Kamal Bakshi, who perhaps has taught all of us. Such a big CV, and what to say about her. I'm missing her comments. She would have lightened up this, this program, So now I just want to know, any participant wants to say something? Is there no voice from the participants? Speak up, please, anybody.
How did you like the class yesterday, the case presentation?
Anything, because we're doing it repeatedly, instead of giving a lecture on it like that.
Ma'am, then they are replying in chat box.
Okay.
Chat box.
They are replying in the chat box.
Chat box mein dekho kya comment hai.
Good morning, ma'am. It was very fruitful session yesterday. Such a good initiation, this online class, since many of us students are not able to attend live. It was very informative from all of us, for all, madam. This is Dr. Garima and this is Dr. Prerna. SR.
Yeah. So that's nice if the students feel that way. All I want to say that you're going to go to many places to give exams. You see, DNB, different hospitals have different kind of setup, different kind of teaching. So you don't have internal examiners from your institution. That's the difference between DNB and MD. And I personally feel, having done MD myself, that it's easier to pass MD. It may be difficult to get MD, but it's easier to pass because you have your examiners at the back of you and your own institution also. So here you're in a new institution, new examiners, different setup. So this kind of forum really, exposes you to various places. As you can see, the faculty is chosen pan-India. So wherever you are, maybe in practice, maybe in medical school or anything, you're going to be exposed. So I'm sure this is going to be more helpful, for DNB rather than a small teaching. And also, I hope you all are attending the DNB seminars. Sorry, you all are attending the DNB seminars every Thursday. They're also very informative, you know. So this and plus classes like this, you can just go through the DNB. It's nothing very difficult to pass. So do we start, Mala? Still, we've got 5 minutes, sir.
While Dr. Renuka gives introduction to the moderators, I will ring up Dr. Vidya Thobi, madam, whether
She's already, you already introduced me. So Renuka, you can introduce Dr. Meena. I have been introduced, and you can introduce Dr. Meena and Dr. Vidya. So as soon as you
sharp 2 o'clock, we will start.
So introduce Dr. Meena Samant and Dr. Vidya Thobi.
Okay. So very good afternoon and happy Lohri to all of you. So we will start session 1 of today's scientific program. And with this, and to chair the session, Dr. Gujral is already here. And I'm inviting Dr. Vidya Thobi. Ma'am, she is a professor and head of the Department of OBGY at Al Amin Medical College, Vijaypur. Next is Dr. Meena Sawant, ma'am. She is professor, consultant and head of the department at Kurji Holy Family Hospital, Patna, Bihar. Welcome, ma'am. Dr. Vidya will join us soon. So I am
Dr. Vidya is joining from a laptop. So
Okay,
we just wait for 1 or 2 minutes to introduce our PG students, and then they can start off their Vidya history.
Okay.
While we
So
give the introduction of our PG students.
so next I'm inviting Dr. Priti. Dr. Priti is a DNB student with us, and next is Dr. Spurti. She is also DNB student with us. So they both of them will present case on multiple gestation. Dr. Priti and Dr. Spurti, please say yes.
Yes, ma'am. Good afternoon,
you can
moderators. Ma'am, can we start?
Just a minute more because Dr. Vidya has to join. Just sharp to, I think organizers give us a tinkle when it's 2 o'clock.
Okay, ma'am.
That'll be better.
Okay.
I'm seeing one comment in the chat box, Mala. Are you there? Organizers? They're not there?
Yes, ma'am.
Well, they say that the one candidate has written that just one small thing to it to the team. I was logged off many times yesterday. It becomes difficult to catch up. So why this happened? Is it the local?
Mr. Alok will answer it, please.
Alok ji, answer karo.
Ma'am, then there was a internet issue from their end, not from our end. So then they log off from June.
So the answer to the candidate is just see that your internet is good enough when you log in and you are in a quiet place, not on your mobile phone when it keeps getting off and you get a call also. So Alok, just give us a tinkle at 2 sharp so that Vidya Thobi can join us. Alok, can you hear me?
Yes, ma'am.
One candidate has asked that, are these lectures recorded? Are you recording them?
Yes, yes, ma'am.
So if the candidates want to use get these lectures, how do they go about it?
Then they will ask with the organizer committee. If they approved, then we will send.
The organizing committee is us, no?
Yeah.
Yeah. So if we approve, and where does the candidate approach? To you or to us?
From you, ma'am.
So we gave a yes to the thing, and then you are able to.
Yeah.
You know, and we also have to take consent of the person who has given the lecture.
Yes.
You know, who's given the lecture, that consent has taken that they can be used.
Yes, ma'am.
You know, like when we give a presentation in a conference, they ask us, can we use your slides? So we have to give a consent, no? So that part you should put it.
Yes.
The dedicated lectures which are there, if the candidates want a recording, can we give them? You know,
Okay.
whatever
Sure.
happened yesterday, आप उनसे ना consent ले लीजिए.
Yes.
है ना?
Sure.
To a written consent to you, I mean, email consent, yes, my recording can be given, and then we can give.
Sure, ma'am.
Because that will include the slides as well, na?
Right, ma'am. Right.
Right. So आप ये देख लें. Do this job. Yesterday there were
Ma'am,
lecture on contraception. There was there, and only one lecture was there. Instruments for questions otherwise. So there was only one lecture. So there are not that many lectures as I can see. Yeah, there are not many lectures, you know. Mostly there are cases and few vivas. So there's only one, and CTG. There were 2 lectures, correct. Yesterday there were 2 lectures, so you can ask both the speakers, you know, that whether they can be given to the audience.
sure, ma'am.
And just 2 lectures there, and maybe 1 odd lecture in the, yeah. I think 2 or 1 lecture in every day. So 3 or 4 lectures only, and they are theoretical lectures, so they may need that slides also. So is it 2?
Yes, ma'am.
Hmm?
Yes, ma'am.
Can we start?
Doctor, Vidya is not in Zoom right now, ma'am. So
We can
Can
start. I think she will join us soon.
we
We'll
can
call.
start. Otherwise we get late. Now she can join a little late. No problem.
It's
Few
already 2, so
minutes
we.
to go.
Huh.
Okay.
Ma'am, please show your slide in full screen mode.
Yes, full screen and start.
Yes, ma'am.
Please start.
Is it,
Mr. Lo, please
is it
start.
visible? We've started
yeah.
slides. Ma'am, are we
Yeah.
audible enough, ma'am?
Yeah, you
Yes.
are audible enough.
Yes, yes.
Good afternoon to everyone. I myself, Dr. Spurti Javalgi, first year resident at Gangaram Hospital, and Dr. Priti ma'am, finally resident at Gangaram Hospital, are going to present a case on twin gestation. A 33-year-old primary gravida with 30 weeks of period of gestation with dichorionic diamniotic twins with 1 intrauterine fetal death of twin. A 33-year-old female, Mrs. X, who is a resident of Vasant Vihar in New Delhi, who is a BA graduate homemaker, wife of Mr. Y, 35 years old, BSc graduate, who is a businessman, belonging to the upper middle class by modified Swami scale. The presenting complaints of the patient is primary gravida with 8 months of amenorrhea with DCDA twins with the ultrasound diagnosed as intrauterine fetal death in 1 twin. Patient had no history of pain in abdomen, bleeding per vaginum, or leaking per vaginum, and she appreciated the fetal movements. History of present pregnancy in the first trimester, it was a spontaneous conception, which was confirmed with UPT at home at 10 days overdue of missed period. She was registered at a local maternity home at 2.5 months gestation. Routine blood investigations were done, and patient was started on folic acids that she took regularly. First ultrasound was at 11 weeks of gestation, which was suggestive of the DCDA twins, and NTNB was done for both the fetus, where both the fetuses was reported normal. The dual marker test reported low risk. There was no history of excessive vomiting or no history of any discharge, bleeding, or spotting per vaginum. No history of any frequency of burning micturition or fever with rash. There was no history of easy fatigability. There was no history of exposure to radiation or drug intake. Routine antenatal care was done. In the second trimester, the quickening was felt at 5 months, and she continued perceiving the fetal movements. 2 doses of tetanus vaccine received, and patient took iron and calcium supplements regularly. Level 2 scan was done that was suggestive of no gross congenital anomaly. GTT done that reported normal. In the third trimester, the patient continued perceiving the fetal movements adequately. Iron and calcium intake were regular. There was no history of any bleeding or discharge per vagina. At 30 weeks of gestation, an ultrasound was done that was suggestive of a fetus A, that is phallic. At the gestational age of 29 plus 6 weeks, placenta was anterior, which was away from os, and fetal heart rate of the first twin was 150 beats per minute. SDP was 3.6 centimeter, and estimated fetal weight was 1391 grams. The fetus B was breech with a gestational age of 25 plus 6 weeks, and there was a diffuse edema all over the body. Cardiac activity was absent, and SDP was reported 5.1 centimeter with estimated fetal weight of 835 grams. Then the patient was referred to the Sir Gangaram Hospital for further management. Menstrual history. Patient had menarche at 14 years of age. Previous cycles were regular for 44 days and of 30 days cycle. There was no associated dysmenorrhea. Her last menstrual period was in April 10th, 2023, and her EDD was estimated about 17 Jan 2024. Marital history, married since 2 years, that was a non-consanguineous marriage. Primary gravida, cohabiting with the husband since marriage, and contraception was never used. Past history, there is no history of hypertension, diabetes, asthma, thyroid disorders, or any other systemic disease. There is no history of clotting disorders, no history of any blood transfusion in the past, and no history of any surgeries in the past. Family history, there is no history of hypertension, diabetes, or any other systemic disease in the family. No history of twins in the maternal uncle. And there was history of twins in the maternal uncle. Personal history, normal bowel and bladder habits. Sleep pattern was normal, no adverse social habits. On the basis of 24 hours recall method, her daily calorie intake was 2,250 kilocalories and her daily protein intake was 56 grams. General examination, patient is conscious, oriented to time, place, and person. She is moderately built and nourished. Height is 160 centimeter. Her pre-pregnancy weight was 55 kg, so her BMI came out to be 21.5. Current weight is 66 kg and weight gain was 11 kgs. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema seen. Breast examination, no abnormality detected. Thyroid, no enlargement present. Tongue, teeth, gums, normal. Spine lordosis was seen. Gait, waddling gait is seen. Vitals, respiratory rate 16 per minute, that was regular and abdominothoracic. BP was 120 by 80 in both the arms in the sitting position. Pulse 82 per minute, that was regular with a good volume and all the peripheral pulses were palpable and there was no radial or radiofemoral delay present. Temperature was 97.6 degrees, febrile to touch. CVS S1 S2 heard and no murmurs. On the respiratory system, bilateral air entry equal and no added sounds. CNS, there was no focal neurological deficits. On obstetric examination, on inspection, abdomen over distended, umbilicus is central and everted, linear nigra and stria gravidarum were seen, no prominent veins seen, and no scars were seen. And the hernial sites were intact. Palpation, fundal height corresponding to 34 weeks of gestation, symphysial fundal height of 34 centimeter, abdominal girth of 98 centimeter, and multiple fetal parts were felt. On the fundal grip, multiple fetal parts were felt. Lateral grips, a smooth continuous curve was felt on the right side, and irregular multiple fetal parts were felt on the left side. The first pelvic grip, a hard ballotable mass felt, which was suggestive of head of one twin. And on the second pelvic grip, the findings of the first pelvic grip were confirmed, and cephalic pole not engaged. On auscultation, one fetal heart sound heard on the right spino-umbilical line with fetal heart rate of 136 beats per minute, and the second fetal heart sound was not localized. On local examination, external genitalia was normal. There was no leaking or bleeding per vagina. Summary, Mrs. X was a 33-year-old primary gravida with 30 weeks of gestation with a last LMP of 10th April 23 and EDD of 17 Jan 24 with dichorionic diamniotic twin pregnancy who is diagnosed on ultrasound with IUFD in twin B was referred in the view of one twin IUFD. Antenatal care was done outside and level 2 ultrasound showed no gross congenital anomalies. Ultrasound done at 30 weeks showed no cardiac activity in twin B. On examination, her weight gain in pregnancy was 11 kgs, her pulse rate was 86, and her BP was 120 by 88. On obstetric examination, revealed relaxed uterus with adequate liquor and twin pregnancy with twin acephalic and fetal heart sound localized on the right spino-umbilical line with a heart rate of 150 beats per minute. And fetal heart sound of the twin B was not localized.
Right. Dr. Toby, would you like to comment? Dr. Toby is not there. Ramina, would you like to comment something on the history?
Yeah, a patient came to you when she was seen in the first trimester and her ultrasound was done. What are the usual things that you see in that?
Ma'am, we first, in the very first ultrasound, we first go for viability of the fetuses. Then we go for a number of gestational sacs. And if she's come to us like in 8 or 9 weeks, we can even determine chorionicity.
No, she's come to you at 11 weeks. That was the time it was free. And that is the time we usually do. So
Yes,
what are the things that you're looking? You told me the number of fetuses and the viability. What else?
chorionicity, ma'am.
Okay, if it's a twin, then chorionicity.
Yes, ma'am.
Then NT.
Dating.
Crown rump length.
Crown rump length, ma'am.
So whenever we make a diagnosis of twin, it's not just twin. You have to do the chorionicity, and also you have to label your. And you kept saying fetus A and fetus B. How do you describe fetus A, and how do you label fetus B?
Ma'am, usually the fetus or the gestation sac which is closer to the os is termed as the first twin, and the gestation sac of fetus which is away from the os is termed as second.
I have a comment to make here, Preeti. This is not correct. A and B is it's right or left, upper or lower. That's the way to label it. That's the correct labeling. So A, B is out. Number one, I have one question of Meena. If you notice that she said in the history, the dead fetus has more like a SDP was 5 there, or did I hear it wrong? Can you
No, ma'am,
refer back?
the normal fetus had the liker of
just see, I thought I heard it the other way around. Okay. And what the dead fetus? No. You go show your slide. You wrote that.
Yeah.
Dead fetus had more, larger SDP, and the live fetus had a smaller SDP. Is that so? Or you written it reverse?
I think, ma'am, it's a typing error. The live fetus had the normal liker.
Yeah. So that's what I'm saying. That was the mistake. Labeling was the way you said again. That was a mistake. Otherwise, I think all points you covered. This is a very gross mistake.
Another thing, if there is a, if it is a fetus which is dying with the polyhydramnios, what should you suspect? Generally, we expect,
anomalies.
Yeah, chromosomal anomalies or other malformations are more likely.
Yeah, but she's had a scan. No, she's had a. All right. When you said dating in the first semester, how do you date a twin? Yours was an IVF pregnancy. How do you date a normal twin, naturally conceived, or an IVF conceived twins?
Ma'am, ours was a naturally conceived twins.
All right. So how do you date? How do you decide which CRL you use for dating of pregnancy?
Ma'am, we take the CRL of the larger twin so that we don't miss out on the FGR.
We don't miss out FGR. In a naturally conceived twin, you see the CRL of larger twin, and in the IVF conceived twin, how do you date? In an IVF conceived twin or otherwise also, how do you date?
Ma'am, we in IVF conceived twins,
or even IVF conceived,
we'll look for, we'll first take into consideration the embryo transfer date at when was the embryo transfer date. Then according to that, we calculate LMP. And even if it's a IVF conceived twin, then too we should go for a twin which has a larger CRL for dating.
You date the pregnancy in a natural conception, you know it. In an IVF conception, it is a date of egg retrieval in a fresh cycle. Remember that. Egg retrieval in fresh cycle, and in a donor, frozen cycle, you date the embryo transfer and minus 14 days. When you have a blast, it will be just 2 days plus here and there, right? So that is the way, and always use the CR for correction for that. But IVF dating is different from the other dating. This is number one. Then how do you do an aneuploidy screen in twins?
Ma'am, in the twins, we will take, in the DCDA twins, ma'am, we'll take the NT of the larger twin and the mean of the serum maternal serum markers.
In a DCDA twin, you take
NT of individual NTs.
Individual NT and use all the other. And
yes, mean of
1%, please. In a
the mean of the serum bio.
The serum analytes, they are not biomarkers, the serum analytes, the software corrects by itself. You have got the form, you click tick twin, the software corrects. So you take NT of the individual twin, correct, for aneuploidy screening. And for monos?
For monos, we take the mean NT and the mean serum marker.
Suppose your patient had started with triplets and there was a vanishing twin, how would you interpret aneuploidy screening? There is a vanishing twin or measurable pole is there. So what markers are going to use? It's very important.
So, ma'am, that time we take only the NT and the
Age.
serum. We don't take the serum markers. We take the age and the NT.
You use the NT and the maternal age. So these are the important things. And what else?
So something which always going to be asked is about determining the chorionicity is so important. Can you just briefly tell this?
Ma'am, there are specific signs like in dichorionic, we have the lambda sign, which is because of the membranes present in between the two. When there are 4 membranes in DCDA, so we have a lambda or a twin peak sign, and in monochorionic we have a T sign.
Lambda. Fine. Can you see the other thing? Number of membranes, but these are 2 signs. When Dr. Meena asked you at 12-week scan, you said everything. You missed out one thing. Can you recall? You said the dating, the number, the viability, all that you said. What else did you miss?
Cervical length assessment.
Not really in first trimester. Placenta, never forget the placenta. For any ultrasound in first trimester, never forget the placenta, and any adnexal mass also. That's a routine first trimester. Must always remember. Say the number, whatever you want to say, but these 2 factors must not be forgotten. Now, having done a first trimester screen, we will not discuss NIPT here because not everybody uses it. Now come to your second trimester. What are you going to look in the ultrasound?
Ma'am, in second trimester, we will look for first of all, any anomalies, congenital anomalies. Then secondly, we as these patients are at a higher risk for preeclampsia, we'll do a preeclampsia screening for them. And also, if it's a monochorionic...
So we're talking now. Let's not do that. We're doing dichorionic at the moment. Your case.
So we...
Umbilical artery Dopplers, ma'am.
See, you look at the
Doppler.
Not really, chalo. Uterine is more important here. See, in a second trimester, what I wanted to answer, the recommendation is that you do at a little later gestation. Instead of 18, you do it at about 20 because twins are smaller, they're clear 1. And secondly, as per the guideline by the societies, you are supposed to spend 45 minutes on that.
45 minutes.
45 minutes. That means you scan the babies from head to toe, look at the placenta. Now it becomes the importance of what you said in first trimester, though you can see in first trimester also the cervical length. And then the uterine artery Doppler along with the preeclampsia screen, if you have PIGF, etc., available at your institution. Otherwise, you can look at the uterine artery Doppler. And how do you interpret it? You don't have the PIGF, you just have the ultrasound. How do you interpret that?
So if we see an early diastolic notching or persistent diastolic notching, then...
Do you think this is a correct answer?
Ma'am, ideally, in uterine artery Doppler, the PI is more than 95th centile.
But that's all you have to say, na? Uterine artery Doppler, mean PI more than 95th centile. It's a 95th centile. Tells you that it is an abnormal and you may start aspirin or whatever. Even at 12 weeks, it applies to the same thing. Mean uterine artery PI, that's all. Whether it's a singleton or twin or triplets, whatever it is. Notches have no meaning, right? So anomalies scan done. When do you do echo? Do you do in all? What are the recommendations?
Ma'am, fetal echo is to be done in a singleton pregnancy, or we used to do it if we have a indication like if the NT is not okay, or we have a risk in the dual marker.
What is the risk in a dual marker for a fetal echo?
Ma'am, like if the NT is on the higher side, but the dual marker has come out to be normal, so there is a discrepancy. So we can go for a fetal echo.
It has nothing to do with the dual marker. It is raised NT besides the chromosome. Next common is the heart defect. So you do. This is one you said. Second.
In high risk patients, like if they have diabetes, pre-pregnancy diabetes, they are more at risk of congenital heart diseases when they conceive.
See,
And,
whenever a question is asked like this, no, in exam for anything, think of the mother, think of the baby. What are the maternal conditions leading to what I've asked? Maybe heart defect, maybe anything. So you said diabetes and other thing, you know. Then there's a past history, personal history, medical history, and the fetus. So if you look at that particular thing, she's had a child with a congenital heart disease, sibling is there, or a family history of a congenital heart defect. So this is where you stand with family history. And if they're carrying some gene, etc., and some drug intake, maternal history, diabetes, so many other things, you know. Epileptics, you also screen. But specifically, they remain the same. Fetus, you said, one abnormal entity. Second, if you find one anomaly, then echo has to be done to rule out the cardiac anomalies. Any one anomaly in any system, do an echo. But specifically in twins, when do you advise echo? These are for general echo for all pregnancies. When do you advise an echo in a twin pregnancy?
Ma'am, first of all, in all monochorionics, we advise.
In all monochorionic, despite a normal cardiac screen at mid-trimester, which involves a 4-chamber and outflow and 3-vessel tracheal view. These are 3 things which are, if this cardiac screen is sufficient, you don't have to do echo. But in monochorionic, you do echo. That's the only answer I wanted. Dr. Meena, you want to add something?
Not in the related to the echo, but yes, in the second trimester, we all know that twin pregnancies are very prone to preterm deliveries. So what in the assessment of cervix you're going to see, and how do you interpret that?
Ma'am, we look for cervical length in second trimester scan. And
transvaginal, remember that.
Yeah, or transvaginal. Any funneling or any U-shaped if we defect.
No. We just have to look at the cervical length. Yeah,
how much cut off she wants to ask you. Cut off.
If it's less than 2 mm, then it's a high risk.
2 mm.
What is 2 centimeter? Sorry.
25 is the cutoff line. 25 is less than 25. They have higher chances of about 60-70% going into preterm birth. But do you offer anything? Let's see, your patient has a length of 22 mm. This patient, what would you do? Can you do something about it? In twin pregnancy, not singleton, please. Huh? In twin.
As she is a primary gravida, she has no previous any history of any preterm or any abortion. So we can, we usually do not offer anything like progesterones or encerclage is not recommended.
Cerclage is not recommended. So, yes, ma'am. Yes,
yeah, I think there is some. There is some.
Yeah.
I just joined. Sorry.
They were just saying. I was just asking them. Have you heard the case from the beginning or no? Dr. Vidya, are you there? Is she there?
About the sonography, right?
No, we just give you a brief. This is a case of twin gestation, diachorionic diamniotic. She was having ANC elsewhere. Everything was normal till 20 weeks or 22 weeks of pregnancy, everything. And then when she goes for a scan at 30 weeks or 29 weeks, there's one twin which is dead. Right? This is the case, and this is how she's referred to them for further management. That's the brief. So we have dealt with chorionicity, we have dealt with dating, we have dealt with anomaly, we dealt with echo, and now Dr. Meena was asking her what is the cutoff of cervical length? And what do you do if the length is, let's say, 22 mm? So the candidate has answered that she doesn't want to put a stitch, which is right. And she says she doesn't even want to use vaginal progesterone at a short cervical length in twin pregnancy.
Yes.
Well, some
there's some rule,
that's
the
right.
micronized vaginal progesterone now
may help, you know. So, but twin, the pathology is different. It's over distension and all. Right. And what about the hypertension you said? When will you start aspirin? If you're screened for preeclampsia?
About 16 weeks, ma'am.
She said at 12 weeks. You should have started at 12 weeks if the uterine PI was more and your markers did predict preeclampsia. Correct?
Yes.
Now, how many checkups you do in a, and how many checkups and how frequently ultrasound is recommended in a dichorionic and so in mono also?
Ma'am, in dichorionic, in dichorionic pregnancy, we usually go for 8 ANC visits and 2 with the specialist, and we recommend a 4 weekly ultrasound, which was missed in this case.
Yes,
ideally.
she had at 20 weeks, and then when she was having a routine antenatal where sepsis spondylitis is very misleading, so she was perceiving movement wells, and when she was advised to scan at 30 weeks, one fetus was at 25 plus 6 weeks. It stopped growing at that time, right? So 4 weekly scans is the recommended norm in a dichorionic diamniotic. And how about, so 20, 24, 28, like that go on till 36. And what about the monos?
Ma'am, in monochorionic, there are 11 visits recommended, 2 with the specialist, and we have a 2 weekly ultrasound in monochorionic pregnancies.
Yes. So when we said 45 minutes you spend in a anomaly scan, how many minutes you spend in a growth scan?
30 minutes,
30
ma'am.
minutes.
15 minutes for each twin.
And
30
how
minutes
you
overall,
Yes.
not 30.
how you monitor this growth scans? I mean, how often?
Ma'am, your
Ma'am?
voice is unclear.
and
4
again,
weekly, she
can
said,
you
and you said
repeat
4
it?
weekly
Mono
growth
and
scans.
dichorionic, diamniotic.
Okay, you're doing 4 weekly scan, and when you see the growth of the baby, when you check the growth, what do you use? What is the recommendation? How many parameters?
Ma'am, we use head circumference,
Head.
abdominal circumference, and female
What is
length.
the
And
usual
estimated
ultrasound?
fetal weight.
Yeah. What is the usual recommended formula for fetal weight reduction? Singletons or
Headlocks.
headlocks?
Headlocks
Headlocks
form.
is the best specificity sensitivity. So use that formula. 2 or more measurements. Headlock formula. So my again question to you, what do you mean the weight and the amount of amniotic fluid? When do you add Doppler? Do you do Doppler as a routine? Many of us are doing without any reason. Or when should you ideally add Doppler in a growth scan?
Ma'am, in twin
Yes, in
gestation.
twin. We are at twin only. When would you add Doppler? We are talking about dichorionic diamniotic. We didn't talk about monos.
Yes,
Okay, so there's no TTS business here. Quick, yeah.
So, ma'am, if we have a discordant growth or if we have a selective FGR, then is the time that we should be looking into the Dopplers.
Your answer should be if the growth of one fetus is less than 10 centimeters or there's a discordance more than 20%, that's the time I like to add Doppler. Huh? This is the answer, correct answer. So now you have put your foot into the mouth. Your baby had selective FGR because the other is normal. How do you define selective FGR? You do get a short note also in OSCE, selective FGR.
So, ma'am, starting with in dichorionic, if the estimated fetal weight of the smaller twin is less than 3rd centile, it is definitely FGR, selective FGR, or there should be either of the two, the following, either the weight discordancy is more than 20%, or there is a abnormal umbilical artery Doppler. And
95th.
And if the
so you said in a selective FGR, if 3rd centile growth is there, this is definite FGR of one fetus. Obviously, selective means one. You said the weight of the or 2 of the 3. If the weight of the fetus is less than 10 centile,
10 centile.
right? If the discordance is more than 20%, and the umbilical artery Doppler is more than 90.
More than 90%.
These 3 correct, that is called as selective FGR. So if your patient had an ultrasound at 28 weeks as recommended, not even at 24 she had at 20. So maybe at 24 weeks or 26 weeks, there should have been some discordance for you to realize that it is going to lead into the FGR. And in monochorionic, how do you do this selective?
Ma'am, apart from all these criteria, and we also add in the abdominal circumference.
Yes, in that is all. And stage 1, 2, 3, you read it up on your books.
Yeah.
Okay, now, so you've done this. And what? Sure, ma'am. Yes, ma'am. Dr. Vidya has gone off the...
No. Some network issues.
The sound, now we are listening. You please speak up.
Yeah. Whether I'm audible, I don't
Yeah,
know.
very much audible. Now clear audible.
Yeah, yeah. What are the causes of discordance? If we see, what are the main causes in mono and di? Both. Can you tell me, and how you can
sure.
monitor them?
Good question.
Yeah.
Ma'am,
Causes of
basically,
discordance. Yeah.
they say that discordance is usually at the level because the placental volume, that one fetus has more sort of placental volume, so there is better vascularity, and the other fetus has a little lesser placental surface area, so there is a compromised vascularity, and so
So main
there is a
three causes we have to tell is fetal growth restriction or twin-to-twin transfusion syndrome, what triple T is. So that is the main cause, or any abnormal karyotype also you can mention. In these cases, we get this discordance, right?
Yeah.
So,
Main thing is the normal baby is normal, the abnormal baby is small. And in the monoclonal, she says the twin to twin, one baby is big, one is small. That is the difference how you decide. So having said that, we will come to the death of the fetus little later. But in dichorionic twins, when do you time the delivery?
Delivery, yes.
Ma'am, it's usually
antenatal care, usual, watch iron, folic
and
acid.
you have to read about the antenatal complications and all those things that they are routinely asked, no?
Yeah.
So you know those complications.
Yeah, and two things you must remember: anemia and blood pressure. These are two things which are more common in twins, no? So that you look after. Since we were to stick to twins, we are not going to that. When would you deliver them? Recommendations.
If it is uncomplicated DCDA, ma'am, at 38 weeks, we can deliver the patient, ma'am. I mean, if it is monochorionic, ma'am, monochorionic diamniotic, it can be at 36 weeks, ma'am. And if it is monochorionic monoamniotic, 32 to 33 plus 6, ma'am.
Yeah.
So what happens? So it's 37 plus 6, no? That's till
yes,
that
ma'am, 37.
So that's fine. 38. This answer is okay. Now, what happens if your patient says, I am all right, my BP is okay, I'm good, I am perceiving the movement. So not this patient. And why do you want to deliver me at 38? I want to go on. Now, this is complicated, uncomplicated. I'm talking about. What would you do?
Ma'am, because
she says, I have no blood pressure. I'm absolutely feeling good. My babies are absolutely normal, healthy. You are telling me this. And why should I deliver at 38? I'm not ready. So what should you, how should we be counseling about?
We will counsel her about, like, after 38 weeks, there have been increased chances of stillbirth and intrauterine deaths. So that's why we want to deliver you at 30, maximum at 37 plus 6
weeks. As per the evidence, there is higher death rate after 38 weeks and never beyond 39. So if you wish to go beyond it, we will monitor you. And how will you monitor? You can't say, jab aa jana, pain aayega. No. No. So you have to tell her, this is the way. Normally, you don't monitor that way. She says, I don't want to deliver. 36 weeks ultrasound has happened and now she doesn't want to deliver. What will you do? How will you monitor specifically? What will you tell her and what will you do?
Ma'am, we will counsel her that she has to have twice weekly visits along.
She should feel fetal movements and weekly ultrasound at least should be done, where we should look at all the factors, the biophysical score, etc. Who will ask her questions how to deliver the twins?
Yes. How
That's
do
the most
we manage
practical
twin
question.
pregnancy in labor?
Yes.
So this is most important. Yes.
Both twins are normal, AGA fetuses, and you want to deliver them.
And where you want to deliver?
Yes.
Oh, ma'am, for twins, as it is a high-risk pregnancy, we will require a tertiary care setup. Where basically we have 2 obstetricians available, 2 neonatologists available, an ultrasound machine, portable ultrasound machine, anesthesia team at backup, and we have facilities for blood transfusion and emergency LSCs anytime when
Whether
we
you
feel
will
so.
give epidural? You prefer
Yes, ma'am. Epidural is allowed for twin gestation.
Yes.
How
And
do you monitor them?
monitoring?
Monitor कैसे सुनोगे fetal heart?
Ma'am, 2 clinicians should stand with the probes at 10 centimeter apart, and there should be a silent area between the two, ma'am.
What is the silent area?
Ma'am, in between the 2 probes, there should not be any fetal heart sound heard, and the beats of the 2 babies should be at least 10 beats apart, ma'am. The heart rate of the 2 babies.
So it's recommended that if you have any difficulty and feel the maternal pulse also, Many times
Yes.
the fetal heart rate, you're listening to the maternal, and if you're
Yes.
not being able to see fetal hearts like this, which most often you may not be, so then you should have an ultrasound in the labor room to localize the fetal heart and then put the probes in case you are unsure.
Yes.
Right? And dual channel should monitor. It's a high risk pregnancy, continuous CTG. And if the membranes are ruptured, if you have the facility, debatable, you can do one internal and one external. None of us do that.
Both vertex, one vertex, one breech, one breech, one vertex.
Ma'am,
Yeah.
when we have the first vertex, we can allow vaginal trial. And
It is not called as a trial, right?
we can allow vaginal delivery.
Hmm.
We can induce the patient if the first is vertex, basically. And if she has no discordant growth, no FGR, and also if there is no obstetric contraindication for
Absolutely.
induction of labor.
Absolutely. Yes.
So these are the indications for, if your patient asks you, they tell me which method is better, both cephalic, right? Both okay. What will you tell her? Which method is better, doctor, as per you? In practice, they ask you this question very often. What will you tell
Ma'am,
them?
using any drug rather than using any drugs, I would prefer using a Foley's. Mechanical induction. Mechanical induction with Foley's.
See, normally majority are going to be in labor by themselves by 37
Yes,
weeks. And normally their services are short. So labor, if it comes, it is not very long and not very difficult, But if the patient desires to have an elective cesarean, she says, give me the data. What is better? Will you recommend cesarean? मुश्किल में डाल दिया ना. Quick, yeah, it's very little time left.
Not unless there is an not unless there is an obstetrical indication, ma'am.
So if
we
the patient,
will counsel her. We will counsel
counsel
her
her,
yes,
that in cesarean we have a chances of TTTN, and in twin, or then there will be.
so you will give her the advantages, disadvantages of cesarean and tell her, let her take a call, because cesarean on maternal request is now allowed. And even the RCOG says if the patient asks for it, you can go for it, but we are not recommending. So you have delivered both the fetuses. Any precaution in the third stage, and what is the recommendation? And then we'll come to your case.
Ma'am, after delivering the first baby, we are not supposed to do the active management. We are supposed to do active management.
No,
that
you
is
delivered both.
oxytocin.
That's
You
fine.
have delivered both, na? So you have to do active management.
Yes, ma'am.
Let us ask them. First is delivered, and now second, when do you do the rupture of membranes? Very important question.
Ma'am,
First is delivered, second is cephalic, and when will you do ARM, or you will not do whatever you do? What do you do once the twin has caught the clap, send it? Then what do you do?
Ma'am, ARM is usually preferred when the presenting part has descended into the
Yes, it should be
pelvis.
engaged. Then only
You
you should
see
do
the
it.
fetal heart of the second baby, see for the contraction, feel for the lie of the second baby. Sometimes they turn. ये नहीं कि आप वेट कर रहे हो तो वहाँ हैंड आ रहा है आपको पता नहीं है. So feel for the lie, feel for the heart, look at the contraction. If required, most often it will be required, start an oxytocin drip for the second fetus. Most often important because you need it in the third stage. And then do the rupture of membranes when the head descends into pelvis. Right? That myth is wrong, that within 10 minutes or 15 minutes you have to deliver the baby like we were taught. That's wrong. If you have monitoring the baby, you can easily give time. Maybe an hour. There's no time limit for that. And if after a long time she's not there, there must be some reason which you're missing. It could be brow, it could be face, it could be anything, So reassess your person, but see that the fetal heart is all right and contractions are adequate. Now, ma'am was asking you the third stage. I interrupted.
Management of third stage.
Yeah.
Ma'am, we will give her oxytocin. We will
active management of third stage of labor, isn't it? I'm still in this more energetic rather.
More energetic. And even the RCOG recommends if besides twin, one more high risk factor is present, let's say hypertension, then you can take an additional oxytocin.
Yes.
VPH is very common and you should not waste time on the PPH. Correct? Now, anything in the dichorionic management you've not understood, normal one? You want to ask any question or the audience wants to ask any question?
One more thing I just wanted to ask
Sure,
is,
sure.
there is an ideal interval between the between the deliveries of the twins. So first has delivered, and there is again 15 minutes, 20 minutes. How long you will keep this?
Ma'am,
You just-
as long as the fetal heart is reassuring, we can wait.
Then you have to just look at the ultrasound also.
Yes, yes.
Intrapartum
Yes,
ultrasound.
with
Sometimes
the
the
lie
light changes, as Madam
Yes,
was
ma'am.
talking.
Yeah.
Lie also changes, and then it becomes difficult. If it becomes transverse, then there will be again difficulties. So you have to again assess, do an intrapartum ultrasound, and look at the expected weight and all those things. No? So what is the safer interval which is cited is less than 30 minutes.
Yeah. Most often they deliver within 30 minutes. Now, is
And
there
I
any
have to
reason that
again-
at second stage you'll need, first twin has delivered and you have to rush to an immediate cesarean? What can be the scenarios? One baby is delivered, and what can be the scenario that your boss says, "Abhi chale jao cesarean mein." What is it?
Immediate shift
Ma'am,
karo.
there can be cord prolapse, there can be abruptio, there
Yes.
could be any sudden fetal distress,
Yes, this all and right, abnormal presentation, transfer.
and the lie has changed.
Okay, so you may not be able to turn at that particular time. That's okay. Third stage we done. Anything else we left? I think we covered all. Now
Yeah.
your case.
Anybody has done internal podalic version? Earlier we used to answer about
I
this
know, now-
because if it now only
Ma'am, I've
information here.
seen it do. Someone had done it in front of me, but I haven't personally done it.
Yeah,
I
not
was on
personally, but
No, I
we
think
have
with
done maybe.
advent,
I
internal
had just
podalic
seen
membranes
it.
have to be ruptured, no?
Ruptured,
Now
and
they
then-
recommend that the
Yes,
membranes are intact, ultrasound guided, you can do an external cephalic. But
Mm.
actually, we lost the practice, honestly
Yeah,
speaking.
yes,
We
yes.
lost the practice.
Yeah.
And more premature the twin is, more often the
More
section for
often
that,
is
for the
the-
section for that.
So,
So
but
now your case, having an IUFD of one twin at 28 weeks, and
And
now she has
another.
come to you at about 30 weeks of pregnancy, how will you monitor? This is your case now,
Yeah.
right? बोलो।
Ma'am, in DCDA twin, if there
ये
is
DCDA नहीं, अब
IUFD,
ये आपका केस
ये
है।
आपका केस
Yes,
डिस्कस
हाँ,
करो ना,
हमने कर लिया,
आपका
we
केस।
discussed the DCDA and everything we discussed. Your
Ma'am,
case now, you are the treating consultant or the resident, whatever. तो आप बताओ कैसे manage करो? We still got 10-15 minutes, quick answers. Quick, no?
Ma'am, the patient has been referred to us because she was registered at a local
अरे
maternity
नहीं,
home and
आ
she
गया ना, we
required.
already said
हाँ.
that. Now what will you do?
Yeah.
Now you're the treating
So
person.
now the patient has come to us. We will first get her routine investigation done. Since there is one documented IUFD, we will also like to rule out DIC in her.
So you
So,
get the all right. You do a coagulation profile. बाकी सब हो चुका है ना उसका. Right.
हाँ.
What will you counsel the patient?
We
come
will
to you,
counsel.
she asked, yeah, this is very important. What is the risk to my baby now? What I'm carrying? I didn't even realize. I still feel both the babies are moving. That's what she told you in the history, right? So what will you
Yes,
tell
sir.
her now?
So I would tell her that since yours is a DCDA twin, the twin of the one twin demise will not have that much effect on the
Right.
second twin. The second twin can grow healthy. We will keep the second twin under monitoring, and the risk that you have is developing DIC and preterm labor, which we would be monitoring you for. And secondly, we will treat the live twin with the same frequency that we were looking. Like we go for a weekly ultrasound for the live twin. So, and with Dopplers to rule out any
So rightly
yeah.
so, you tell the patient that there's a small risk, manageable, but for that small risk of DIC or whatever, we are not going to put the life of this baby in danger. Your baby is premature. These are the risks. You need increased monitoring. So report anytime you are bleeding, leaking, pain, fever. These are few things, and you do a weekly surveillance on her and look at the growth, the Dopplers, and everything. Then what happens? How frequently you do the coagulation? What is the risk? How long can you wait? You are 30 weeks now, and death occurred at about 28, 29 weeks. How much can you wait?
Ma'am, studies say we can wait up to 6 to 12 weeks
Yes.
in one single IUFD in a dichorionic
Right.
pregnancy.
Mono is separate. Mono में भी आते हैं. So monitoring there, you can just watch this baby guide thing, watch for hypertension, watch for fever, watch for, other symptoms, leaking, bleeding, anything. And then you can take her to term, which is 37, 36 weeks, 37 weeks. You already said they can be delivered between 37 and 37.6. So you can deliver at a 37 weeks. Now, how will you deliver this one? The presenting twin, you use the term presenting as the lower twin, upper lower twin is cephalic. And now the weight you reach 36 or 37, your weight is 2.5, 2.4. And the second one, of course, is very small. Would you give her normal delivery?
Yes, ma'am. We can
should give her
give
normal
her the
delivery.
option of induction of labor.
You'll deliver normally, methods we have discussed. If the other way around, the lower twin was dead, what will you do?
Ma'am, if it's valid, we could do an induction of labor for that also. If it's a
That
valid.
also you. Lower twin तो dead है ना, तो उसमें cephalic और उसका तो मतलब ही नहीं है ना.
मतलब ही नहीं है.
It's going to be a difficult normal delivery. This fetus is already crumpled. So when you induce, it's going to be a long, like any trimester abortion, which may not be okay for the baby. So in fact, the lower twin, the dead fetus is presenting it and the cervix is uncompliant. You have very good reason to do a cesarean for her. Right?
Yes, ma'am.
Now come to your monochorionic. Tell me what is TAPS, TOPS, and TTS.
Tops. Yeah.
TAPS. How do you define? Start with TOPS.
TOPS is twin oligopolyhydramnios syndrome, ma'am, where there is a superficial anastomosis of the two babies, and there will.
My question was not the
arteriovenous-
pathology that you'll answer
Yes,
in your
ma'am.
query. My question is, you are seeing the patient. How will you say it is TOPS? You come to monochorionic. Na? TTS is
Yes,
the
ma'am.
cause. We're not asking you the cause, but I'm asking you, what is an oligopoly sequence? Twin oligopoly sequence, that's called as TOPS. Define
Ma'am,
करना, right?
Yes, ma'am.
If in a monochorionic twins, we are seeing
Mono ही तो हो रहा है ना ये oligopoly mono ही हो रहा है ना. It's not di.
on ultrasound, if we see there is oligohydramnios in one and polyhydramnios in
What
another.
is that? I'm asking you. I'm asking you, how do you define? बात समझ गए ना? Oligopoly तो हमने भी कह दिया ना. तो
The values, what are you going to see in the
Yes.
ultrasound to define it?
One single vertical pocket in one baby will be more than 5 centimeters, ma'am, and the other, which is oligo, will be less than 2 centimeters, ma'am.
Less than 2 is right, more than 5 is not
More
right. 7
than
hota hai. And 8 or even 10 you can take in the later pregnancy. Or there's a difference between the two,
Yes,
of more
ma'am.
than 4 or 5 centimeter difference between the two. That is oligopoly. So what will you
Then
do in that?
how you will manage these tops?
Yes.
Ma'am, first of all, if we see any oligopoly sequence, we will keep her on strict monitoring along with NST, BPB, and twice weekly ultrasound. Then, according to Kuntaro classification, we will look
No,
for
we are
any
not asking
accents.
this one classification. I am asking you how you are going to manage. What is the role of
Who
amnioreduction?
will manage and how you will do it? Who will manage this patient and how they
Yeah.
will manage?
So what is the role of amnioreduction? In which patient you will do that? And how you will do that? Any
Doctor?
ablations, anything?
Ma'am,
Dr. Kintu
if
is
we
very
have,
prompt with the answers.
Say, one person continuously she will, whatever questions we are asking, all answers are ready in the chat box.
Chat box में पढ़ रहे हैं.
Ah,
Oh, it
are in
is
the
already
chat box.
written. I did not see that. I didn't see the chat box. Very good.
Yeah, chat box में हाँ देखो सभी everybody is answering in the chat box. Very good.
ma'am, in
That's nice.
oligopoly sequence, we will monitor the patient for any.
See, it depends on at what age you got, gestational age you got, oligopoly.
You answer systematically so that you will come to some, as madam was
If you've
telling.
gotten it very early, then this will not work. It will only work in the later reduction or even the septostomy, just cutting the membrane so that the lichens share, but that doesn't change the pathology. So suppose you're already 32, 34 weeks oligopoly, monitor both the babies and you can be delivering them also. Right now, you're now going to go for laser coagulation now, right? Somebody has written laser in the chat box. But if it is in the later part, that's easier. It's the earlier part, then you have to go look at the pathology. That is all about it. And if you have a TAPS, anemia, polycythemia, how do you define that? One line answer. Abhi aa jayega chat box mein.
Chat box में आ जाएगा.
Ma'am, it's defined as when the MCA PSV is more than 1.5 moms in one
Right.
and less than
Which one is that? One per with the one anemic fetus.
That is the
Anemic
anemic fetus. And the less than 1 moms in the polycythemic 0.5. There basically there should be a difference of 1.7 moms.
Centimeter. Yes. So what you'll do in this fetus? Very difficult. Advanced pregnancy, hai na? Earlier, everybody's doing laser, they're experts, hai na? So now what will you do? She's, let's say, 33 weeks, anemia, polycythemia.
Ma'am, we plan to deliver her if she's like 33 weeks or so, because laser photocoagulation also of the.
See here, both fetuses are dangerous. One dies of starvation, one dies of overfeeding. So it's very difficult to monitor these patients, you know. So the anemic one needs a transfusion, the polycythemia needs a reduction. It's very difficult. So timely le jaake delivery karna. Coagulation at this point of time may not be possible. 33, 34 weeks, you can consider delivery also. And now comes your TTTS quintro classification, which you have read, right?
Yes.
Just another theoretical question regarding your this thing, laser coagulation. What is the method that is applied here? What is it called?
Yes.
How do you do it? Technique.
Septostomy is just putting a hole in the. I'm not technique.
So Solomon's, yeah, somebody.
Yes,
Solomon.
Was Solomon a fish? No, which is like this. So multiple cuts. You do it.
So equatorial. You have to get.
You just cut the thing and sort of. Okay, and now we have dealt with death. And what else we wanted to ask her? One question.
Now TTS
yes. How will you counsel regarding neurological damage of a single of one fetal death in a diet fetus like yours and in a monofetus? One baby dies. How will you counsel her and monitor neurological damage and when?
Ma'am, in dichorionic, there is very less chances, like 1 to 2% of neurological damage in the other fetus.
2% the fetal death occurs in die and 5% is the maximum.
And in monochorionic, it's as high as 25%.
Yes.
So since ours was a dichorionic, we will counsel the patient that the neurological damage in the other twin is relatively very, very low. So, and that too, it happens after 6 to 8 weeks. So we, if the patient is conscious, so after 6 to 8 weeks, we can have the fetal MRI of the surviving twin.
Later than that, you can do MRI for the chances of damage. But what happens in a monochorionic when one fetus dies and they come to you immediately, doing a delivery for the other fetus doesn't prevent the damage. It occurs, it has occurred because water shedding mechanism. So that is the problem. In diet is easy, in mono, it is not easy. Now, suppose your fetus had one anomaly at 20 weeks and one fetus is normal. Anomaly which is incompatible with life. What will you do?
Yes.
Ma'am, as it is a lethal or fatal anomaly.
I said incompatible with life is supposed to be lethal. I did say incompatible with life.
After we have to counsel the patient, and after counseling, we'll give them the options available. If they are wishing to continue the pregnancy or not, and if they continue the pregnancy, if they want, we can introduce fetoscopic laser ablation, ma'am. For that, if any abnormality is lethal with the life, or we can also do
So fetal reduction will do by depending on the gestation and the method. Or,
Yes, ma'am.
yeah, but explaining them that
condition?
whatever method you use, there's a risk of a premature
Risk to the
labor
other twin,
to the other twin.
miscarriages and
That
spontaneous.
clarity should be given to them.
Mm.
So if the anomaly is lethal and it's not going to survive, they have the option of continuing pregnancy unless they have something like a polyamnios where she's uncomfortable. है ना? She has an encephaly, she has a big thing, it's going to be uncomfortable, then you think of those things. But if the anomaly is something which is not a complex heart or anything like that, so she can deliver both the fetuses. She'll have a neonatal death or an IUD by itself, So this is what we wanted to say, one fetal anomaly.
Just one question regarding the fetal reduction. What are the cases where you're not going to use KCL intracardiac?
Yes.
Ma'am, in monochorionics, we avoid KCL. We will rather go for clipping of the umbilical cord.
Yeah, radio frequency ablation can be done.
The reason being that it can cross over to the other side because of the vascular anastomosis.
Yes, ma'am.
What are the malformation which are very common in multiple gestation? Which are the malformations?
Ma'am, are you asking about the congenital anomalies?
In the twins.
In the twins.
Cardiac anomalies are relatively more common. And even
cardiac anomaly, fetal amenorrhoea, then conjoined twins itself is a congenital. Yeah. How you diagnose conjoined twins? I think madam has asked, I think, in some.
No, I have not asked conjoined. You have not reached conjoined.
Yeah.
You're just almost going to finish. So, bolo.
Mama,
it's a mode of delivery if you are diagnosed conjoined twins.
The fertilization timing and when conjoined twins occur, every book has that. Go and read it up if you're not reading.
Yeah. We are
How
not
will you manage? Yeah. Yeah. You can't deliver a conjoined normally. No?
Yes,
so, and suppose a conjoined twin, what are the precautions in cesarean you're delivering them? It's very, very rare. You may not encounter one case in life,
but sometimes.
Yeah.
We would have to give a liberal incision in during LSS, even for skin and even for the uterine
incision. Open abdomen by a vertical incision because it's not formed lower segments. You may give a vertical incision in abdomen, give a nice U-shaped incision in the lower segment rather than getting into the uterine later. If required, you can make it an inverted T or whatever J. The thing is getting this, stuck. But avoid extension of the ankles. And then the PPH. These are the few precautions.
Yes.
Have you left anything, Dr. Meena, Dr. Vidya? I think we covered most of it.
Most of the twin we have. I just wanted to ask you one question. You said 2 doses of Tetrac. What is the vaccinations that we're prescribing in pregnancy these days? Is it TT?
Yes, it is.
Ma'am, it is Tdap vaccine that we are giving in our center. But in government setups, still there are places that they are still giving TT because of the cost issues of Tdap.
I think even government is getting TD. Not Tdap, but TD they are getting. So they can have the benefit of TD rather than just tetanus.
So you're giving 1 dose of TD or 1 of TT and 1 TD? In government, you're giving 1 dose of only TD or 1 TT in the 4th month and then in the 28, 30 weeks? What's the protocol there?
Vidya Di. Dr. Vidya, you're muted.
Yeah. In our side, we give the TD, the second one.
Just single dose?
Single dose.
Single dose. So it's you like Americans, they give single dose of TDAP.
Yeah.
And still they say some TT and but you see that, TDAP should be given because
TDAP should be given.
has become very common these days. So this just covers it up.
In the question answers, some of the questions we have answered. how to manage the twin with concomitant molar pregnancy.
My God, very difficult question. See,
One
molar
question.
pregnancy, it's impossible to say you suck out one mole, the molar, and leave the other twin, you know. So it's just like a partial mole management.
Partial mole
Partial management. I would advise a termination if I get a mole in the first trimester. It's self-diagnosed, most likely. I would advise a termination.
Yes.
I have no other way of removing that, leaving that mole grow and then have all the complications. Anybody wants to say something?
Yes, I agree with this.
Mm.
We also terminate if this comes.
Yeah. Mole
And other question answers, I think we have answered most of them.
What is the classification of TAPs is written in the TDAP is given. Second dose TDAP 1 at thick. Both doses TDAP. Acha. There's a query about this. Should you give one tetanus and one DAPT? Should you give the DPT? What you give? What is the best? This is the big query there now. Please repeat.
One TT and one TDAP, if that we have the choice. Yeah. But in government, I hear that they are not getting TT, they are getting TD. So two TD they
are
giving
two TD. So as of now, we are giving two doses, whether one of tetanus, one of that. That's fine.
Yes. Otherwise, all we have answered, I think, all the questions.
What about how to manage?
Madam, iron and calcium recommendation.
How to manage twins with one having Down syndrome? Same way like you manage them normally. Down syndrome is compatible with life. So here you have a chance of selective reduction. Down syndrome is not incompatible with life. So you can't tell them continue pregnancy and have two babies, one normal, one down. No. So you do a reduction. And reduction is allowed now, even in the late pregnancy by the new MTP law. The medical board can allow termination, and radio frequency ablation of the cord can be done if the cord is thicker. What else?
One I wanted to just bring out is in an early, if one of the fetuses, whether dead or alive, she goes into preterm labor, delivers one, what do you, and then she's not in labor, what do? Would you, continue with the labor, or you can allow her to, the pregnancy to go on?
Answer the question,
Ma'am, has she delivered the
first twin is delivered? Now what? Do we, accelerate and induce and, get the second baby out? Or it's similar to what Dr. Dubey had asked regarding the time duration between the two.
Yeah. So there are so many in literature they have seen, no, after 8 days also delivery. There's so many case reports are also there.
And I think the longest they have said is over a month.
Yeah, 47 days also, has been described. So you see, one twin dies and the other one will go into labor most often. Very rarely, the contractions stop, that is one. The cervix closes, that's two. And you explain to the woman that we can leave it. You have a chance of going to a week, 2 weeks, especially if the pregnancy is 30, 31 weeks. It may make a difference to her. If the cervix closes, contractions stop. These are the two things, which is so unlikely that you can stop. And then you have to cut the cord very close to the cervix, reposit it, put her an antibiotic. She has a great risk of infection. And she will go into labor eventually. That's all. Even suturing has been described cervical, but with caution. And I can see Renuka telling her time is up.
Ma'am, I had one question, last question. If we are, for some of what reason we are doing a cesarean, for the first is cephalic and the second one is breech. So we have, so is there any difference in while we are doing like taking the incision? Because usually when we take the uterine incision, we just like avoid we just separate the bladder and then we take the uterine incision. So is it normal that we go for, because in that incidence also, do we need to take a J-shaped incision or a
no, you don't. No. Babies are in fact chota hai. Both the babies are smaller than a term baby.
Smaller only.
Yes.
In conjoined twins, the diameters, they're bigger. So we cannot separate those and we cannot take one by one. So.
On an average, twin is smaller than a singleton pregnancy. Never seen 3 kilo twins. Very rarely, I would say that.
And same goes for locked twins also. This was a case like if we have a locked twins. So in that case also we go with the same decorum.
Yeah,
that we-
incision doesn't change. You have to define the locking head versus head. You have to define. Head doesn't lock with breech. It's very, very rare. You can push one up and do it. And remember, if the twins are there, lower segment is usually stretched, thin, stretchable, maneuverable. It is not thick, no, in labor at least. So that is that.
And in locked, we can even extend the incision, no, if required.
Yes, you can extend it.
Yeah.
Fine then.
Thank you.
Thank you.
Yes, yes.
Thank you.
Thank you,
Some
ma'am.
of the questions which are not answered, we will be able to answer in the chat box itself.
So good presentation, both of you.
Yes.
Dr. Priti.
Thank you, ma'am.
Thank you, ma'am.
Thank you.
Thank you.
Thank you.
Okay.
Thank you. Thank you.
Thank you.
very
And Dr. Sunita Malik is joined. Hi.
much.
Hi.
Sunita is joined. Hello.
Yeah. Shaloji, what are you going to take? Sunita ji, you are going to take demo on breech delivery.
Demo on breech delivery.
I think we should also learn. We have forgotten now.
Yes, yes. I will learn from her.
No, you
No, when
people
you
have
come
done
to
such a
practice,
good
you're
job.
not going to do a normal delivery breech. That much I can tell you.
So who does this delivery? That's the problem, no?
Yeah.
Yes.
Your case presentation and this discussion was really good.
Thank you. And
Myself
Sunita, I
was absorbed
remember,
with that.
just one second, I remember long ago, we done a debate, what we do in a primary uncomplicated breech, 39 weeks, or full-term primary uncomplicated breech. And I was for cesarean and my opponent was against cesarean. So I sent a survey, this is about 25 years ago, to 30 years ago. I sent it, that time cesareans were not common. I sent a survey to all the, about 100 practicing obstetrician. Same thing, what you do for the patient, what you do for yourself, what you do for relatives. For patient, they said we'll try. For relatives, they said we may. And for themselves, 100% nearly said they'll opt for a cesarean. So I remember that debate, you know.
Yes,
Dr.
yes.
Mukherjee was the decider.
That's right.
That's
That's
right.
what. So my is going to be more theoretical, no, how to do what and when.
Breech. No, we need to know it. even in cesarean, the art of breech remains. You cannot just pull out because you have a big incision there.
Exactly.
You have to hold the bucket, you have to rotate, you have to unlock the arms and deliver the head the same.
Yeah.
So this is what I want. Chalo, we'll enjoy your class.
Hello.
Thank you.
Hi and bye.
Thank you, Dr. Gujral.
Nice to see you.
Thank you, all the chairpersons. And I welcome Dr. Sunita Malik for the next session. She will be talking, she will give a demonstration on breech delivery. Dr. Sunita is a professor at ESIC Medical College and Hospital, Faridabad, and former professor and unit head of OBGY at VMMC and Safdarjung Hospital, Delhi. Welcome, ma'am.
Thank you, Dr. Renuka, and thank you, Dr. Mala and Dr. Kamal for inviting me over. With the warning of severe winter outside and my throat, which is troubling me. So I'm just going to breech presentation. We know it is what? This is what? Breech presentation, where the buttocks or the legs are the presenting part. Can you see my slides? I'm sorry, can you see my slides?
Yes, ma'am. Please show your slide in full screen mode. Yeah. Okay, perfect.
Yes, ma'am.
Thank you.
Okay, so the presentation is in which the lower side fetus is in longitudinal lie with the buttocks as the lowermost part. And we have different types of breeches. Complete breech, when the legs are flexed and the buttocks are presenting and the feet are at the same level, you know, a little. So that's what the complete breech is. Frank breech when the legs are extended, mostly in the primigravida. This is mostly in the multigravida. And this is footling presentation, again in a multi or knee presentation. So these are the different types of breech which can occur. Denominator, you know, is always the sacrum. So this is the denominator. So which side it is presenting in relation to the pelvis becomes the position left sacroanterior or right sacroanterior, left sacroposterior, right sacroposterior. So these are the different positions in which it can occur. So why does breech occur otherwise? Most of the times it is in the multigravida, causing uterine relaxation, uterine obliquity, placenta previa, or coronal fundal attachment of placenta, which is occupying the upper part. So the head is accommodated on the side and the breech, the broader part, comes lower down. Or fibroid in a lower segment or other pelvic tumors. pelvis, contracted pelvis. These are the maternal factors. Hydramnios, oligohydramnios, previous breech delivery. Generally, this keeps on increasing. If one breech, 10%, second, third breech, 28% even. Fetal factors, prematurity. At 28 weeks, 24% fetuses are in breech presentation, which rotates once the period of gestation increases. Multiple pregnancy, which we have been discussing, one of the twins may be in breech presentation, hydrocephalus, anencephaly, trisomies, intrauterine death, very long or very short umbilical cord, or extended legs. So these are the factors. So whenever we find a fetus in a breech presentation, we should also look for the underlying etiology also, and then manage before deciding on the mode of delivery. How do we diagnose abdominally, of course, and vaginally? And final confirmation is by X-ray, which we used to do earlier. No, we don't do, just to confirm the breech. Ultrasound, yes. MRI, yes. So these are the two. I don't think I have to go. Yeah, vaginal examination, when we do, one thing is dilatation of cervix is very slow. There's a sausage-shaped chapel bag of 4 waters, and which is likely to rupture prematurely with prolapse of the cord. And when we try to feel the presenting part, we feel the buttocks with the anus in between. Don't confuse with the face. That is the one. Anus has got a grip in a sphincter. And it has got genitalia on one side and sacral spine on the opposite side. Complete breech, feet are felt on the same level as the buttocks. Extended legs, only buttocks are felt. Knee, we know that knee are at a lower level than the buttock. So this is how we see it on ultrasound. So how does spontaneous breech delivery occur before we go on to the actual how to conduct a delivery? These are the 2 trochanters. So this bistrochanteric diameter, which is the one which is going to Aegis, this is about 10 centimeters. Like in a vertex, that is 9.5 biparietal diameter. This is 10 centimeter, but softer. Descent keeps on occurring. There is internal rotation of the breech, more descent, then birth of the buttocks, and then restitution occurs so that it comes to lie in epidiameter. After that, the shoulders and the arms have to be delivered. In shoulders, we have bisacromial diameter, that's 12 centimeter. Descent keeps on occurring, and it will come to rotate in epidiameter again. And first the posterior shoulder, and then the interior shoulder delivers. Restitution, and then the external rotation of shoulders, and then the baby after coming head of the baby. Engagement may occur in suboccipitofrontal diameter or fully flexed. That's the ideal position, 9.5 centimeter. That's suboccipito, bregmatic. Descent, and this continues, and then it is flexion, internal rotation through 1/8 of a cycle, and the birth of head by flexion. So this is the spontaneous breech delivery, and we have to mimic this section in our assisted breech delivery. So how do we manage this? Is till see, I just said that in premature babies the breech may persist, but if it persists beyond 34 weeks, do an ultrasound to exclude other abnormalities, polyhydramnios, placenta previa, or all those factors which I told you. So you have to, at 34 weeks onwards, you have to find out, is there any underlying etiology? Then by 37 completed week, we think of external phallic version. So that's what I thought. Let me read the recommendations by RCOG, latest one. They say, yes, we should always offer them external phallic version unless there is an absolute contraindication. So this is what the version is. From the breech, we rotate and bring the phallic pole down. The contraindication which we have to rule out, previous scar on the uterus, placenta previa, unexplained APH, preeclampsia, multiple pregnancy, any high-risk pregnancy, in fact, elderly primary, FGR, oligo and polyhydramnios. So these should not be there before we think of doing external phallic version. So generally this version is done in a delivery room. she shouldn't be taking anything orally, and we should have arrangement for cesarean section also, because sometimes the cord accidents may occur and we might have to deliver them. That's why we do it at 37 weeks, so that baby is term, at least we can deliver them. Give a tocolytic head down position so that breech is dislodged, disengaged, and before starting we just dislodge it and gently then turn around. And of course, we have halfway through, we have to listen to the fetal heart or CTG, whatever is available with you, and then the final. And if there is some problem, then we might have to revert also. Generally, once the version is successful, it stays. But if it is liquor is too much or any other problems are there, then it may revert. So it's a unstable sort of like that we can do later on also. The problems are placental abruption, prom, cord accidents, hemorrhage, and bradycardia. Okay, this is what is the procedure. Mobilize, disengage the breech, manually bring forward, try to keep the fetus in the flex position. That's important. Complete the forward roll and then little backward and make it stable. That's what it is. Okay, now coming on to the types of delivery. As already said by Dr. Kamal, cesarean delivery, following so many trials and, all this is what for breech, cesarean is the first line. But even in cesarean, we have to deliver the breech according to the principles of breech delivery. So we have to know the art of breech delivery. Spontaneous delivery, where we are not giving any support to the fetus, to the mother, and baby delivers on its own, like in a cephalic version, cephalic presentation. Assisted breech delivery means we are doing partly spontaneous and partly assistance. And assistance starts after the umbilicus is born. After that, we start assisting in the shoulders or in the head. So this is assisted breech delivery. Total breech extraction is when everything is done by obstetrician and the mother or the fetus. So that's what, and this is generally done under general anesthesia. So that obstetrician has to deliver the whole baby on its own without any support from the mother. So this question, should we do cesarean section for all breech presentation? Well, it has been seen that planned cesarean section leads to small reduction in perinatal mortality compared with the planned breech delivery vaginal, but it needs to be balanced against the potential adverse consequences that may result from this. This is grade A recommendation. Tell them about the risk of perinatal mortality, 0.5 per 1,000 with cesarean, 2 per 1,000 with planned vaginal birth, and compared to the 1 per 1,000 with planned cephalic birth. So this is, their data. So it all depends on the expertise of the person who's doing delivery. So it's good. The vaginal birth is safe, but of course, if you know how to conduct this delivery. So we need to have skilled intrapartum care. Then only we can think of doing vaginal birth. And then it's as safe as planned cephalic birth. And it has also been shown that it does change the low Apgar score and serious short-term complication, but long-term morbidity is not, risk is not decreased by cesarean section. Another thing is that if she opts for vaginal delivery and due to any reason we have to do cesarean section in emergency, then our complication rate increases by 40% in women who had planned for vaginal breech birth if we have to intervene in between. So that is also should be kept in mind. And so tell them all the risk and the pros and cons and then decide. So as such, where we should do a cesarean breech delivery, very big fetus, any degree of contracted pelvis determined clinically, no need of doing radiological pelvimetry. And when we don't do induction of labor also with breech presentation, it has to be spontaneous labor or uterine dysfunction. If somebody has uterine dysfunction, don't persist with vaginal delivery. Go for cesarean. Hyperextended head. This is another important thing which we should be seeing on ultrasound. If the baby is hyperextending or stargazing appearance, one should not attempt vaginal delivery because chances of spinal cord transaction are there and baby will die during delivery. Weight more than 3.8 kg, low estimate or less than 10 centile, incomplete or footling presentation, or some other antenatal complication in the mother or the fetus. We generally don't like to do vaginal delivery. So we have to assess before we select for vaginal birth, know how to do it. Our criteria I've already told you. So that's the same. There used to be a score, although we hardly use it now, but just for your sake, I have put it in the table form here. That is scoring we used to ask. We were asked in our exams. It all depends on it has 0, 1, and 2 points. The parity, the gestational age, is estimated fetal weight, previous breech, dilatation, and station above -3, -2, below or at -1. And if the score is less than 4, even in emergency, she is coming in labor. So this score is only when she comes in labor. You had opted for vaginal delivery, but yes, then score is less than 4, you can still go for cesarean section. Okay, so we will inform her the benefits and risk. Now coming on to the assisted breech delivery. What to do? It should take place in a hospital with facilities for emergency cesarean section. This is a must. Labor induction may be considered, maybe. It's very, very rare. Generally, we don't like to do any IOL. Augmentation, we don't recommend at all. If there is a slow progress, that means there may be some degree of feto-pelvic disproportion. So better to opt for cesarean section even now, even during intrapartum management, intrapartum period. Epidural anesthesia should not be routinely advised, but if she wants to have, so she has a choice of analgesia during breech, labor, and birth, so may augment. But yes, it has been said, if due to epidural, there is some hypotonic contraction, we may augment, but not otherwise. So she wants an epidural. Continuous fetal monitoring has been advised in these cases. With breech presentation, blood sampling from buttock is not visible. So cesarean section is not that we cannot do it. We can do even in any time in the breech delivery, even in the second stage of labor, we may have to do. Again, the problem and the morbidity increases. Passive second stage up to 90 minutes is acceptable, but once she starts bearing down and no descent for 30 to 60 minutes, do cesarean section. Episiotomy should be performed when indicated to facilitate the delivery. So I'll be showing this video at the end. So what to do? Lithotomy position, bring the patient to the edge of the bed. This is very important, edge of bed. Episiotomy, whenever indicated, allow to bear down till the buttocks and the legs are delivered up to the umbilicus. So this part is no touch till the umbilicus is delivered. So that's very important. Don't be in a hurry that you've seen the buttocks coming out. Wait, have some patience, and just wrap the part in a warm towel. Push the cord on one side to minimize traction or compression. So if it is extended legs, then we deliver them by putting a pressure on the popliteal fossa and slightly abducting it. So what happens as we do that, this legs falls down on your fingers, and then you can take it out one by one. Then hold the baby in a femoro-pelvic grip. That's very important. Fingers on the fetal pelvis. These are the fingers on the fetal pelvis, lower one, and thumbs on the sacral-like joint. Don't hold it here, because with pressure or your panic, you might press and there may be chances of visceral injury. Another basic principle is don't try to pull the breech. It is only push from above by maternal effort, or some assistant may help. Only no pulling. Pulling may dislodge the arms or the shoulders, or other problems may occur. So we don't pull that. and try to keep the back interior. That's another principle which should be kept while we are delivering the vaginally. So once we have the umbilicus is delivered, we rotate the trunk so that the shoulders occupy the epidiameter of the pelvis. See, this is difficult to show like this. I show it in the video. So this is what the shoulder have to occupy the epidiameter of the inlet. Then try to feel the lower angle of the scapula and the inner border. If don't see that lower edge of scapula, then only you intervene for the shoulder and the arms delivery, and then feel for the inner border of the scapula both sides. If it is parallel, that means the arms are flexed, then you can just deliver the shoulders first, the posterior, since there's more space, then the interior, or whatever is accessible first, you can deliver the arms by that. But if the inner border of the scapula is divergent, like an extended arm or a nuchal displacement, so then we have to do a love sit maneuver. So what is love sit maneuver? Is principle is that when the interior shoulder is above the, so this is like this, interior shoulder is above the symphysis pubis, the posterior shoulder will be lying below the sacral promontory. It's a little lower level because of the pelvic's obliquity. So when we feel that we are not, the arms are abducted or like this, and this one will be at a lower point than this one, interior shoulder. So what we have to do is we have to rotate the trunk to interior with downward traction so that the through 180 degree, so that the posterior shoulder reaches below the symphysis pubis, and then we deliver that interior arm. Then we rotate it back again, keeping the back uppermost. So your principle is to keep this back uppermost. Rotate it back by 180 degrees so that original anterior shoulder comes back below the symphysis pubis, and then deliver it. So this is the basic principle of left sit maneuver. For after coming head, Burns-Marshall method, forceps delivery, or jaw flexion and shoulder traction, are also known as Mauritius Meliwit technique. All three discovered it separately, and now that has been clubbed by this for the same technique. So these are the three, and in this, according to RCOG, Burns-Marshall term is not done because more chances of having hyperextension of the head and chances of spinal cord injury. But if the baby, when you were delivering, if the nape of the neck has come down, the nape of the neck has come down below the symphysis pubis, then this is the time to deliver by Burns-Marshall. So what, according to this, is let the baby, allow the baby to hang by its own weight. When the nape of neck is visible under the pubic arch, baby is grasped by the ankles and maintaining a steady traction and forming a wide arc of a circle, swing the baby up towards maternal abdomen. Head is delivered by flexion. So this is what it is. The baby, the head is on the edge of the table. You hold it between the ankles, and with the suprapubic pressure by the assistant, you have to just take it up in an arc form. This is what the technique is. And so that's what they say. No, if you are, the head or nape of the neck is not visible, please don't attempt this Burns-Marshall technique. Then there are chances of having injury here, spinal transection. So second is Mauritius Meliwit maneuver technique. In this, what we do is the fetal head is in the flex position. We have to, because it's a little high up, nape of neck is not visible. So what we do is we place the index and the middle finger over the maxillary prominence on either side of the nose, and the other two fingers on the shoulder and the fetal neck to grasp. So these two fingers here, and this one is against the scalp. So this is how this position is there. These two fingers on the shoulder, this splints the neck. So that's what. And the other side, I have already shown, the other hand is like this. So with the assistance given by the assistance who's putting a pressure in the suprapubic region and as well as supporting the perineum. So these two, so both the obstetrician and the assistant are busy with both the hands. And then we try to pull it downward traction, and we try to pull it till the subocciput appears under the symphysis pubis. So that suprapubic pressure with this finger, which is on the back, this is the one, the middle finger of the right hand. This is the one which keeps the head flexed with suprapubic pressure. Okay, so this is the one. These two are on the shoulders and the middle finger. So, and then since the baby is on your arms, so we deliver it towards the maternal abdomen. The third, of course, some people prefer this, especially in preterm babies, they prefer this Piper forceps. It's a long forceps without any pelvic grip. This is generally they say that sudden decompression of the fetal head is avoided if we use forceps, and some people have a first choice of forceps only. So if you're good in that, so this is the better technique. And assistance is needed to hold the infant while the operator applies the forceps from below. So it has to be from below, not from above, like we do in cephalic presentation. This is fetus is kept up, and from below we put in one blade and then the other blade. So this is how we go about. This is one of my postgraduate students who so these are the two blades applied with the perineal pressure and the baby held up. So that's what we do with it. This is forceps application, and the application is the same as in vertex presentation. Mentobregment, that this is how it should be, totally covering it. Now, less chances of spinal cord injury and others. So that's what it is. With this another thing you see, suprapubic pressure. This is very important. It gives a flexion to the baby, the fetal head, because we have to deliver by flexion only. So flexion is maintained, pull directly on head, not through spinal column, avoid sudden decompression, and the baby can take inspiratory efforts also when we are applying the forceps, because there is a space in between. Now, if you are ready with everything, but still the aftercoming head is entrapped. So generally what happens, entrapped aftercoming head of breech is when the head fails to descend into the pelvis after shoulders have been delivered. Now, another thing is timing. So as soon as the umbilicus is born, we have to time it. Allow duration of time up to 5 minutes, ideal to 10 minutes to prevent cerebral asphyxia. Don't delay it and don't panic also. If you panic and start delivering fast within 3 minutes, you're likely to injure the baby more. So keep your calm and let it have smooth delivery and intervene only where required, in the shoulders or in the head. And in fact, Arul Kumaran, as long as back 1997 said, first is spontaneous delivery with the contractions, spontaneous delivery of hip in one contraction, assisted delivery of rest of trunk and head in the next contraction. The other is assisted delivery to the shoulders in one contraction and next head with another contraction. It has got a better Apgar score. So you can either see according to the contractions at what interval they are coming, and then deliver first the umbilicus is born, then the shoulders one contraction, next head in next contraction. So that's what they say, that timing becomes around 5 to 10 minutes only. So this is entrapped aftercoming head. See, the nape of the neck is not visible, and baby, the mother is not on the edge of table. That is another thing. So you have to bring the mother on the edge of table. So first, the thing is what is the cause of entrapped head? So this is the most dreaded part for the obstetrician, the entrapping of aftercoming head. So what to do? Generally, it occurs in preterm fetus and in 8.5% of vaginal breech delivery. Cause could be incompletely dilated cervix, molding didn't occur properly, hydrocephalus, deflexed head, contracted pelvis, locked twin, uterine constriction ring. So in these cases, contracted pelvis, locked twins, we have to sacrifice the locked twin. Already discussed, we might have to sacrifice that particular twin. So try to find out why did the entrapment occur. Incompletely dilated cervix with gentle traction on the fetal body, especially in a preterm fetus, cervix may be slipped over the occiput. If we are able to do that, we might give IV nitroglycerin 100 microgram also. Flex the head abdominally and insert a finger vaginal hand in mouth to flex. Generally, we avoid this because it may cause dislocation of the lower jaw, mandible. Duration incision given at 4 o'clock or 8 o'clock position of the cervix, might have to resort to this also to deliver if it is due to incompletely dilated cervix. This is how we give the incisions. Hydrocephalus cesarean section should have this should have been diagnosed beforehand. With nowadays with ultrasound and all those, this should not be at the second stage entrapped head that we are diagnosing hydrocephalus. Then it's very difficult. Of course, unbooked, unknown case, sometimes they do come like this. So what we have to do is once the head is entrapped, just check suprapubically for the size of the head. If it is too big a size of hydrocephalus, then we can't do anything but cephalocentesis and vaginal delivery. But generally it results in fetal demise. So this needle can be put through the spinal column or from the side, or we can do craniotomy also from the sides. Now, if due to any reason, back is posterior, what to do? So far, I've been telling you, try to keep the back interior, but it has happened and the back is posterior, head is to be delivered. So then we have some maneuvers. Prague maneuver, in this case, we hold the baby with again suprapubic pressure, hold the baby and take it up. So this is opposite of burn marshal. That's what is the Prague maneuver. Delivery of the head when fetal trunk fails to rotate interiorly. 2 fingers of one hand grasp the shoulders from below, while the other hand draws the feet up over the maternal abdomen, and we take it out in an arc. Brecht's maneuver, this is another one. After the arms are delivered, the infant is grasped by the hips and lifted with both hands in a femoro-pelvic grip, and just we pivot it around the symphysis. And having an assistant apply the suprapubic pressure facilitates delivery of the aftercoming head. Another is if the baby the head descends in an oblique way, turn the body of the fetus sideways, apply suprapubic pressure again to flex head, push into pelvis in the occipitotransverse position only, and then try to flex it and deliver. So these are, desperate measures to deliver the baby if this thing happens. This is again Martin method. Moisture smelly we were keeping on the molar eminences. In this case, the middle finger of one hand is in the mouth. Occipitotransverse position. Basic principle in all you must have seen, all the maneuver is the assistant keeps a hand in suprapubic region to help in flexion of the head. This hand of assistant is very important. In fact, what I tell is keep a hand on the fundus. Keep on going as the umbilicus is born. That hand should keep on coming with the uterus. And once the head is there, put it in suprapubic region and try to flex, help there, flex the head. See the femoro-pelvic grip. If there is hyperextension of fetal head, very high risk of cervical spine injury, and it's an indication for cesarean section. This could be one of the reason of entrapped aftercoming head. CPD. Yes, this is another, now that otherwise we call it feto-pelvic disproportion. But if the head is entrapped now, and you think pelvis was not right for this head. It's a, it becomes between head and the pelvis. So we call it CPD now. So one measure is to do symphysiotomy, enlarge the episiotomy, infiltrate lidocaines in interior, superior, and inferior aspect of symphysis pubis, place the index finger in the vagina, apply lateral pressure to the catheter to move the urethra away from the midline, make a vertical stab incision over the surface, press through the cartilage joining the two pubic bones until the blade is felt on the finger. I have never done it so far, symphysiotomy, but yes, I thought I'll tell you the procedure. So this is what happens. The cartilage is cut, the two bones separate, the pubic bones, and the diameter increases, and then head white deliver. But then you have to be super fast. When the head is entrapped, the time is ticking by, you have to be really quick to decide about symphysiotomy, and you think it's only pelvis which is obstructing. This is one of the methods. Locked twin, ideal should have been cesarean section, may decapitate the first twin, deliver the second twin. There's another maneuver, like in shoulder dystocia, it's McRoberts maneuver. Forcible abduction of legs by sharply flexing them on abdomen after removing from stirrups and suprapubic pressure. Suprapubic pressure. This maneuver does not change the actual dimension of maternal pelvis, but straightens the sacrum relative to the lumbar spine. This facilitates delivery of head if arrested at the inlet, and MSV, that Moshe's Malevite method has failed, might help. Just flexion abduct suddenly, and then it might increase some, straighten the axis, and the head may come out. So this is one of the maneuvers which can be done. Other positional changes, upright. So this is also written that upright position, if the patient wants so, with hips abducted, increases the outlet measurement of pelvis. But then the obstetrician should also be able to do the delivery in upright position of the patient. Forward tilting of the pelvis slides the innominate bones forward and down to increase the AP diameter of inlet. This effectively puts the baby head into pelvis and rolls it into the posterior surface, or precipitates the action of face sweeping over the perineum. See, 1982, 1998. Nowadays, like Dr. Gujral said, hardly anybody does breech delivery. That's art, but this art you have to know. In cesarean section, you have to be careful again while delivering, especially a preterm fetus with non-formation of lower segment. Uterine relaxant, midline vertical incision may or may not, depending upon how much is the lower segment available. Conversion to any types of incision. Don't think of doing preterm fetus vacuum assisted delivery. Might apply forceps also if we need. So we should be ready with that to avoid injury to the fetal head. There's another maneuver which I came across, Zavanelli maneuver, very brutal. You found that fetus has coming out, so they have to, and you think now the pelvis is not right or some other reason is there, place the fetus into the abdominal cavity and then do cesarean delivery. It has successful result according to Sandberg. This has been written by him in 1999. Very high incidence, of course. You can even think of that, injury and death. Now coming to the last part of this breech delivery, what is total breech extraction? This is when this is done, when one thing is cervix is fully dilated. Then the obstetrician wholly solely has to deliver the baby without any assistance from the mother. And we are not waiting for umbilicus to be born. So it is done under general anesthesia. Generally, when we need immediate delivery, as in fetal distress, cord prolapse, maternal distress, we really need to deliver them fast, or following internal pedalic version in second twin with transverse lie. Mind you, I have done many IPVs long back in my residency and initial years. So then this is not difficult. It can be done. So This is, and then the breech extraction. So that is there under general anesthesia with uterine relaxant. This is very important. Halothen has to tell the anesthetist to relax the uterus. In this case, if it is extended legs, we have to deliver the buttocks by groin traction. Then, or Pinard maneuver. In Pinard maneuver, what we do is we go along the ventral aspects of the legs and then again try to go. If we can reach the feet, it's all right. But if maybe it may be very high up. So then in that case, we have to press against the popliteal fossa again, like we did in extended legs otherwise also, and then we deliver. Shoulders are by Lovset maneuver and head is by Marshall's maneuver. I think I have almost done all the maneuvers. Complications. Now, what can happen if we are not careful? More chances of genital tract laceration, tears. If we are doing some intrauterine maneuvers, especially with a thin lower uterine segment, yes, it may cause injury or rupture also, especially in breech extraction after IPVs, if one is not really careful. Delivery of after coming head through incompletely dilated cervix may lead to rupture uterus, especially if your incisions are, you are given recent incisions and if they were extended. So one should be ready for that. Cervix or vagina may also be lacerated. Extension of episiotomy if the perineal support is not right, or otherwise deep perineal tears. So another problem is you've asked for relaxant anesthesia for total breech extraction, then they have to stop that relaxation immediately after delivery so that atoning does not occur and PPH doesn't occur. Manual manipulation within the birth canal increases the risk of infection. So risk and benefit of breech delivery for term fetus: risk, of course, poor APGAR, intracranial hemorrhage, medullary coning, severance of spinal cord, brachial plexus injury, occipital diastasis, fracture of long bones. If we are, the clavicle fracture, the long bones, the femur, if one is not careful, visceral injury, epiphyseal separation, these can occur to the fetus. Rupture of internal organs, long-term neurologic damage, genital damage in male, especially while diagnosing the breech presentation, hypopituitarism, damage to mouth and pharynx if the finger is in the mouth. Benefits, of course, reduction in idiopathic pulmonary hypertension, asthma, arthritis, like in all vaginal delivery. Cesarean section, we know sepsis, increased pyrexia, need for blood transfusion, increased mortality rate, decrease in future fertility, placenta accretas, difficult birth experience, subsequent pregnancy with a scar on the uterus. These are risks always there with any cesarean, whether it be for breech or any other indication. So that's what we have to advise them. They should be advised that planned cesarean carries a small risk as compared to vaginal birth. So this is just a summary of what I had talked. Long-term health is not compromised. Long-term effects of planned cesarean for term breech presentation and future outcomes for them and their babies is uncertain. But since nowadays are, two babies, the people opt for elective cesarean even for cephalic presentation, so breech is next in any case. To conclude, since the incidence of cesarean section for breech presentation is increasing, vaginal breech birth may become extinct. It's already become extinct due to lack of experienced clinician teaching next generation. To perpetuate the art of vaginal delivery, learning in a simulated pelvic model in a non-threatening environment is recommended for you people. Thank you very much. Any questions if you want to ask?
There's one question in chat box, ma'am. Perineal support is needed in Burn Marshall method or not?
Which support? I'm sorry?
Perineal support.
Perineal support. Yes, of course. We are bringing out the head, we need perineal support. So that assistant, one suprapubic pressure and one in the perineum. So ऐसे करके दोनों काम करने हैं उसको.
And Like why decrease in fertility? I don't know.
That is previous cesarean section in any case. With all this. So that's a general risk with the cesarean.
So there were only 2 questions in the chat box. And,
okay.
But we have left with time, and students, if you want to ask any questions, you can put it on the chat box.
We have around 5-7 minutes.
Yes, ma'am.
Yeah, I can, or otherwise the next Dr. Amita is ready. I just saw
Okay.
her doing.
So I don't think they are asking any questions. There's no question in
Basically,
chat
it is
box.
for them to practice. That's the most important thing, to practice on the models. Like a photographs, I didn't put the actual baby and the mother. I put it on that models only. So when they have to practice on that, so that actual baby injury doesn't occur. And if they so what I have seen is panic when the breech comes in labor already 5-6 centimeter. Madam, I said rule out contraindication, go ahead. But वो panic दिमाग में end तक रहता है, वो baby को pull करना शुरू कर देता है. There's some mother have patience while delivering the baby. That's in breech presentation.
Yeah, there's very famous, that the one student had never seen breech delivery. So his friend's father has a nursing home. He says, you come to my nursing home, I'll show you that. So evening they go to nursing home. There is no patient in the nursing home. Then he said, no, just wait. I'll demonstrate breech delivery. Then his father reaches nursing home. He said, now you observe my father. He'll open the car door. The way he comes out of the car, it is how the breech delivers. First he will take out the one leg, then the second leg.
Yes. I think Dr. Amita, you'll have to change the name. The link was different. So you just change your name here.
Sunita Malik is written in your.
Okay, I'll just thank you. Thank you.
Just change your name. That's the thing. Okay. Dr. Saraswati, you want to say something? You are.
Yeah, somebody wants to see the video. You said you will play the video
Oh,
later.
yes. Oh, yeah. I'll share it again. Good. Just share it. Yes. I forgot it. Thank you for reminding me.
Yeah, the student reminded. They are very closely watching.
Yeah, of course. I'll just show that video.
Breech presentation is when podalic pole presents at the pelvic rim. So after confirming the diagnosis of breech presentation per abdominal.
This is 5 minutes actually.
Ma'am, audio
we can't see.
Video
we
is
can't
not
see.
showing, ma'am. Please
we can't
share
see.
your video.
But it is showing it, no?
No, ma'am, there is no video. There is only audio.
Oh my
Audio
God.
is there.
What to do? दोबारा share करूँ?
Yes, ma'am.
Senior obstetrician or senior postgraduate. Call should be sent
Just
for pediatrics.
I think I'll have to stop share and then
first stage
stop
of labor
video.
of breech
This is stop my video.
Where the patient receives supportive care as per
normal. No, ma'am. You have to start your video.
Yeah, I'll do
Click
that.
on share button.
Yeah, I'll share after that. Yes.
Yeah.
That's it.
Breech presentation is when podalic pole presents at the pelvic rim. So after confirming the diagnosis of breech presentation per abdominally, performing the abdominal examination and confirming it by bimanual pelvic examination.
Cannot see.
No, I'm just trying to. I haven't shared it
okay,
yet.
okay.
Not shared. I have to finish actually.
Breech delivery is only to be conducted by senior resident, senior obstetrician, or senior postgraduate. Call should be sent for pediatrics SR prior hand. Breech presentation is when podalic pole presents at the pelvic rim. So after confirming the diagnosis of breech presentation per abdominally, performing the abdominal examination and confirming it by bimanual pelvic examination, ruling out all contraindications.
Can you see it now?
Yes, now. Yes, we can see.
I'll start it from there. Yeah.
Presentation is when podalic pole presents at the pelvic rim. So after confirming the diagnosis of breech presentation per abdominally, performing the abdominal examination and confirming it by bimanual pelvic examination, ruling out all contraindications for breech vaginal delivery, the patient is taken as a candidate for breech vaginal delivery. Breech delivery is only to be conducted by senior resident, senior obstetrician, or senior postgraduate. Call should be sent for pediatrics SR prior hand. The management of first stage of labor of breech is similar to other high-risk pregnancy where the patient receives supportive care as per normal labor. She is kept in left lateral position and we have to avoid premature bearing down. Meconium is common with breech presentation and it is not a sign of fetal distress. ARM should not be done. However, per vaginal examination anesthesia and descent of breech. Once the patient enters the second stage of labor is when we have to assist breech vaginal delivery and that is encouraged. We must ensure the availability of the assistant, clean towel to cover and hold the baby, and a neonatal resuscitation tray. The patient is put in lithotomy position and brought to the edge of the table when breech is distending the perineum, which is called as the climbing of perineum, or the fetal anus is visible. Catheterize the bladder if it is full. Prudental block anesthesia is given along with infiltration of perineum. A generous episiotomy is made. Now first is the delivery of buttocks, which is allowed spontaneously till the umbilicus is visible. If the legs are extended, they are gently manipulated. Gently hold the buttocks by hand, but do not pull.
She's trying to adjust it. She's not pulling it.
If
So that's the
legs do
thing.
not deliver spontaneously, we can deliver one leg at a time. Give a gentle push behind the knee to bend the leg. Grasp the ankle and deliver the foot and leg. Repeat this for the other leg. Do not pull the baby while the legs are being delivered. At this point, umbilical cord is loosened and cut if short. Check for cord pulsations and the length of the umbilical cord. Also note the time to ensure that the delivery is completed in 5 to 7 minutes. Cover the baby with a breech towel and hold at the hip by pelvifemoral grip, keeping back anteriorly. Important is to keep the back anteriorly. Do not hold the baby by the flanks or abdomen that might cause kidney or liver damage. Now delivery of the arms. When lower angle of scapula is visible, the arms are checked in front of the chest. Medial border of the scapula should be parallel to fetal spine. Allow the arms to disengage spontaneously one by one. Assist only if necessary. After spontaneous delivery of the first arm, lift the buttocks towards the mother's abdomen to enable the second arm to deliver spontaneously. If the arm does not spontaneously deliver, place 1 or 2 fingers in the elbow and bend the arm, bringing the hand down over the baby's face. If the baby's body cannot be turned to deliver the arm that is anterior first, deliver the shoulder that is posterior by classical method. Now delivery of the head. Head can be delivered by either MSV technique or the Burns-Marshall technique. Here we are demonstrating the MSV maneuver. Lay the baby face down with the length of its body over your hand and arm. Place the first and third fingers of this hand on the baby's cheekbones and place the second finger in the baby's mouth or at the chin to pull the jaw down and flex the head. Use the other hand to grasp the baby's shoulders. With 2 fingers of this hand, gently flex the baby's head towards the chest while pulling on the jaw to bring the baby's head down until the hairline is visible. Pull gently to deliver the head. We must ask the assistant to push above the mother's pubic bone as the head delivers. This helps to keep the baby's head flexed. Raise the baby still astride the arm until the mouth and nose are free. The baby is handed over to the pediatrician for resuscitation.
Thank you. So this was the small video which I wanted to show you. Thanks for reminding me. I'll stop sharing now. Stop it and then, yeah. Thank you very much.
Thank you, Dr. Sunita ma'am, for giving us your valuable time. The presentation was very informative, crisp, and knowledgeable. Thank you once again.
Thank you.
So moving ahead, in the next session, we will have a case presentation on abnormal uterine bleeding. And to chair the session, I would like to invite Dr. Amita Suneja. She is Senior Consultant and Head of the Department OBGY at GTB Hospital, New Delhi. Dr. S.N. Basu, she is Senior Director, Head of the Department of OBGY at Max Super Specialty Hospital, Shalimar Bagh. Dr. Shashwati Sanyal, she is Professor, Department of OBGY at Guwahati Medical College. She is also President ISOPARB at Assam chapter. I welcome you all and I request Dr. Rishav and Dr. Priti, who are DNB students with us, to start with their presentation. Dr. Rishav and Dr. Priti. Dr. Priti, are you there? Dr. Priti and Dr. Rishav, please start your presentations. Dr. Priti, can you hear me?
Yes, ma'am. Just sharing the slides.
Okay.
Yeah, I think good morning, everybody. Good evening, rather. It's 4 o'clock.
Good evening, ma'am.
Yeah, so I think you complete your history. We'll make the comments. Then after history, experts will ask you a few questions. Then you start the examination after that. Is it okay?
Good. Yeah,
Yes,
yeah,
sir.
absolutely.
Good evening, everybody. I'm Dr. Rishav. I'm going to present a case on the abnormal uterine bleeding. My patient is Mrs. ABC, is a 45 years old homemaker from Karol Bagh, Delhi, and educated up to class 12 and belongs to middle socioeconomic status. According to modified Kuppuswamy scale, is a wife of Mr. BC, who is a 49 years old male. Presented with complaint of heavy menstrual bleeding since last 6 months and pain abdomen since last 6 months and distension of abdomen since last 4 months. My patient was apparently all right 6 months back. Now presented with complaints of heavy menstrual bleeding since last 6 months and as which was associated with pain during menstruation and passage of clots. Her previous history was menstrual history was regular 28-day cycle with 9 to 10 days of. Currently, she is on 28 days regular cycle with 9 to 10 days of flow, and she changes her pads 7 to 8 pads per day. Previously, she used to have 3 to 4 days of flow and used to change 2 to 3 pads per day. And she also complains of pain in lower abdomen, which was insidious in onset, gradually progressive, which was a dragging type and present throughout the day, radiating to back, and no aggravating and relating, which was not associated with any aggravating and relating factors. There is a history of loss of appetite since 4 months and a disturbed sleep cycle due to pain since last 1 month. For with backs, she has consulted a local doctor for heavy menstrual bleeding, where she was prescribed medication for same likely tranexamic acid, and her symptoms subsided temporarily. She has similar episode 2 weeks back, for which she took same medication, but bleeding didn't stop. Hence, consulted at Sargangaram Hospital for further management. There is no history of intermenstrual bleeding and any mass coming out of vagina or discharge per vagina, or any decreased frequency of micturition or burning micturition, or difficulty in passing stool or constipation, or history, or there is no history of weight loss or any fever. She achieved menarche at age of 11 years. Her LMP was on 1st of December 2023. Since 6 months, she is having 28 to 30 days cycle with 9 to 10 days of flow, which requires 5 to 6 times changing of pads per day, which is associated with pain during days of menstruation, and clots are being passed. Previously, her cycle was normal, and it was not associated with any pain or any passage of clots. She is a para 2 leaving 2, Her first child was born 24 years back. She had a female child, which was a female child born at term by normal vaginal delivery at hospital. And birth weight was 2.8 kg. There was no antenatal, perinatal, and postnatal complication. She breastfed for 1 year. Second child was born at 20 years back. She was also a female child, born at term by normal vaginal delivery at hospital, and birth weight was 3 kg. There was also no antenatal, perinatal, and postnatal complication, and she was also breastfed for 1 year. She was postpartum sterilization was done after second delivery by mini lab technique. She's not a case of diabetes mellitus, hypertension, tuberculosis, bronchial asthma, epilepsy, or cardiac disease. There's no surgery is being done other than postpartum sterilization, and she's not allergic to any known substances. Her family history includes her mother is a known case of hypertension and has undergone hysterectomy for mass in the uterus in the past, as per the history given by the patient. Exact cause of hysterectomy was not known to her, and there is no history of diabetes mellitus, tuberculosis in the family. Her personal history includes she is a vegetarian by diet and takes adequate calorie intake. She takes adequate calories. Her appetite is reduced since 4 months, and she has disturbed sleep since last 1 month. She has a regular bowel and bladder habits, and she is not addicted to any substance. Her general physical examination reveals that patient is conscious.
We can stop here for 1 second.
Okay. Okay,
So,
ma'am.
from history, any question you want to ask, Doctor, from them? What is
I just
the
want
I
of
forgot.
the patient. Yeah.
What is the age? Can you say it again?
44 years female. She's a 44 years female. Yes.
Okay. So, from the history, can you make your diagnosis? What is the diagnosis?
She's a 44 years P2 para 2 living 2 female who is sterilized, and since she has belonged to post perimenopausal age group, and she has got a heavy menstrual bleeding since last 6 months, and there is gradual distension of abdomen, and so my differential and there is also so mass felt in according to history, ma'am, this is a case of abnormal uterine bleeding, and which for which for confirmation we need to examine the patient. And
from history, your diagnosis is AUB.
Yes, ma'am.
But what did you say? Did she say distension of the abdomen? You have not elaborated on that particular point.
Gradual distension of abdomen since last 4 months. She has been saying.
You said last 4 months she's not been appetite, loss of appetite. You said.
Yes, and also there is a loss of appetite since last
What does
1
that
month.
indicate from history? The 2 things you have highlighted: distension and loss of appetite. Is there a loss of weight? You did not ask, huh?
Ma'am, there was no loss of appetite. There is no history of loss of appetite and fever when asked for it.
Okay. So, did you ask specifically for lump abdomen? You can ask.
Yes.
Sometimes.
Yes, ma'am.
So, is there a history of lump or not?
Ma'am, she was unaware of when we asked her, she was unaware of her mass abdomen, lump abdomen status. So,
Well, ma'am, she complained to us that she's been feeling heavy down there. She's feeling that the abdomen is distending and it's heavy, like while she has slight discomfort.
That should come in the history. There's a heaviness.
Yes, that's very, very important. Very, very, because it is a cyclical kind of heavy menstrual bleeding, which also tells you something, you can exclude something and you can say something. So this is very, very important. So this is heaviness in the lower abdomen, because from in the history, we could not see that there is something there in the lump. The history should tell us that there is something in the abdomen.
Yes.
Okay. And from history, one thing more you can add. Now there is change in terminology that it is chronic AUV. No?
Yes, ma'am. Since she is suffering from this problem since more than 6 months, so it comes under the criteria of chronic abnormal uterine bleeding.
AUB, but then we have to see what is this lump. Is what it can be. If we see in the lower abdomen, there's a heaviness. What differential?
This can also be any adnexal mass. This can also be a uterine fibroid. This also can be a broad ligament fibroid.
Okay.
Can also be.
So you're suspecting a structural problem, right?
Yes, structural. We are going to see.
So in the group of PAM, PA.
Yes, ma'am.
Okay.
So, Dr. Basu, do you want to ask any question? Okay, I think you carry on with the examination.
Yes.
Sorry, not at this point. You carry on, you ask the question.
Okay. Okay, ma'am.
After taking consent from the patient, we started to examine the patient, and after telling her what I'm going to examine, patient gave the consent, and we saw that patient is conscious, cooperative, and well oriented to time, place, and person, and she is moderately filled and nourished. Her vitals were, her pulse rate was 90 beats per minute, which was of low volume, and showed normal rhythm and rhythm and character. There was no radio or femoral delay. Her BP was 124. Her systolic BP was 124 millimeter of mercury, and diastolic BP was 82 millimeter of mercury, which was taken in sitting position in left arm. And she was febrile. Her temperature was 98.4 degree Fahrenheit, and her respiratory rate was 16 cycle per minute. And her weight was 50 kilogram, and her height was 168 centimeter. BMI was 17.7 kilogram per meter square. She was underweight in category, and there was pallor was present. There was no icterus, cyanosis, clubbing, lymphadenopathy, and edema. And thyroid, breast, and spine examination on thyroid, breast, and spine examination, they appears to be normal. The oral cavity was examined, and teeth were slightly stained. On the systemic examination, cardiovascular examination, first and second heart sound were heard normally. There was no murmur. Respiratory examination, there was a bilateral equal air entry on the both, as well as bilateral normal vesicular breath sound were heard. No added sound were heard. Central nervous system examination, there was no focal neurological deficit, and on GCS score it was 15 out of 15. On per abdominal examination, on inspection, first of all, we ask patient to pass the urine, then ask the patient to lie down and with leg flexed. On inspection, abdomen is slightly distended, appears to be slightly distended, and umbilical is pushed upward and it was inverted. All quadrants move equally with respiration, and there was a tubectomy scar is seen, and which was looking healthy. There was no sinuses and dilated veins, and hernial orifices were intact. On palpation, there was no local rise in temperature. There was no tenderness felt on the superficial palpation. A firm to hard mass was palpable just above the level of umbilicus, corresponding to 20 weeks of gestation. It was nearly 11, approximately 11 into 22 centimeter in size, extended to right and left iliac fossa and umbilical region. Surface was smooth, and it was only transversely mobile. All borders were felt except the lower one, and there was no organomegaly felt on the deep palpation. On percussion over the mass area, the dull note was heard, and there was a resonant note heard all over the other areas. There was no fluid through or shifting dullness which can be elicited. On auscultation, normal sound were heard. On local examination, external genitalia appeared to be normal. On per specular examination, vagina was grossly normal. Cervix showed multiparous os. There was no any abnormal growth, any discharge, or any vascularity.
Move your slide.
Normal.
Kindly move your slide, Mr. Dubey.
Slides are not moving. I think they have a problem of.
Okay. Because your PV findings are not
transmission.
Can you make it?
So,
Is it
is
visible?
it moving, ma'am?
No.
No.
We are still at auscultation.
Internet connection.
Must be having some problem with the net.
Yeah, I think one person can deal with it. Till that point, are you correcting it or we should continue the discussion?
Mr. Alok, are you there?
Yes, ma'am.
Mr. Alok?
I am here. Ma'am.
Dr. Renuka, can you talk to them if necessary, whether they'll be able to join or not?
Otherwise, they can present it on paper, just like that.
Yes, without this thing, they can also say if the only.
Rishav, you can tell us the PSPV examination.
Ma'am, then they have left from Zoom now. Now,
Okay.
then they are trying to connect again.
They're logging again, ma'am.
Yeah.
Okay.
They just log out, they're logging again.
In the meantime, if you any one of you have any questions, you can put in the chat box. Till now, anybody, the participants, if you have any questions, you can put it in the chat box.
Anything you want to ask in history or which should have been asked or in examination?
There is one question in chat box. Do we need to state size of mass in centimeter or can we state size in weeks?
Both ways.
It is, for us because we practice obstetrics, if you express in the duration of pregnancy, the size, it's become immediately visual. You can visualize it, but you have to put it in centimeters as well. But if you say 20-week size uterus, we can immediately visualize how big big is the lump, or 24-week size lump. We can immediately visualize. So that is the one advantage of obstetricians, being an obstetrician.
In history, I will point out, like, he presented it very well. It was almost complete. But when you say blood pressure, there's no need to say systolic separate from the diastolic. Just say 120 by 80. The examiner will understand. He did say systolic is this much, diastolic is this much. So that one point. And I could not see the breast examination. Did he present?
Yes, it was there.
Then instead of saying abdomen is distended, they could have said the lower abdomen is distended.
Yes, the specification. Distension means something, which means that is, the gaseous distension that you see in the post-operative case. But once you see a lump, it is very kind of localized kind of swelling rather. It will go
We
to
can say lower abdomen distended.
right.
Because
Yeah.
post-operative, we find generalized distension.
Distension, yeah.
That. So for all the students, and rest, let's see now what they after PSP.
Okay, we can see them. Welcome back.
Sorry,
Yeah,
ma'am, for the delay.
no
The
problem.
connection.
Doesn't matter, doesn't matter.
Uh, On local examination, external genitalia appeared normal, and on perispecular examination, the vagina was grossly normal. Cervix was seen as a multiparous os. There was no abnormal growth or any discharge or any abnormal vascularity was seen. On pervaginal examination, cervix was pointed upward and forward. Uterus was retroverted, irregular, and it was irregularly enlarged, and which was up to 18 to 20 weeks size. And the mass most laterally with the cervical movements and vice versa. And there was no groove felt in between uterus and the mass, and bilateral fornices were found. And my provisional diagnosis is 45 years, a female with complaint of abdominal distension and heavy menstrual bleeding and painful menstruation since last 4 months, and pain abdomen since last 1 month. On examination is found to have 11 into 22 centimeter abdominal mass, which was transversely lower abdominal mass, which was transversely mobile, and which was formed to hard in consistency with smooth surface corresponding to 20 to 24 weeks of gestation, extended to right and left iliac fossa and umbilical region, with all borders except the lower border field, which is dull on percussion, is suggestive of fibroid uterus. And the differential diagnosis, which can be of adnexal mass
अभी रुक
by
जाओ, अभी रुक जाओ. ये तुमने जो डायग्नोसिस दिया ना, ये केस समरी है. इट इज नॉट ए डायग्नोसिस.
जी मैम. जी मैम.
तो डायग्नोसिस तो एक या दो लाइन का होता है.
जी मैम. She is a 44 years female, P2L2, sterilized, with abnormal uterine bleeding.
आगे कुछ नहीं बोलोगे?
Just AUB.
AUBL, Leo में.
AUBL. It's important to mention size here because it's a huge mass. So you can
Yes,
say
ma'am.
20 weeks or 24 weeks, that you can mention.
Yes, ma'am.
Okay. तो irregularly enlarged है, तो can you make out intramural है, submucosal है, क्या है?
Ma'am, since the mass is irregularly enlarged, so it can be subserosal or intramural fibroid, ma'am.
And intermenstrual bleeding नहीं है, तो
Yes, ma'am.
less like.
Yes, ma'am.
एक
History
चीज
में
तुम्हारी एग्जामिनेशन में जो ठीक नहीं लगी, uterus retroverted. If it is 20 weeks uterus, we can't say it is retroverted. You say uterus is enlarged, it is irregular, it is 22 weeks of gravid uterine size. ठीक है? फिर कैसा है? हाँ.
then she was our differential diagnosis goes towards the since this is an enlarged uterus, since we had differentiated from the history and ruled out the
अभी एक
causes.
मिनट रुक जाओ बेटा, अभी फिर आपने पीआर नहीं किया. पीआर करना चाहिए, नहीं करना चाहिए?
मैम करना चाहिए मैम, ये रूल आउट करने के लिए कि उसमें पैरामीट्रियम फ्री है या फिर सरफेस जो है वो रेक्टम से अटैच्ड है.
Okay, but in this case, PR,
nodular,
it is a
nodular
mass. There can be nodularity in POD.
Yes.
So PR you have missed.
Yes, PR was done. Sorry, ma'am, for not mentioning.
नहीं लिखा.
No, sorry.
Okay. So ठीक है, और diagnosis ठीक से लिखना है.
जी.
Okay.
Can I?
हाँ, बताइए.
No, can I come? Can you go back a couple of slides? No. Here, the next one. You said cervix was upwards and forwards, uterus retroverted, irregularly enlarged.
Yes,
and
sir.
the mass moves laterally with cervical movements. So you
Yes.
meant to say that this mass was continuous with the uterus?
Yes, ma'am.
It was. And when
Yes,
you
ma'am.
say it moved laterally, what
Yes,
about
ma'am.
up and down movements? Does that
Ma'am,
also
it was,
mean something?
yes, ma'am, it was moving up and down. Lateral movement is and up and down movement were present, ma'am. But on abdominal examination, we were not able to go to the up to the down margin. The
Obviously,
lower
you can't.
pole could
If
not
it
be
is
felt.
continuous with the uterus,
Yes, ma'am. But
then you cannot go beyond the
up,
uterus and feel it from the, from the
sidewise
abdominal
movement
side.
and up and down movement with the cervix, it was correlating with it, ma'am.
Can I just ask you one thing? Supposing this was not a fibroid, which you have said it is, it was an ovarian adnexal mass.
Yes,
And
ma'am.
on clinical examination, how would you be able to differentiate that it's more likely to be an adnexal mass?
Ma'am, if if it was an adnexal mass, then we need to see if it's unilateral or bilateral, and on bimanual examination, we could
Yes.
have reached to the lower pole of the lower border of the mass, and it would not have been moving with the lateral movement of the cervix, and now we could, and the groove between, we can reach between the mass as well as the uterus. The finger can be reached, so the groove will be felt between the uterus and the mass. So by clinical examination, by this way we can differentiate
Also,
between.
also an adnexal mass can more easily move up and down rather than the uterus. If you push it and it's moving up, then the cervix also moves up with it. Unless it's an advanced adnexal mass where it's everything is tethered, then in that case you would also probably feel something in the pouch of Douglas,
Yes, ma'am.
isn't it? So it is
Yes.
important to differentiate or try to differentiate. Sometimes it may not be possible, but you can also be misled by a pedunculated subserous fibroid,
Yes,
which can
ma'am.
have a similar finding.
Yes, ma'am.
Okay.
Mhm.
So this
Yes.
is what you have mentioned, the no groove felt between the uterus and the mass.
Yes.
And
And what is the consistency of the
yes,
mass?
yes.
What is the consistency?
Ma'am, the mass was soft to firm in consistency when it was touched, ma'am.
Soft. Are you sure?
Ma'am, firm, sorry, ma'am, firm to hard. The
Oh,
uterus.
बहुत
can it be
फर्क आ गया
soft?
बेटा because
मैम
ऐसे ही
सॉफ्ट
soft
एडनेक्सल मास में आ सकता है डिफरेंशियल.
बिल्कुल बिल्कुल
हाँ, और यहाँ पे 1820 है, तुमने फाइनल डायग्नोसिस में 24 you have written. So what is
मैम that was ma'am a gross mistake on my part while preparing the.
कोई बात नहीं, then you're
कोई
not
बात
wearing
Sorry.
कोई बात
this.
So what is
Consistency is
it? It is
important.
1820 or 24?
मैम 18 to 20 weeks का था मैम.
Okay.
18 to 20 weeks per abdominally.
Yes मैम.
Even on PV?
मैम पीवी में इलाज था मैम, बाई मैनुअल जो हम लोग कर रहे थे तो इलाज था इरेगुलरली ऐसे बोल सकते थे, और पेल्विक रीजन के ऊपर गया था, एब्डोमिनल में फील हो रहा था मैम वो.
You said umbilicus is inverted, right? Or inverted?
Inverted मैम.
Okay, okay. Then it is fine. It can be 18 to 20 weeks, right?
So I
How
think
do you
एक
explain
चीज
that?
जरूर sorry no carry on You
Pardon,
were
ma'am?
Patient was complaining of pain, and you have provisionally diagnosed it to be a fibroid. So does it go together?
Ma'am, in fibroid also presents with the heavy menstrual bleeding with
Pain.
sometimes dysmenorrhea, ma'am.
What is the
And
typical bleeding you get in fibroid? Very typical about it.
Ma'am,
it's
painful,
heavy
menstru-
prolonged with passage of clots.
clots.
It's not painful. You said painful. Painful. It cannot be
Heavy
painful.
prolonged with passage of clots.
It is typically explained as second-day flooding. You know, second-day flooding, that's a typical say that is usually said. But how do you explain the pain?
Ma'am, pain can be because of the any infection, or it can be of the degeneration, or it can be also be because of any, if it's a case of ovarian, if it's a pedunculated, then the torsion can also lead to the pain, or any
Pain
Or
in this patient. What she is having, you explain the reason of that pain.
ma'am, the fibroid must be the pressing on the surrounding structures, which can lead to a stretching pain. And
No.
No.
Ma'am,
She's
like
having dysmenorrhea, or she is having pain, constant pain. You have to first
we started with dysmenorrhea and then it gradually turned into a chronic pelvic pain. So, starting with dysmenorrhea, the dysmenorrhea could be because the fibroid has increased vascularity. So, while in menstruation, it leads to increased release of prostaglandins, and hence she lands up into secondary dysmenorrhea. And chronic pelvic pain is due to the pressure of the increasing fibroid on the surrounding structures.
But then you have mentioned there were no symptoms, no bowel, no urinary symptoms, nothing at all.
ma'am, she was not having any symptom, ma'am, but she was continuously feeling dragging kind of pain in the lower
Dragging
The
abdomen.
heaviness down below.
Yes, yes, ma'am.
Okay.
And it was
Okay,
continuously
and-
radiating to backs.
And another thing, do all fibroids lead to menorrhagia or heavy periods?
No, ma'am.
No.
Mostly,
Okay. So you did mention one thing, degeneration can occur and can lead to some pain, or what are the other factors? Anything else, Dr. Amita or Dr. Sanyal? You would like to-
What are the causes of that heavy menstrual bleeding in fibroid? Why there is heavy menstrual bleeding in fibroid?
ma'am, there is increased vascularity, and as the size of the uterus increases, there is increased vascularity due to new vascularization.
One is
So
increase,
it leads-
second is
Anything else? Anything else?
There are many factors. What about increased
Not
size
only-
leads to what? Increased
ma'am,
size.
surface area of uterus also increases,
Any other
ma'am.
factor? Any other factor?
Any other factor? It is an hyperestrogenic state. So what will happen?
There is a endometrial hyperplasia will occur, ma'am. So which
That
lead
is
to the more sloughing of the endometrial during the menstrual
Any other
cycle. And
factor? Any other factor which is very
Any other?
20 weeks uterus, multiple intramural fibroids.
yes, ma'am, multiple fibroid can also lead to the.
So how they lead to that? That is the question. Only one factor you can is left. What happens to the contractility of the
The contractility increases, and that's why we have a heavy menstrual bleeding.
It is not because of increased contractility.
The contractility increases and the vessels are quite fragile, and so it leads to bleeding.
No.
Okay, can I pose the question in a different way? In a normal menstrual period, how does the bleeding stop? What are the factors involved?
Ma'am, after in menstrual during normal menstrual cycle, when there is a increased estrogen, when there is a withdrawal of the progesterone, so there is a sloughing of the endometrial superficial layer of endometrium, and with increase in the estrogen level, the stromal support occurs, and the bleeding stops slowly.
No, I agree. What you are saying, why
Ma'am,
is there menstruation?
There is
How does it
gradual
stop?
imbalance between the vasoconstrictor and vasodilator, like thromboxane A2 and prostaglandin F2 alpha. It increases, which lead to bleeding, and there is a decrease in the prostacyclin, and which is the vasodilator. So due to this imbalance, the bleeding continues to increase, ma'am.
My question was, in a normal cycle, you have a period and it stops by itself without taking any medication.
Yes, ma'am.
What are the mechanisms
Yes, ma'am.
involved in the stoppage of the bleeding?
Ma'am, when there is a progesterone, when there is progesterone,
The progesterone levels also fall. No?
Yes, ma'am. Ma'am, there is a gradual rise in estrogen, like it follicular generation happens, and that's why there is stoppage.
Okay, why does the bleeding occur? Because the blood vessels are open?
Yes, sir.
Is that why the bleeding is occurring? What happens to the blood vessels?
Ma'am, there is increased permeability and increased fragility of the blood vessel, and
That is for the bleeding. I'm
yes, ma'am.
talking about stopping of bleeding. Cessation of menses क्यों होता है?
फिजियोलॉजी में पढ़ना, इनिशिएशन एंड सेसेशन
है ना? उसमें वन ऑफ द, ठीक है, यू कैन रीड अप द केमिकल फैक्टर्स, द प्रोजेस्टेरोन वगैरह जो भी है जो कंट्रीब्यूट करता है, बट प्रोस्टासाइक्लिन्स, प्रोस्टाग्लैंडिन्स, व्हाट डू दे डू टू द यूट्रस? एक फैक्टर सिर्फ ये हम पूछ रहे हैं.
मैम, प्रोस्टासाइक्लिन जो है वैसो कंस्ट्रिक्शन वैसो डायलिटेशन कराता है, और थ्रोम्बोक्सिन A2 और प्रोस्टाग्लैंडिन F2 अल्फा ये वैसो कंस्ट्रिक्शन कराता है मैम.
और
तो
does the contractility of the uterus contribute at all?
यस मैम, ये कॉन्ट्रैक्टिबिलिटी की वजह से मैम इंक्रीज हो जाती है, और सारा स्लफ endometrium
But does it help in the closure of the blood vessels? A sort of a pressure on the blood vessels?
Yes, ma'am.
It's a very simple physical thing.
Simple physical, the leading ligature.
There is crisscross ligature muscle.
वो ठीक है. फिर फाइब्रॉइड में जो आपने बोला ना कि
this is what I was
इंक्रीज होती है, वेसल्स फ्रेजाइल है, तो they'll open up. That concept, to clear that concept, this question has been asked. So fibroid, they have incoordinate contractions. If there is a large uterus because of fibroid, so that is one of the cause of heavy menstrual bleeding.
Because the vessels do not constrict as effectively.
Yeah.
Yes, ma'am.
चलो अब तुम्हारा diagnosis.
Sorry, I thought I just.
बिल्कुल ठीक है. Provisional diagnosis fibroid है, then how will you confirm it?
Ma'am, we are going to by clinical examination we came to know that this is fibroid. Then we'll go for investigation such as, ma'am, we can abdominal. We also tell patient for ultrasound, and then we can see, since the mass is felt more than 12 weeks, so transabdominal sonography is better in this case. So we will go for transabdominal sonography, which will show hypoechoic to isoechoic structure, which can be differentiated with the myometrium. And
and you will do TVS also or not?
Ma'am, TVS we will do to since in TVS the probe is nearby to the uterus.
We can also rule out the associated any tubal or ovarian pathologies. So we will go for a TVS also. AS and TVS
both,
approach.
Okay. So you have done ultrasound. Now it says there are multiple fibroids, and it is showing all the fibroids, and few are intramural and subserosal, and then bilateral ovaries are normal.
Yes, ma'am.
Line of action, and endometrial thickness also is around 10 millimeter. It is irregular.
Ma'am, in case of any patient who is in perimenopausal
This
age
patient,
group,
45 years, what
yes,
will you
ma'am.
do?
Ma'am, this is a perimenopausal age group. So before going to any thing, we'll go for taking pap smear. And since the endometrial thickness is 10 mm, we will go take the endometrial sampling, and we'll also look for the histopathological examination, depending, and we'll see whether there is any atypia or not. First of all, we will rule out that. And also, ma'am, on the family, since the family is complete, she does not desire of pregnancy, and there are multiple number of fibroids are there. So this patient, ma'am, will
So that will be the plan. Yeah. So what will
yes,
be your
ma'am. First of all, ma'am, we will take endometrial biopsy.
Hold the apne. Biopsy is
then,
normal secretory endometrium. Okay.
Ma'am, then we counsel the patients that these are the options available for you. So are you desiring fertility? We'll reconfirm if she is desiring fertility or not. And then
what parents?
Remember, she is having pain also.
Yes,
45
ma'am.
years in. To 45 years, you'll ask her whether she is multiparous. Para 2?
Yes,
Ma'am,
prior to
sometimes
living to.
the females are like, we want to retain the uterus. We are not willing for such a big operation. We don't want to compromise on our uterus. We want the uterus, so that's why we will first take it from her that does she want her menstrual function to be retained, reproductive function to be retained, or she wants hysterectomy. After obviously after explaining all the things to her that you have multiple fibroids, if we go for a myomectomy, then what will be the risk possible, and what will be the risk and pros and cons if you go for a hysterectomy.
Okay. Meanwhile, what will you do?
Meanwhile, we are going to, ma'am, do the from basic test like CBC. We are going to see the level of anemia, what's the status, and we are going to optimize her for if we are going to plan her for the surgery. Then we are going to.
If you are not planning for surgery, you will not optimize the removal.
No, ma'am. Then also, basically, we need to see the hemoglobin status of the patient. What is the, and then we will prescribe her. And if she is currently right now she is bleeding, then we will give her tranexamic acid, antifibrinolytic. Also, depending upon the status of hemoglobin, whether she belongs to severe anemia or moderate anemia, or she is mild, then we are going to give her iron. If for mild, then we are going to give her oral hematominics, and if she is moderate, then we are going to
thyroid function test.
Yes, ma'am, definitely, ma'am. Because both hypo as well as hyperthyroidism can lead to the abnormal uterine bleeding, then prolactin test will also be done.
Even if she has 20 weeks uterus with HMB, you would like, and there no clinical sign and symptom of hypothyroidism or hyper, you would like to do TSH and prolactin?
Ma'am, since it is 20 weeks, so we are obviously will go for the surgical part. So for that very operative analysis, we need to do the thyroid function test on the basis.
Great. Good. So for that reason also then anesthetist will need TSH. But then is there need for getting prolactin?
No, ma'am. This 20 weeks, so there is no point of doing prolactin. Like
clinically, you see the patient.
Yes, ma'am. Since she is not complaining of any kind of headache or visual, so like
visual prolactin
or galacturia also is not, breast examination is normal. So
Dr.
we are
Basu, you say yes, Dr.
clinically we will exclude.
Okay.
No, you said because the uterus is 20 weeks, we will not do prolactin. So which size would you do a prolactin then? What I want to stress is don't say things which can lead to questions which are uncomfortable and lead you on a different track.
Sorry, ma'am.
Okay?
I will keep in mind, ma'am.
No, don't have to apologize. I'm just pointing it out. That stick to the
surely will
basic
keep in mind in future, ma'am.
So whenever you speak anything, make sure it is really justified. Otherwise, just keep quiet about that, and unless you're directly asked. And then don't say that you have to justify it just because you've said it. You can say, okay, sorry, it just slipped from my mouth or whatever, but you say something.
Yes.
Okay. Your plan is now you give the choice to the patient, but she needs one thing is clear, she needs operative intervention.
Yes.
So your patient has opted for hysterectomy. ये चले ठीक है
Yes,
एक option ये है. So कैसे करोगे क्या कौन सी अब hysterectomy में भी there are so many options. So what type of hysterectomy, what route will you offer her?
Ma'am, there are 3 hysterectomy, ma'am. Vaginal hysterectomy है, abdominal hysterectomy.
आप क्या ऑफर करेंगे? Everybody knows that.
Abdominal route में मैम total abdominal hysterectomy उसको ऑफर करेंगे मैम, क्योंकि 20 to 24 weeks के साइज का यूट्रस है, लार्ज यूट्रस, तो
Laparoscopy 18 to 20 weeks.
So laparoscopy will be tough, but also it depends upon the expertise of the surgeon. So
okay.
Any factor which would be against laparoscopy?
Size?
Ma'am, size would be against, because we will have to do morcellation. It won't be coming out from the vagina without morcellation, and endobag morcellation for a 20-week uterus would be difficult.
वो तो खैर expertise पर many people would claim कि I would be able to do it. But the important thing is that morcellation, power morcellation, is not
Yes.
recommended, and whatever you do, it should be in the endo bag.
Yes.
That is that. Okay, so you will do hysterectomy. Anything along with hysterectomy, which will you write for plan of management? Only hysterectomy.
Ma'am, hysterectomy with bilateral salpingectomy. Salpingectomy will like to retain the ovaries if the ovaries are normal.
And then no history of cancer, or she not
No.
high.
Yes.
Bilateral opportunistic salpingectomy you will do along with the hysterectomy.
Yes, ma'am.
Okay. So if she is willing for not willing for hysterectomy,
Then, ma'am, if she is not willing for hysterectomy, then we are going to do
Open myomectomy, ma'am. We'll offer her open myomectomy because she
Will
has.
it also depend on the endometrial sampling? What is
Yes,
there?
Yes,
in-
ma'am. Yes.
yes, ma'am.
that we gave her secretory endometrium.
Okay.
So
Okay, don't you think your counseling should come in here?
Hmm.
And you should help the patient arrive at a decision?
Yeah.
Yes, ma'am.
Yes, ma'am.
We are going to give.
Explain her all the pros and cons of having myomectomy and hysterectomy.
No,
As I
so
said
tell us
earlier.
now. Tell us the pros and cons of myomectomy in her case.
So, as she is 45-year-old, if we go for a myomectomy, she is all, as we have said, she has a pallor on general examination. That means she is anemic. So we'll have to first correct her anemia. Second, so
Even in
corrected
hysterectomy,
anemia. Corrected
Priti,
anemia.
can
When
you
we
please
go
listen
for
to
a
hysterectomy
Priti,
will be
please
the
listen
correct.
to the question.
Yeah.
Ma'am, recurrence of the
Very good.
recurrence is very important in this case. And
In how many percent it will recur then? Can you tell us the recurrence rate?
15% recurrence of the fibroid occurs, ma'am.
Multiple fibroid, it is more little. But what about other conservative? If you have all the facilities in your hospital,
we can
and
tell our
endometrium
patient
says it is
regarding,
secretory. Yes, what else can be done?
since benign is, then we can go opt for uterine artery embolization in this case, ma'am. And also high intensity focused ultrasound HIFU can be offered.
HIFU for multiple fibroid will be little, I don't know, I'm not very sure, but definitely uterine artery embolization is a good option.
But I would
for
like to
45
know
years
what
age.
is the upper limit of uterine size for UAE?
It's like 24 weeks, ma'am.
12 weeks.
No,
12 weeks.
24.
No, it is
No,
24 weeks is, ma'am. 24 weeks have been said, ma'am.
Sorry, I don't know. Any idea?
Yes, it is up to 20. I have done up
22
to
weeks.
much more than that. 28 weeks also I have done. But the size in decrement comes around 60% or something. At least the patient don't have that heavy menstrual bleeding. And for a patient who is at 45 years of age, you have that particular option because maybe she's going to have her menopause very soon. And if you want to have the other medical management, I think if the patient is strongly willing that I don't want to remove my uterus, you will get a lot of patients. You are absolutely right. So for saving the uterus, you can also think of other options like mifepristone for a temporary, maybe within 6 months if she attains her menopause, nothing like that.
Yes, ma'am. And
How
also, ma'am,
now let us ask the dose of mifepristone. What dose will you give if you plan to give mifepristone?
25 milligram per day is like for 6 months, ma'am, we are going to give, and then we are going to again do ultrasound to see the shrunk decrease in the size of the
And on an
uterus.
average, what is the decrease in size if we give GnRH or mifepristone?
Ma'am, if we give like GnRH or mifepristone, then is 70% decrease in the size, approximately 70% size has been seen to
70% is
reduce.
quite a lot. I don't
25, ma'am, it's 25 to 30% decrease in size with 65 to 70% decrease in the menstrual bleeding.
Yeah. And up to 30% the mass is decreased. And then, what is the side effect of mifepristone? You are given it for 6 months.
Yes.
What is the objectionable side effect?
Ma'am, the liver function, her liver
That
function
was with
will get reduced.
ulipristal, not with mifepristone.
Ma'am, there is mifepristone induced endometrium.
Yes, very good. Bolo, bolo. हाँ endometrium पे क्या इफेक्ट है? It leads to amenorrhea, endometrial hyperplasia. Though on stopping the drug, it regresses, but then you have to monitor the endometrial thickness. It leads to endometrial hyperplasia. So those are the options. The GnRH is a good option.
Yes, ma'am.
She might reach menopause by the time we give her 3 to 6 months with ADVAC therapy after 3 months. So that can be an option. You can buy time with medical treatment. Invariably, then ultimately need surgical. And uterine artery embolization, of course, is a good option.
Yes.
So myomectomy, you said one will be recurrence, second?
Ma'am, bleeding is also increased if there is multiple option is a multiple fibroid or there, then while intraoperative the bleeding chances is also there, ma'am. Because
that is per op. You might have to convert to hysterectomy.
yes, ma'am, there are chances of conversion from if
That is okay.
like
So post-operative, you said chances of
We
recurrence.
keep her in follow-up and because of recurrence.
Okay.
Before going for myomectomy, if you are planning, the patient is insisting, so do you want to properly map? Because sometimes
yes, ma'am. We are going to do profile mapping of the fibroid mapping by doing 3D ultrasound to know the correct position and location and what kind of
type of
fibroids are present. Then we can plan our procedure more precisely and with care.
Plan you?
Yes. Because it's a very small fibroid inside the endometrial cavity can cause heavy menstrual bleeding. And if you go for myomectomy for bigger ones, the symptoms may continue. It's very, very important. It's very important. And it is always better to go for an hysteroscopic evaluation before you go for myomectomy. Very important.
Yes.
The mapping can also help you in planning your surgery. Is there any kind of fibroid you think which will not respond to your mifepristone or GnRH analogs, or less likely to respond?
Ma'am, subserosal fibroids respond to drugs very poorly. Pedunculated subserosal.
No, those in which we have mentioned, I'll tell you, usually if they have mentioned that they are all calcified, the calcified ones are less likely to respond.
Yes, ma'am.
Okay?
Yes,
and
ma'am.
those are also the ones which break the instrument during morcellation.
Yes.
Okay. You said about we were discussing uterine artery embolization. What would be the fallout or the side effects?
Ma'am, after there is a post-operative pain is very much, and continuous vaginal discharge is like it is very much seen in patient and if it's any subserosal or subserosal pedunculated fibroid is there, then it can lead to the it can get converted into wandering fibroid. Basically, ma'am, lower pelvic pain and this vaginal discharge is the most commonly seen.
And infection.
Yes,
which can lead to infection.
yes, ma'am.
So
And
you have to choose your cases judiciously.
yes, ma'am.
Decide, and the counseling becomes very important in the modern day and age.
Yes, ma'am.
That's the most important thing.
If the patient wants to conceive again, will you do uterine artery embolization?
No, ma'am. No, ma'am. It is not option for it.
Why?
Not enough.
Because it can lead to, ma'am, because uterus has got dual supply from ovarian and uterine vessel, so it can lead to the premature ovarian failure, ma'am. So we are not going to give this option to the patient if she wants to conceive in future.
Also, there is a chance of rupture uterus. I have seen after doing uterine artery embolization, within 6 months, somebody conceived and it got rupture uterus, because there is also some damages to the uterine musculature in relation to in that particular area where this happens. So it is never to be done patients who wants to conceive again till now.
Yes, ma'am.
So that question is still incomplete. So one, if you do myomectomy, one counseling you have done is the chances of recurrence of myomas, you know.
Yes,
Also
ma'am.
the chances of recurrence of HMB in
Yes.
these cases. And there is chances of reopening, resurgery.
Yes, ma'am.
Because of adhesions, because myomectomy does lead to abdominal adhesions, bowel adhesions. So they may be reopened because of other reasons. So that counseling also needs to go when you're doing open myomectomy or even laparoscopic.
Yes, ma'am.
So
Causes of pain in uterine fibroid, one you say degeneration, right?
Yes, ma'am.
And anything else you said?
Torsion.
Pain, acute pain can be because of torsion.
Torsion, anything else which can cause cyclical, that kind of what you said, that patient is having dysmenorrhea. What are the other causes that can happen that can cause this dysmenorrhea when there is fibroid?
Ma'am, if she has development of adenomyosis, like
Yeah, associated endometriosis.
Yes,
So
ma'am.
fibroid is a condition where you have something associated. And the associated condition, one is pelvic inflammatory disease, which also causes excessive bleeding per vagina.
Yes.
That is heavy menstrual bleeding. And they can also have endometriosis as well as pelvic infection. Yeah.
Yes, ma'am. Yes.
And sometimes a very small fibroid, if it in the submucous region, every time, and especially in the cornual region, where you have the initiation of the uterine contractions, then also patient can have pain. So these are the situations where you have pain with fibroid.
Yes, ma'am.
how common is the malignancy in fibroid?
Less than 1% is the chance of leiomyosarcoma in getting benign getting converted to malignant. There is very less chance, 1%, less than 1%.
And what are the symptoms if you clinically suspect?
Very rapid rise. When we examine the patient, there is very rapid growth in case of uterus, like increase in size of uterus more than 6 weeks in last 1 year.
in the postmenopausal
movement, we need to see.
Then we need to be alert for leiomyosarcoma.
Any other loss of weight, fever?
Yes, ma'am. A patient generalized cachexia, loss of weight and fever, and recurrent infections we may point towards the by history we can come to know whether she.
Okay.
Okay.
Patient also had decreased appetite. What is the reason of that decreased appetite, which is little disturbing to me?
Ma'am, actually, she, as we said, she had a bit heaviness and chronic pelvic pain with, and she had some abnormal like uterine contour. She came to us like मेरा मतलब पेट बढ़ रहा है, मुझे heaviness लगता है नीचे, तो मेरा कुछ खाने का मन नहीं करता. I'm just in low mood because of this dull aching pain all the time. I can't do my chores. I don't feel like eating. So it's just it's a like added symptom. Because of that pain, she is so like dull and discomfort. She doesn't feel like eating.
So just a mechanical thing. But if you
Yes.
get something, the patient is complaining of dyspepsia at this 45 years of age, what should also come to your mind? And the lump.
It can also, this is a vague symptom which is mostly seen in the ovarian malignancy, ma'am. You need to say.
So you have to think of that. Okay. Yes,
Just
Dr.
one
Basu.
thing. No, it was just going back to the history. You said that there was heaviness and pain down below.
Yes.
Now, this mass of fibroid, which you said was 24 week size, would not have arisen in 6 months, would it?
No, ma'am, it was earlier. It
Why
must
did she
have
come
been,
now?
ma'am, because most of the time, ma'am, fibroids are
No,
asymptomatic.
I'm not talking about most of the time. I'm asking you, in this particular case, what made her come now?
Ma'am, because now she earlier felt only heaviness and mild distension. Now the distension increased, and along with that, the pain had become unbearable. The chronic pelvic pain has gradually increased over the months. Because of that, and the bleeding also, she once, as we mentioned, she once took tranexamic OPD management somewhere. Then likely she took tranexamic acid, but she was relieved only for that
Just one
cycle.
thing.
And then,
Just one
yes,
thing.
ma'am.
You said that she had taken treatment elsewhere.
She went to just.
What was
A
the
local-
size of the uterus reported there?
Ma'am, it was a local hospital, so not with a gynecologist. She went to a local hospital where she complained of PV bleeding, and she was prescribed some drug, which eventually she took for 3 to 4
Nobody
days, and the
examined
bleeding
her.
had stopped. No, ma'am, no.
No examination, no ultrasound, nothing.
No, ma'am, and there was no
The point that
documentation
I'm trying
also.
to make is that a fibroid of this size does not grow in 6 months' time. And if it has grown rapidly and she did not feel, then you should become suspicious of other factors as well.
Yes.
There is loss of appetite now and everything. So this would be probably one major factor why you would not consider any laparoscopic surgery. Because there is no investigation on earth which can confirm a sarcoma pre-operative.
Yes. Any hormone which has been suggested, any test before taking for laparoscopic, you do it so that the sarcoma, we to certain extent we can rule out.
Ma'am, ma'am, to differentiate it with tumor of ovarian malignancy, we are going to do HE4 for this.
No, not that way. Just in leiomyoma and leiomyosarcoma, to differentiate those.
LDH, ma'am,
LDH.
need to be done, ma'am.
You remember the cutoff? I don't remember. If it is raised, then you should be careful.
350.
I think it's around that only. Yeah. So,
Okay, the clock is ticking. Two
yeah,
more minutes.
and,
Yes.
they have really presented very well.
Very well.
Answered, I want to know what was done for this patient.
Ma'am, eventually she underwent, ma'am, total abdominal hysterectomy and
Lateral salpingectomy.
and
The ovaries were normal, so we preserved the ovaries.
and they were sent for histopathological examination, which benign. There was nothing. Multiple fibroids were seen. Histopathology said walled appearance of the and myocytes were seen.
Well managed, huh?
Good.
She was opened by peninstil or longitudinal?
A midline vertical incision was taken, ma'am.
Peninstil से खुल सकती थी नहीं?
मैम खुल सकती थी, लेकिन अगर बढ़ाना पड़ता तो it would have difficult. So
नहीं होता, easy.
नहीं, कभी-कभी
easy.
मायोमा जो सामने आ रहा है उसको निकाल के हटा लो, फिर चल जाता है।
Now there's so many options. Every case, this or that, this or that.
Absolutely.
So
Okay.
Okay, thank you. Very nice.
Thank you so much. Thank you so much. And thank you,
Thank you,
Dr.
ma'am.
Mala Srivastava, for
Giving
giving
this
us this opportunity. Yeah, thank you. Thank you.
ma'am.
Nice meeting
Thank
you,
you,
Dr.
ma'am.
Bhaskar and Dr. Sunita.
Thank you. And it's nice meeting you as well.
Okay.
Bye.
Thank you, Dr. Amita, Dr. S.N. Basu, and Dr. Sashwati for conducting such an informative and knowledgeable discussion on AUB. And thank you for giving us your valuable time. Thank
Most
you.
welcome.
And I thank Dr. Rishav and Dr. Priti also for presentation was very well and they answered very well.
Yeah.
Now I request Dr. Huma, who is Associate Consultant OBGY at Rangaram Hospital, to continue with further session. Dr. Huma?
Good evening, everyone. Am I audible?
Yes.
Yeah, good evening, everyone. And thank you, everyone, for the previous interactive sessions. It was really great and a great discussion on AUB we just had. So moving up to the next case, we have an interesting case of postmenopausal bleeding, the panelist. And we have Dr. Harsha Kular ma'am. I guess ma'am is a bit busy, so we will be having Dr. Sharmishta Garg, who's consultant in Sir Ganga Ram Hospital, Institute of Obstetrics and Gynae. The next panelist is Dr. Bindya Gupta. Ma'am is Professor in Department of Obst and Gynae in UCMS and GTB Hospital. Welcome, ma'am. And the third panelist we have Dr. Pakhi Agarwal. Ma'am is Consultant Obstetric and Gynae in Fortis Healthcare, New Delhi. And the presenters we have Dr. Nikhil Ritolia, who's a second year DNB student in our hospital, and Dr. Miki Shah, who's currently pursuing fellowship in Gynae Onco in Sir Gangaram Hospital. So let's begin with the session. Dr. Nikhil. Dr. Nikhil, are you there? Dr. Nikhil, Dr. Miki.
Are the presenters there?
No,
Yeah.
no, ma'am. Both are not in Zoom now.
I'll just confirm, ma'am.
All right.
They'll be joining soon. They have little network connection there. Yes, Dr. Nikhil, I can see you over there. So
Yes,
you can
ma'am. Sorry
proceed
for
with the
that,
case
ma'am.
presentation.
Good evening, ma'am. Sorry for the delay. So, Mrs. X, wife of Mr. Y, 62 years old, Hindu female, resident of Trilokpuri, New Delhi, homemaker, Arati L2, married for 40 years, belonging to low socioeconomic status by Kupuswami scale, and she's a postmenopausal since last 8 years. So she came with a complaint of spotting per vaginum, 3 episodes in the past 2 months, each lasting for 1 day. Last episode was 2 days back. Fresh red in color, staining only the undergarments, not requiring pads, not associated with abdominal pain. There was no history of preceding genital trauma or coitus, no foul-smelling discharge, any history of hormonal pills intake or anticoagulant therapy, any vaginal pessary use or mass per vaginum, no history of any recent perineal surgery, hematuria, burning micturition, dysuria, altered frequency of urine or urgency, bleeding per rectum. No history. There was no history of altered bowel habits, constipation, diarrhea, painful defecation, dark-colored or blood-stained stools. No history of loss of appetite, early satiety, cough or hemoptysis or significant weight loss. No history of any mass per abdomen, hot flashes or night sweats. Menstrual history. She had a menarche at age of 13 years and she attained menopause at age of 54 years. Her previous cycles were it stayed for 4 to 5 days, came after a period of 28 to 30 days. It was regular, average flow, no clots or dysmenorrhea, and her perimenopausal period was uneventful. Her ops history, she's married for 40 years. She's married to live to both NBDs. Her last childbirth was 18 years ago. She history of barrier method of contraception and no high risk sexual behavior in the patient or husband.
Past history, patient is a known case of hypertension on antihypertensives since last 4 years. She is compliant and well controlled. No history of any other chronic medical illness or cancer. No history of any surgical intervention. Personal history. She's a homemaker, vegetarian, non-smoker, no history of any drug abuse or intake, no history of any change in bowel or bladder habits, normal sleep pattern. Family history, there's no family history of any chronic medical disorder in the family or cancer of breast, ovary, uterus, or colon. Her dietary history, she consumed a mixed diet with a total calorie intake of 2,400 kilocal and a protein of 50 grams. General physical examination.
So just a minute. Yeah. So your history is very complete. And so just on the basis of history, what all things are in your mind? What do you think that she is a postmenopausal lady with bleeding? So what all differentials have you formed on the basis of your history in your mind?
Ma'am, atrophic vaginitis, senile endometritis, endometrial polyp, cervical polyp, then endometrial cancer, endometrial cancer, endometrial hyperplasia, ma'am.
Okay.
All the
So-
conditions that you just spoke about, which is the most common?
Yeah.
The things you enumerated, which is the most common?
Ma'am, as she is most common, ma'am, is senile endometritis and atrophic vaginitis, ma'am.
Okay. So okay, then go ahead with your examination. Let's see.
Patient was conscious, oriented to time, place, and person. Her height was 156 and weight was 80 kg, which made her BMI to be 35 kg per meter square. On examination, bilateral breast and thyroid was normal. There was no pallid icterus clubbing cyanosis, pedal edema. BP was 130 by 82 and right arm in sitting position, and pulse was regular. It was 82 beats per minute. Chest and CVS examination was normal. On abdominal examination, abdomen obesity was present. Abdomen was uniformly distended. Umbilicus was central and inverted. All four quadrants moved equally with respiration, and there was no visible vein, pulsation, scar, sinus, fistula, or peristalsis, and hernial orifices were free. On palpation, abdomen was soft, non-tender, no mass was palpable, no organomegaly, no guarding, tenderness, or rigidity. On percussion, there was no shifting dullness or fluid thrill. Local examination, external genitalia appeared normal. There was no evidence of any ulcer, mass, or pigmentation over the vulva. Per speculum examination, cervix was flushed with vagina. Cervix and vagina was healthy. Vaginal mucosa was pale and vaginal rugosities were present, but it was decreased. There was no local lesion or abnormal discharge was seen. No bleeding was seen from the os, cervix or vagina. On per vaginal examination, cervix was smooth, firm in consistency, no lesion or growth was palpable. Uterus was anteverted, normal size, and non-tender and was freely mobile. Bilateral fornices were free. On rectal examination, there was no nodularity felt or no thickening of the parametrium was felt. So my provisional diagnosis is a 62 years old postmenopausal female, para 2 L2 with postmenopausal bleeding with known case of hypertension with obesity.
Yeah, with obesity, you have to add that.
Yes.
Okay, so what is your differential diagnosis now? In the order of your whatever causes you thought about in your history. So now, according to your examination, after examination, please tell them in the order of preference.
Ma'am, atrophic vaginitis, as she is postmenopausal, she's hypertensive, she's obese. So endometrial hyperplasia and then endometrial cancer, ma'am.
In order of which you will exclude. Differential means you want to exclude this condition first, then this, then this. So which is the first one on your list that you want to exclude?
Ma'am, atrophic vaginitis and then endometrial hyperplasia and then endometrial CA.
See, you've examined the patient, you've seen that the BMI is 35, she has a
Yes, ma'am.
PMB, she is hypertensive. So, don't you think we should keep hyperplasia and a pre-malignant or a malignant lesion first in our priority as compared to atrophic vaginitis? You've examined the
Definitely.
patient, hai na? So it
Yes,
should
ma'am.
be, I think it should be more, you have to first exclude your pre-malignant and malignant conditions and then go down to atrophic vaginitis. Okay, it is the most common cause, but now you've examined the patient, you know her as a whole. So that is why atrophic vaginitis should come lower down in the list as compared to the
atrophic vaginitis will be your diagnosis of exclusion when you have excluded cancer.
Okay, ma'am.
Nikhil, what are the points in favor of endometrial CA and what are the points which doesn't favor endometrial CA in your case?
Ma'am, she had an early menarche and attained her menopause late. She is postmenopausal. She is obese. She is hypertensive.
Now, each and every point.
Relative risk भी बताते जाओ साथ साथ. Early menarche, relative risk so many times increased. Late menopause, relative risk so many times increased. All of that.
Exactly. And with each
Ma'am,
and every
early
point, Nikhil, with each and every point, Nikhil,
Yes,
listen to
ma'am.
me first. With each and every point you're explaining, keep on explaining the reason behind it because all PGs are listening. Whenever you're enumerating one reason which is in favor of endometrial CA, keep on explaining the reason behind it. Why does it favor neoplasia or hyperplasia?
Ma'am, early menarche and late menopause, there is a increased exposure of estrogen. So there is more chances of endometrial cancer. Then when she's obese, the androgens get converted to the estrogens. So there is increased chance of endometrial cancer and hypertensive.
No, Nikhil, calm down. Does every female who has circulating estrogen in her body lands up having an endometrial CA?
No, ma'am, she's an obese female. That's why she has an
Does
increased
every
risk.
obese female end up having an endometrial CA?
No, ma'am.
Then what happens? It's a free estrogen. There is less of sex hormone binding globulin.
Yes, ma'am.
Okay, that's a free estrogen is calling that. That's unopposed estrogen. Okay, your third
Yes,
point.
ma'am. Then she's hypertensive. That increases the risk of endometrial cancer.
Have you heard about corpus cancer syndrome?
Yes, ma'am.
What is?
Ma'am, obesity, hypertension, and diabetes associated with endometrial is known as corpus cancer syndrome.
Keep on
so what are
narrating.
and what are the relative risks also? Please tell the relative risks, as madam has said. Tell how many times the risk increases with obesity, with hypertension. What is what
in this case, as the BMI of the patient is more than 35, so there is 6 times increased risk of endometrial CA. And 6 times, ma'am. 6 times.
6 times, I think it's quite a bit. No?
It's about the RR for BMI of more than 35, which is class 2 obesity is 4.5. And if it is
6
class
times
3
becomes very
obesity,
high.
if it's
Okay,
class
ma'am.
3 obesity, which is BMI of more than 40, then RR is 7.
Okay, ma'am.
Okay, so then with hypertension?
Hypertension, ma'am, 2 to 3 times increased risk of endometrial cancer.
And any other risk factors she has. So what are the risks? What are the points which do not go in favor of endometrial cancer in a history and examination? Did you hear my question?
Yeah, ma'am. I have heard the question.
Yeah.
Ma'am,
You
she's
can go through your slides, yeah.
Slide is not moving actually.
Okay, someone in
so
the
then
chat box wrote down
She's ma'am
parity.
multiparas, ma'am. She is multiparas, ma'am.
Okay.
Then no history of any HRT intake or OCP's intake.
Okay.
No
What were the
family
previous menstrual cycles?
Ma'am, previous menstrual cycles were regular. It stayed for 4 to 5 days and it came after an interval of 28 days.
So there is no history of any chronic anovulation, suggestive of any
Yes.
chronic anovulation. All right. Next.
No history of any infertility, ma'am.
Yeah.
PCOD, all of those are risk factors.
Yeah.
Yes, ma'am. No history of any cancer in the family.
Yes. Okay. So not when you're asking about cancer, you specifically wrote about the colon cancer, stomach cancer, etc. So what syndromes are you looking for in for endometrial cancer?
Most commonly, Lynch syndrome is associated, ma'am, with endometrial CA,
Mm-hmm.
hereditary non-polyposis coli syndrome.
Okay.
And then, ma'am, P10, Cowden, these are also associated with endometrial CA, ma'am.
Okay. What about BRCA?
Ma'am, BRCA1 and BRCA2 mutation have also been linked with increased risk of endometrial cancer, but an increased risk of ovarian cancer is more associated with
More
BRCA1 and BRCA.
Okay. So that is why you ruled out all the malignancies.
Yes,
All
ma'am.
right. Fine. So, so these are the points which do not go in favor of your patient having the malignancy because cycles were regular. She was multiparous.
Yes, ma'am.
Okay. And so, any more to be discussed, Dr. Paki, about this, or we can go ahead with the management? I mean, how do they proceed further?
Yes. Do you know the percentage of endometrial CA lifetime risk in Lynch syndrome? D Viva question.
40 to 60%, ma'am.
Okay, yeah,
Yes.
close to it can go up to 70. Yeah, that's fine.
Yes.
Go on.
Okay, so how will you proceed with the patient? What will be the first line of investigation?
Ma'am, in the OPD, we'll first examine the patient, we'll take a pap smear, and then we'll have an endometrial curating. Then we will order an routine blood investigations, which include CBC, thyroid profile.
Wait. I think let's go systematically. So in OPD, okay, you do a pap smear, that's fine. But in general, what is the first line of investigation when we talk about postmenopausal bleeding? Do we straight away jump to a biopsy or do we do something else?
Ma'am, TVS, ma'am, transvaginal ultrasound should be done, ma'am.
Yeah, that's the first line of investigation. Okay, biopsy,
Yes,
don't jump straight away to biopsy.
Yes,
So
ma'am.
what all do you see on a TVS, or you will do a
Ma'am,
TVS alone, or you do a combination? Tell us.
Ma'am, we see the uterus size, we see the endometrial thickness, we look for the size of the ovaries. We look at if there is any polyp or what is the endometrial thickness, ma'am. And endomyojunction we look at, and
Collection of fluid.
and any collection of fluid is there or not.
Yeah, in the cavity. All right.
Yes,
So what is the importance of endometrial thickness when you are looking in such a case?
ma'am, if the ET is less than 4 mm in postmenopausal female, then there is a decreased risk. But if it's more than 6 mm or 6 mm, then we have to further investigate her, ma'am.
So what are the
if the patient is coming with postmenopausal bleeding, does endometrial thickness hold any value in that? If the patient is symptomatic,
Yes,
then do we
ma'am.
really rely on the endometrial thickness? Then can we really sit on it? If the endometrial thickness is
No,
less than
ma'am.
4, if the patient is coming to you with bleeding.
No, ma'am. We should investigate her, ma'am.
So all cases of postmenopausal bleeding needs to be investigated.
Yes, ma'am.
Okay.
So with an endometrial thickness of you saying it's a 4 mm is the cutoff. So at 4 mm, what is the risk? Why is ma'am saying that they have to be investigated? Normally we say 4 mm and above it is you need to investigate on that point. Why do we say we are worried about even less than 4 mm? Can
Ma'am,
we have cancer on nephropathic background?
Type 2 cancer, type 2 endometrial cancer, and with ET, there has been found that ET less than 3 mm has also been associated with endometrial CMM.
So there is one variant of endometrial cancer which is not estrogen dependent. These women
Yes,
are
ma'am.
not obese. They are generally not obese. They will not have your conventional risk factors, and
Yes,
they
ma'am.
it will occur on the background of atrophic endometrium.
Yes, ma'am.
So what if your patient was on tamoxifen? So what would have been the situation? Would you have what will be the cutoff of endometrial thickness?
Ma'am,
Would you
when
still
the
take 4 millimeters in that?
no, ma'am. When the patient is on tamoxifen, we take the cutoff to be 8 mm, ma'am.
Okay. So in that case, do you think that is there any? Do you know what any classification which has recently been brought forth for endometrial lesions? Like we have the ORADs and we have the GYRADs and IOTA for ovarian adnexal masses. Do we have any classification system that has come up for ultrasound in endometrial lesions?
I don't have knowledge about that, ma'am.
Okay, so it is known as IOTA. It is International Endometrial Terminology, and it is like the IOTA. It is like IOTA is for ovarian tumors. It is for IOTA is for the endometrial lesions. Okay, and in that
Okay,
they
ma'am.
have various criteria. They have included endometrial thickness, endomyometrial junctions, and they have also talked about the fluid, the lesion inside the cavity, the edge of the lesion, vascularity, color Doppler. So there are various parameters, and that is called IOTA terminology. And depending on the various IOTA terminology, they have developed a GYRAD scoring for endometrial lesions, in which they have started from stage from GYRADs 1 to GYRADs 5, and GYRADs 4 and 5. They have 4 is divided into further A, B, and C, and so GYRADs 4 and 5 they are more likely to be malignant lesions. So they have various parameters on ultrasound which they see, and therefore they accordingly classify the endometrial lesions accordingly. So this is the IOTA terminology and the GYRAD's scoring according to the IOTA terminology. Okay.
Thank you, ma'am. Yes, ma'am.
Okay. So, Dr. Pak.
So back to tamoxifen. What was your answer about tamoxifen?
8 mm was the 8 mm is the cutoff, ma'am. We take when the patient is on tamoxifen, ma'am.
Symptomatic or asymptomatic? What if there is a patient of breast cancer on tamoxifen?
Yes, ma'am.
How do you are you going to monitor? How are you going to monitor her ET first? Second, how
Yes, ma'am.
frequently are you going to monitor her ET? And third, if she's asymptomatic but you detect an ET of more than 8 mm as per your cutoff, what are you going to do?
Ma'am, if the ET is more than 8 mm and although she is
पहले
asymptomatic,
question से शुरू करो. पहले question से शुरू करो. Are you going to monitor routinely? That's number one.
yes, ma'am. Yes, ma'am. We would monitor when the patient is on tamoxifen therapy.
How routinely?
Ideally, if you go to the
Ma'am,
tamoxifen guidelines, they say only when the patient is symptomatic. Okay, then you need to do a scan. Otherwise, what is the difference between endometrial thickness of tamoxifen vis-a-vis a normal endometrial thickness? How does an endometrium become thickened in tamoxifen?
Ma'am, there's edema, subendometrial edema when the patient is on tamoxifen therapy, ma'am. That's why there is a cystic hyperplasia in case of tamoxifen therapy.
Yes. So ACOG says there is no need to do routine scanning, either 6 monthly or 1 yearly or anything for women on tamoxifen. So that's one. But you must investigate them as soon as they get symptoms. Go on.
So the second part of Dr. Paki's question, have they covered?
Yeah, so no screening, no routine screening. So the second question of what is the frequency is now not valid now because there is no routine screening. And more than 8 mm and patient is asymptomatic.
Ma'am, no. If the patient is asymptomatic, then we'll not investigate, ma'am.
You could wait and watch. But if
Yes,
there's
ma'am.
any symptom like even discharge, blood
Yes,
mixed
ma'am.
discharge, not traditional bleeding also, then you must investigate.
Okay.
चलो अपने प्रोविजनल से आगे चलो और हैं स्लाइड्स.
Ma'am, we were discussing the ultrasound findings.
And also,
we were
besides
discussing the ultrasound
endometrial
findings.
cancer, besides endometrial cancer, another what is another is also associated with increased risk of.
I'm sorry, ma'am. I was unable
besides
to hear.
endometrial cancer, besides even it's associated with increased risk of what?
Question is that other than endometrial cancer, tamoxifen usage is associated with what else? Which other endometrial pathology?
Even tamoxifen is associated with increased risk of uterine sarcoma also. That is what Dr. Paki said. Even if she has blood mixed vaginal discharge, you should investigate the patient. Don't wait for HMB to occur, okay?
Yes,
or
ma'am.
PM, okay? Okay, fine. So, So next question was, I saw they interrupted in between.
TVS पे थे ना? We were at TVS.
Yes, ma'am. Yes. So on
Ma'am
TVS,
was
ma'am.
asking question on TVS, yeah.
So on TVS, ma'am, we'll look for the uterine size, endometrial thickness, ovarian size. Then if there is any fluid collection within the endometrial cavity, any endomyometrial junction.
So you have those findings for this patient? No.
Ma'am, I've not included that slides, ma'am, in this.
Okay. So you did TVS, you did a clinical, you did pap smear, you did TVS. On
Yes, ma'am.
TVS, the ET was 4.5 mm. Ovaries were normal. Uterus anyways is normal size even in your clinical. Now what next?
Ma'am, we would take if it is more than 4 mm, although the patient is asymptomatic, we would take an endometrial aspirate, ma'am.
How would you do that?
With a pipple, ma'am, endometrial pipple or a Weber aspirator.
Sensitivity.
Sensitivity is around 90 to 92%, ma'am.
Yeah, upwards of 90%, even
Yes,
up to
ma'am.
95%. If you're looking at a global pathology, if you're looking at a focal pathology, then sensitivity goes down because your
Yes.
pipette might miss it.
Yes, ma'am.
Okay, now if the same endometrial thickness was 10 mm, then
Then also we would do a ma'am endometrial aspirate.
would you like to do anything else before you do that? If you have the facility to, as an outpatient.
Hysteroscopy. No,
As an
as an
outpatient,
outpatient.
if you have the facility to, is there anything else you could do?
Office hysteroscopy.
उसके पहले अगर है तो, नहीं है तो ठीक है. Many centers may not have it. You can do a sono hysteroscopy kind of thing, SIS. Why?
Yes, ma'am.
It doesn't make so much sense if the endometrial thickness is 4-5 mm, but if
Yes,
it's 10 mm, there is likely
Polyp.
possibility there might be a polyp. And
Yes,
if you
ma'am.
do an SIS and you see a polyp, then your pipelle is not the best first line test for you, isn't it?
Yes. Yes,
Suppose
ma'am.
if you don't have it and you did a pipelle and your pipelle came negative and you
Yes,
found an ET of 10 persisting, then you will go to your next step, which is
hysteroscopy.
hysteroscopy. Okay. So about hysteroscopy. Batao.
Ma'am, hysteroscopy is usually indicated when there's cervical stenosis, when the endometrium is not clearly visible, when there is fluid collection within the endometrial cavity, or when the endometrial aspirate is negative, ma'am.
All right.
And focal lesion is present, ma'am. So we would do a hysteroscopy DNC.
ठीक है. So इस patient में हुआ था hysteroscopy DNC?
Yes, ma'am. Hysteroscopy DNC was done.
Okay. What was?
Okay, so suppose if you're suspecting there's a lesion in the cavity, and if we are thinking that maybe this may be malignant or there's a possibility of malignancy, and you're planning to do a hysteroscopy, what all precautions will you take during doing on a hysteroscopy in such cases?
There is one line school of thought that there might be a peritoneal spread when we do the hysteroscopy, but if there is any we suspect any cancer, then we could decrease the pressure of while doing the hysteroscopy. That would prevent the peritoneal spread, ma'am.
Yeah, so basically we should do a low pressure hysteroscopy, and also like this is just a peritoneal spillage thing was a very thing of the past. Nowadays it shows that it doesn't make any difference in the survival or upstage the tumor. So
Yes,
basically, however, we should just keep in mind that we should do a low pressure hysteroscopy when we are suspecting any malignant lesion in the cavity.
Yes, ma'am.
That's important. So you summarize the indication of hysteroscopy, na?
Yes, ma'am.
So what about you've included recurrent PMB also in the list of hysteroscopy indications?
No,
Ma'am, I said recurrent PMB if the two endometrial aspirate are negative within a period of 6 months, and it has to make the patient visit OPD twice in a period of 2 years, then we'll do the hysteroscopy DNC in that case also. Recurrent pain.
Okay. Okay, fine. So, okay, in this case, you've done a hysteroscopy, you've done a endometrial biopsy, okay, and
Yes,
you've done an endometrial biopsy, not a hysteroscopy in this case. Did you do hysteroscopy?
Yes, ma'am, we have done the hysteroscopy DNC.
So, what were the findings?
Ma'am, the endometrium was pale looking. It was hyperplastic. Bilateral ostia was visualized. Endocervical canal was normal, ma'am. And we took the curating and sent for the histopath, and the histopath reported grade 1 endometrial carcinoma.
So in this, you said that it's got a grade 1 endometrioid adenocarcinoma as your histopathology in this case. Okay.
Yes,
so
yes,
what about if suppose we have what are the other histological features which you see on a biopsy when you get endometrial cancer? How do you evaluate the histological specimen? What will you ask for the pathologist to do on your endometrial biopsy specimen when it is reported as endometrioid adenocarcinoma? You said about the grade. Type is endometrioid adenocarcinoma. Anything else?
Ma'am, IC markers will ask if to apply. Then we can see for the any molecular classification is there, so we can see for pole mutation or P53 mutation or MMR. Or
yeah, so just be specific. So IHC markers क्या लगाओगे और molecular markers कैसे करोगे और किस sequence में वो molecular markers करते हैं? Okay, so just be specific. Just every point you just tell in detail.
Yes, but the battery is low, ma'am. 1 minute. Connecting the charger.
Miki, Dr. Miki, I think you can answer this question well. Ma'am, Dr. Miki is a fellow in Gynae Onco.
For the immunohistochemistry, we can ask for estrogen receptor positivity or negativity for PR, Vimentin, and MMR, and pole mutation, sorry.
Okay, so what about P53?
Yeah, did you say
Yes,
P53?
P53 as well.
So how do you interpret these markers? You said pole, you said P53, and you said MMR. So according to these 4 markers, how do you classify, what is the molecular classification of endometrial cancer?
Ma'am, it's mostly for the first initially early cancers. It is usually used for stage 1 and stage 2. However, it can also be classified for stage 3 and stage 4 as well.
Ma'am, pole mutation, then the MMR.
पहले तो just this is a grammatical thing. Although we write it as pole, it is pronounced as pole E. It is called a pole E mutation.
Yes.
Yeah. So when you say pole E, I'm asking not about the staging. I'm asking about the when you're doing these markers, na. So according to that, how will you classify the cancer? I mean, how will you classify them as? Like pole E mutated. Then the second is like if suppose MMR आपका
Yes, ma'am.
जो molecular classes. So Dr. Bindia is asking the molecular classification of endometrial CA. This is the most recent thing.
Yes,
it has come out last year, and I'm sure you will be asked in the exam if you get a case of endometrial CA.
Yes, ma'am. Poly, ma'am. Either it can be wild type or abnormal type.
नहीं, वो P53 होता है. देखो, pole E होगा. So first thing you will do is pole E. So if it is pole E mutated, it's called an ultra mutated tumor, and that's considered a good tumor. Okay,
Yes.
it is a good prognosis tumor. So that is the ultra mutated type. Then you have the next thing you do is the MMR status or the MSI जिसको हम बोलते हैं. So if it is MSI high, then that is a hyper mutated tumor. So not a very good prognosis. Or kind of intermediate prognosis. Then you have then you have to do the other mutations, P10 and those ones. So if there is copy number, then it is classified as copy number high and copy number low.
On basis of P53 mutation. So P53 If P53 is absent, it is null or aberrant, and then you have P53 positive tumors, which is a bad prognosis tumor. And then otherwise, if P53 is negative, then you have the non-specific molecular profile or the NSMP tumors. Okay, so these are the four ways you classify them as the MSI, that is MMR deficient tumors, copy number low and copy number high. So this is the molecular classification, and this is now in vogue. You've been using a lot of them in the clinical scenarios also, and on endometrial biopsy also you can do all these markers. Even if POLE is not available, you can do MMR and the IHC markers and P53 IHC markers, because according to that you have an idea whether you're dealing with a high risk tumor, which can, even if that can also be endometrioid, whether you're dealing with a high risk or whether you're dealing with an intermediate risk tumor. Okay, and so that is why, and once you do it on the endometrial biopsy specimen, you do not need to repeat them on the hysterectomy specimen. That's also one of the things. So it's not that you have to do it both the cases. You can do only in the endometrial biopsy. That's more than enough. Okay. So now let's not go into endometrial cancer. Coming back to your case, so she is now grade 1 endometrioid cancer. Suppose your patient would have had that simple hyperplasia without, there was no hyperplasia without atypia. Suppose in your histopathology it was hyperplasia without atypia. What would you have done in this case?
Medroxyprogesterone acetate would have been given, or migestrol acetate would have been given, ma'am.
She's 62 years old. And so what is the risk with hyperplasia without atypia and hyperplasia with atypia to develop into endometrial cancer?
Hyperplasia without atypia is 1 to 2%, and with atypia is 25 to 33% now.
Yeah. So whenever she is a patient with hyperplasia without atypia, however, she is 62 years old, so you can offer a hysterectomy. That is because now she's postmenopausal bleeding. She's a large woman with a 35 BMI, and so you can offer a hysterectomy. There's nothing wrong in offering a hysterectomy. It's only once she denies the hysterectomy that no, I want to conserve my uterus, you can give an option of better than an oral medroxyprogesterone or migestrol acetate will be what?
LNG-IUS, ma'am.
Yes, better will be a Mirena in this patient. Okay,
yes,
you can give LNG-IUS to this patient, and then you can. How do you monitor a patient on LNG-IUS if you insert LNG-IUS in this patient?
Ma'am, for first 3 months, we monitor, ma'am. We have we give along with that Mirena box, there comes a card in which, but we have to tell about the.
Yeah, so we have to. See, right now our scenarios have changed. Okay, her endometrial thickness was 15 millimeters on ultrasound. Her biopsy is hyperplasia is without atypia, and she is saying, I don't want hysterectomy. I want to keep my uterus. Although I'm 62 years. Okay, patients will be coming to you like this. Na? You are in a private setup. So what will you do? So you were planning to give an LNG-IUS. Now on these patients, you will not be able to monitor their menstrual cycle because she's postmenopausal.
Sorry, ma'am.
So what will you do in this patient?
Question very simple is, how will you monitor the patients who you have put LNG-IUS in?
TVS, ma'am. 6 monthly ultrasound, ma'am.
Yeah, so you do an ultrasound at 6 months or 3 months. When do you want to do an ultrasound? Do you want to repeat a biopsy? What will you do?
We'll do it every 6 months, ma'am. Endometrial biopsy.
Every 6 months, you'll keep on doing endometrial biopsy.
And we'll review for the first 2 months. For the first two, like first 2 times 6 months. First 6 months, then 6 months. For first 1 year.
Okay, so you want to do a 6 monthly endometrial biopsy. Actually, see, there are no guidelines regarding this, but the general consensus states that you do an ultrasound at 6 months, and then you can also do a biopsy at 6 months to assess whether how much is the atypical, whether this hyperplasia is regressing or not. Okay, so how will you do a biopsy? Will you take out the Mirena and do a biopsy?
No, ma'am. It will be in situ.
Yeah, so in situ, can you do a biopsy?
Hysteroscopy guided, ma'am.
No, you can do a biopsy even without hysteroscopy guided also. Okay, you can, in fact, you can just put in your pipple and take a biopsy, and you can send it for analysis. Okay, you do not need to do a hysteroscopy. If a Mirena is in situ, you can just take a biopsy like that. And if it is showing regression of hyperplasia, that means you just ask the patient to do anything else other than the Mirena to continue. She's 35 BMI.
Ma'am, ask her to reduce her weight, ma'am.
Yeah,
Lifestyle
like
modifications.
yes. Because predominantly what we are assuming is that this estrogen excess because of the high BMI is there, and she can, if she undergoes a lifestyle modification, she reduces her weight. It can also help in sustaining that regression. Okay, so
Yes, ma'am.
that's important. Okay, and what about if it is hyperplasia with atypia? What will you do in those circumstances?
Ma'am, we'll offer her hysterectomy, ma'am.
Okay, so any special precautions? You'll take a hysterectomy of hyperplasia, atypical hyperplasia, vis-a-vis a normal hyperplasia without atypia. We obviously will be removing the ovaries, THBSO will be doing. So anything
Yes,
you want to something do differently compared to what is the risk of having a cancer associated concomitant cancer with atypical hyperplasia?
25 to 33%, ma'am.
Yeah. So anything else you will do as routine hysterectomy, or you do want to do something, some subtle steps which you will take into?
Send for frozen, ma'am. Frozen section. All
Okay, so now tell me about frozen. You have only landed up in your own. Now you discuss frozen section in hysterectomy specimen. Is it how relevant it is? What will you see? How is the concordance with the final histopathology? So do you
please, can you repeat the question, ma'am?
So what is the concordance of frozen with the final histopathology?
Ma'am, the frozen is, ma'am, not 100% specific, ma'am. We have to wait for the final HP report, ma'am.
Yeah. So do you send all atypical hyperplasias for frozen?
No, ma'am.
No. So frozen is not required. Okay. First and foremost is this. Any further imaging you would like to do before taking her up for hysterectomy?
MRI, ma'am.
Do you do MRI in all atypical hyperplasias?
I'm not all, but she's a high
Yeah,
risk, ma'am.
not required.
62. Yes, ma'am.
तुम like expert ultrasonologist, so you've done such a good TVS. Your endomyometrial junction is well delineated. There's no adnexal mass. What else will MRI offer? There's no endometrial lesion. It's just the hyperplasia, which is atypical. Okay. So, and
Yes,
your
ma'am.
TVS will tell us if suppose you're suspecting a growth or it has come out to be cancer, then we can do additional MRI. Otherwise, there's no need to increase the cost for atypical hyperplasia. Okay. So no MRI is required. Anything, anything else you want to do? Preoperative imaging? I don't think so. Do you do anything else?
No, at breast screening, ma'am, mammography,
Yeah.
we would have done, ma'am. Bilateral
Yes,
mammography
definitely.
3.
Yes. Okay. So now coming back to our original question, what about hysterectomy? So frozen section is not required. Any other thing in hysterectomy?
Staging, surgical staging is done when in case of endometrial CA, ma'am, not atypical hyperplasia.
Okay,
Atypical
yes, very good.
hyperplasia का दूसरा नाम क्या है, by the way? What is the now accepted terminology? We don't say hyperplasia without atypia or with atypia anymore. What is the terminology for hyperplasia with atypia? What is it called?
Endometrial intraepithelial neoplasia.
It's called
Yes,
EIN.
So if suppose in EIN you're doing a hysterectomy, so will you do lymphadenectomy?
No, ma'am.
Yes. So lymph nodes need not be assessed. You can just palpate that area. Otherwise, there's no need to do a routine lymphadenectomy. Okay. Third, what about anything else in the hysterectomy? The way you apply your clamps, the way you push your bladder, anything you want to keep, you want to do something a little bit different as a routine hysterectomy?
Extrafacial hysterectomy.
Yeah, so try to do an extrafacial hysterectomy, because if it comes out to be endometrial cancer, it's better that we are, although nowadays in endometrial cancer also they say we do a TH and BSO. However, it is better that we are, reducing some subtle differences. Like suppose when you're starting with, do not try to slip the clamps over the uterus. When you're doing an open hysterectomy, try to just apply a direct application of the clamp should be done. When you're pushing the bladder down, don't use blunt dissection. Try to do sharp dissection so that the fascia, part of the fascia remains with the specimen and doesn't go down with the bladder. So there's certain differences, and when you're opening the wall, be very careful that you do not do subtotal hysterectomy. Do not leave a portion of the cervix behind. Try to take the cervix completely. These are certain 3-4 points which you have to keep in mind when you are doing the hysterectomy. Whenever you have EIN patient when you're doing the hysterectomy, because as you said, 30% may be endometrial cancer also. Okay, so we don't want to have positive margins or just some parts of uterus left behind. That's important to try. Not all these 3-4 things which has to be done. Okay.
Yes, ma'am.
Okay, so Dr. Baki.
Yes, so I wanted to share something with them. So EIN, we say it is associated with endometrial CA 25 to 30%. So there is some role now that is coming up. You will find it in the latest publications, the role of sentinel lymph node mapping. So very correctly, they don't need a full lymphadenectomy, but you can do sentinel node mapping the same way you would do for endometrial CA, because there is now good data to show that it doesn't worsen, it doesn't increase the patient's morbidity because you're only doing sentinel. But in case it comes back as endometrial CA, they don't need to go in and have a second surgery just to know the lymph node status. So that is one thing which has come up recently, maybe in the last 1 year, within the last 1 year. So read up about it.
Yes, ma'am.
Secondly, what are the Dr. Bindia mentioned a few surgical steps. There are 1 or 2 more, if you can think of, that will prevent sort of surgical spillage. We used to do them a lot when we were training, and in the middle, no one was doing it, but this thing is coming back again. You tie off the ends of the fallopian tubes. That's one. You tie off the cervix from below, from the vaginal root. You close the mouth of the cervix, as well as you tie off the tubes from the top.
Okay.
Yeah, we can basically, when we apply those conofundal clamps here, as it is occluding the tubal lumen, so that doesn't this thing. And obviously, always take the specimen intact. Never do morcellation. Everybody is not, I mean, we do normally MIS for uterine CA and for endometrial cancer and for even for EIN. So whenever you're retrieving the specimen for EIN, never do morcellation. Never try to bisect it when you're vaginal bisection also should not be done. Don't do vaginal morcellation. Okay, so that is also very important.
Yes,
avoid this morcellation in the vagina, even in the vaginal morcellation.
Okay.
And so regarding PMB, I think what about if it was a polyp?
Ma'am, we would have done a hysteroscopic guided polypectomy, and then we would have sent for histopathology.
Now the report has come to be a benign polyp. Okay, so
Yes,
do you
ma'am.
need to do a repeat scan? You need to follow her up, or she is now asymptomatic? Do we call her up back?
Ma'am, we consider this age group only, ma'am.
Yeah.
The
Same
62 years.
patient, 62 years old, now on endometrial or ultrasound. There was a polyp, and you said rightly, we do a hysteroscopy, we do a polypectomy. It's a benign polyp, and done and dusted. She's asymptomatic. Okay, and
Yes, ma'am.
so now, what do? You call her for follow up, or you just let it be? What do you do?
Ma'am, we'll call her for follow-up whenever she's symptomatic or if she has any other complaints.
Okay, so when she has any symptoms, she will come for follow-up. Okay, so now suppose she's now symptomatic again after 6 months. She again has a bout of bleeding. So you do a repeat ultrasound, again a polyp. You do a hysteroscope, again a polyp. Remove it, again benign polyp. Now what next?
Ma'am, we will offer a hysterectomy.
Okay, so fine. So you're offering a hysterectomy, But before that, do you want to evaluate something? You have got 2 recurrent polyps, PMBs
What is the
recurrent.
reason? What is the reason she's forming
Don't
polyps?
you know want to? And she's 62 years old. Where is this estrogen coming from? She is okay. She's 35, but she was 35. She's still 35 BMI only. लेकिन अब कुछ और सोच सकते हैं कि इसके वापस पॉलिप क्यों बने जा रहे हैं?
Estrogen और कहाँ से आता है बॉडी में?
एड्रेनल्स से हो गया और ओवरी से
या कौन सी ओवरीज में क्या हमें evaluate करना है?
granulosa cell tumor.
Yeah, okay. So you have to evaluate the adnexa. And we have
Yes, ma'am.
microscopic granulosa cell tumors can be there, and they can give rise to repeated, polyp formation. So even if your ovaries are apparently normal, you're right, you're
Yes, ma'am.
offering a THBSO, but then you should always keep in your mind that they can be microscopic granulosa. So what will you do to rule out before doing a hysterectomy with tumor marker?
Serum E2 levels. Inhibin B.
Inhibin B, not E2. Serum inhibin B can be done to look out for granulosa cell tumors. Okay.
Yes,
So
ma'am.
that is
Yes, ma'am.
why that is an important aspect. And whenever you have these patients coming up, so always very carefully look for the adnexa.
Yes, ma'am. And then what would be the follow-up in that case, ma'am, if she has a
So then
gran?
you do a THBSO, na? If suppose the inhibin level is high, so you manage it as granulosa now.
Okay, ma'am.
So you will do a staging laparotomy, you will do a THBSO, and you will do the staging surgery for as a granulosa cell tumor, and then you will keep her on follow-up, and depends on the final histopathology. So basically, what we are trying to make you understand is even if she has recurrent PMB or a recurrent polyp formation, don't forget the adnexa, because sometimes it is not necessary that there should be an adnexal mass. Even microscopic foci of granulosa tumors have been found, and they are associated with PMD or even recurrent endometrial polyps in the postmenopausal age group. So always be careful, and therefore in these cases, if your adnexa is normal, you can go for serum inhibin B estimations. Okay.
Okay, ma'am.
Anything else, Dr. Pakhi?
I think we covered everything. What was in the, I can see a MRI at the bottom. What was in her MRI? Slide.
So there is a mass. So you did a hysterectomy for her? What was the report? There is a growth.
Yes, ma'am. We did an hysterectomy, ma'am, for her.
So what was the final histopathology? You said it was a
Grade 1 endometrioid carcinoma, ma'am.
with less than 50% mammothal invasion.
Yes, ma'am. Yes, ma'am.
I hope you all know the revised staging of endometrial cancer now, the one which is so
Yes.
extensive.
FIGO 2023 guide. Yes, ma'am.
Yes. So all the postgraduates and DNB students who are attending it, they should all know the staging of endometrial cancer, revised staging. Okay. So I think we are, Dr. Sharmishta.
Nothing, ma'am. I think we have covered all the points. I was just going through the chat box. Like most of the questions we have already answered. So I think we can take up questions from our audiences. I mean, if there are any residents who want to ask anything. Someone wanted to know what is the recurrent PMB. We have already answered. Like at least 2 episodes of PMB at a duration of 6 months with 2 reports reporting negative cancer and over a period of 2 years, actually. That's recurrent PMB. Somebody asked it. Apart from that, I think we have answered most of the questions.
Somebody asked to repeat the CIS part. Pakhi, you can tell about the CIS.
So in SIS, what you do is you instill saline from the cervix, and at the same time you do a TBS. And what you're looking for is, because once the saline goes in, it's going to distend the uterus, it's going to separate the 2 walls. And if you have a focal pathology, then you will be able to see it. It would be like almost as if you did a hysteroscopy. So if it's a focal pathology that you suspect, then you know that PIPL is not going to, may or may not, because most of these patients who are postmenopausal and who have polyps, they just have the polyp. They really don't have endometrial hyperplasia along with. The rest of the background endometrium is quite basal and quite atrophic. It's just the polyp. So you won't get anything on a PIPL. So in that case, you will post this patient for a hysteroscopy, polypectomy, DNC, rather than waste your time with the PIPL. And if you don't see a focal pathology, then your PIPL is going to pick up whatever global pathology that is happening in the endometrium.
Yeah. So somebody's asked whether MPA or migestrol is better in benign endometrial hyperplasia. See, actually in benign endometrial hyperplasia, LNG-IUS is the best. But if we want to give oral progestrogens, both MPA and migestrol have similar outcomes. But they say that migestrol acetate sometimes has better regression rates because it has a higher, nuclear retention time. The drug is more effective, migestrol acetate. That is what they say. But if you see the general overall outcomes, it's almost the same with both MPA and migestrol acetate. And normally when we talk about higher doses, we give it for atypical hyperplasia. And you tell us the doses? You only tell? What was the doses for?
Metroxyprogesterone acetate is 10 to 20 mg per day, and migestrol acetate is around 40, I guess 40 to 120 mg, ma'am.
160 mg per day.
160, yes, ma'am.
But that is for normal What about if suppose it is endometrial cancer or we are talking about atypical hyperplasia? In that cases, what are the doses? They're much higher. 400 to 600 of even MPA and migestrol acetate is 160 to 320 milligrams per day. When you talk about atypical hyperplasia or even the EIN, or when you talk about in those cases, we have higher doses of progesterone, oral progestrogens.
In fact, sometimes you have to double up therapy. You put a Mirena and you give migestrol.
Yeah, you have combination of both intrauterine and oral.
Ma'am, once can you repeat the doses, ma'am?
160 to 320 is migestrol acetate. When you talk about EIN or endometrial cancer, and you give it in combination with LNG-IUS, it's saying better regression rates. When you're doing a combination therapy, even you can combine GnRH with LNG-IUS. They have combined. Sometimes they've even tried hysteroscopic resection with LNG-IUS. So combination therapies have also been tried when you're doing conservative management of endometrial cancer or EIN. I'm not talking about hyperplasia without ATP. I'm talking about EIN or endometrial cancer.
Yes, ma'am.
Yeah. And even the doses of MPA also is much higher, up to 400 in EIN or endometrial cancer. 400 to 600.
Okay, ma'am.
And any other question here? Somebody was asking, I think molecular classification.
About the doses, ma'am.
Doses we've just discussed.
Already discussed.
Yeah. I think
for how long we have to give?
See, again, this thing is you have to reassess. If it is atypical hyperplasia and you're doing conservative management, do a biopsy after 3 months. And then after 3 months,
for 1 year.
And then you again repeat it. So you have to, you can even wait up to, people say they wait for regression up to 6 months to 1 year also. But some between up to 1 year, you can wait on your medical management. But we have to do 2 biopsies.
Yes, usually. So if it has not regressed after 2 biopsies, then it's very less likely to regress.
So in that case, you have to go for definitive management. So I think can we wind up now?
Yes, ma'am. I think the time is also over. Okay.
ये molecular classification जो भी पूछा है ना, just type the cancer genome atlas on Google. TGCA classification बोलते हैं इसको. The cancer genome atlas classification.
TGCA classification, and then you can get. So if like what Dr. Paki said, the first you do poly positive negative. If it is positive, well and good. If it is negative, go for MMR testing. MMR you have 4. Basically, you have got the 4 IHC markers: MSH2, MSH6, PMS2, and MLH1. So 4 IHC markers for MMR deficient. In that case, if it is MMR deficient, any of the IHC markers is positive. So that is MMR deficient. If it is MMR deficient, well and good. If it is not, then you go for P53. If P53 is null or aberrant, it is P53 positive. So it is a high risk tumor, that is copy number high. If P53 is negative, it is not expressed, it is non-specific molecular profile or copy number low. This is how the molecular classification divides it into two classes. So poly is good prognosis, a P53 positive one is a poor prognosis, and intermediate prognosis is copy number low, that is non-specific molecular profile, and the MMR deficient group. And the non-specific molecular profile are the ones which you have more of the ER/PR positive tumors will be found in the NSMP group. And besides this, if you want to go for prognostic markers, you have the other molecular markers like CTNNB1 mutations, you have LVSI, you have other mutations are there, but I think we are not dealing with endometrial cancer right now, so let's not confuse and let's just stick to the molecular classification. So that is it. Okay.
All right, you did well. Just read little bit
good presentation
about sensitivities and specificities of various tests and everything. Read little bit about that.
Yes, ma'am. Thank you, ma'am.
Thank you, Dr. Nikhil.
Good presentation. Yeah. Thank you both.
Thank you
Both of
all
them
the
presented very
panelists.
well.
Thank you all the panelists and the presenters. It was a very well presented case and a very well discussed case. Now we are moving to another session of GDM and pregnancy. So I would like to call upon the chairperson for the next case presentation. We have with us Dr. Indu Chawla. Ma'am is professor and consultant in ABVIMS and RML Hospital, New Delhi. And she was also ex-HOD Department of Obst and Gynae in ABVIMS and RML Hospital. The next chairperson for the session is Dr. Priti Saxena. Ma'am is a Director Professor of Obstetric Gynae in Lady Hardinge Medical College. Welcome, ma'am. And the next chairperson we have Dr. Poonam Lal. Ma'am is Senior Specialist in DDU Hospital and with special interest in fertility and high-risk pregnancy. So, and the presenter we have Dr. Arati with us and Dr. Smriti Gupta. So, Arati and Smriti, you can proceed with the case now.
Smriti, you will be presenting the case, beta?
Smriti and Arati, are you guys ready with the case?
हेलो यार कुछ सुनाई नहीं दे रहा
You're audible, Arati.
You are audible now. You can start your case. Hi, Huma.
Arati, you are audible now. Hello, ma'am. So nice to meet you.
Yeah, ma'am. Yeah, please start, beta. We can see your screen and you can start the case.
Ma'am, is our
Arati, your screen is
screen
visible. You are very
visible?
much audible. Yes, your screen is visible and you're very much audible. You can proceed with the case.
ठीक है. Good evening, ma'am. My name is Dr. Arati and Dr. Smriti Gupta. So my patient is Mrs. X, wife of Mr. Y. She is 30-year-old female, resident of Pritampura, New Delhi. She is teacher by occupation, and then her husband is businessman who is a graduate. Her socio-economic status is upper middle class on modified Kukusam. So she is primary gravida with 8 months of amenorrhea with GDM on MNT. Her presenting complaints were present complaints. She is a primary gravida with 8 months of amenorrhea with GDM on MNT, admitted from OPD due to poorly controlled blood sugar levels. Then history of present illness. Patient was diagnosed with GDM due to abnormal values of 75 gram of OGTT with fasting of 118, 1 hour 120 and 2 hours was 190. She was given MNT and was regular blood sugar monitoring was done since past 2 weeks. She was now admitted in view of deranged blood sugars. So her fasting at present was 140 and 2 hours was 170. She had no history of pain in abdomen, no history of leaking PV, no history of bleeding, fever with chills, no history of burning, maturation, increased frequency of urine maturation or dysuria. No history of constipation, nausea, vomiting. No history of raise in BP throughout the antenatal checkup, or no history of headache, blurring of vision, pedal edema, or epigastric pain. Her menstrual history, she attained menarche at age of 13 years. Her menstrual cycle was regular, lasting for 3 days with average flow with no dysmenorrhea. Her LMP was 13 May 2023. EDD was 7 March 2024. According to which her POG is 32 plus 4 weeks. Her obstetric history, she is married since 7 years. That is 2017. It is a non-consanguineous marriage with history of OCP usage or no history of OCP usage or ovulation induction drugs. She is primary gravida. Present pregnancy was natural. Natural conception. She was booked at SGRH. So in trimester 1, her pregnancy was confirmed by UPT at 1.5 months of missed periods, followed by confirmation with USG dating scan on 2nd month of pregnancy. She had no history of nausea, vomiting, fever with rash, burning, maturation, drug intake, radiation exposure, no history of trauma. Throughout first trimester, she had intake of folic acid. USG scan and dual marker was done in 3rd month of pregnancy, which was normal. Her all ANC test was reported normal, including the blood sugar level. In 2nd trimester, she started perceiving adequate fetal movement by 6 months of pregnancy. Then she started having iron and calcium. USG done at 7 months of pregnancy, reported normal. She received first dose of PT at 6 months of pregnancy. No history of rise in BP, perial edema, epigastric pain, headache, blurring of vision, or sudden increase in weight gain throughout 2nd trimester. She had no history of burning, maturation, fever with chills, or bleeding per vagina. No history of increased frequency of maturation. She had adequate weight gain. She was diagnosed during her 2nd trimester. She was diagnosed with GDM at 28 week of gestation to 75 gram of OGTT. After which she was started on MNT and advised for regular isometric exercises. In 3rd trimester, she continued perceiving adequate fetal movement. She continued tablet iron and calcium. She had no history of discharge, burning, maturation, pain in abdomen, or history of rise in BP, blurring of vision, headache. Injection given at 32 weeks of gestation. She continued. It was found to be normal initially, but raised blood sugar was found recently, and she was advised for monitoring and optimization of blood control. No history of diabetes, hypertension, or thyroid disorder. She was negative for any medical illnesses and negative for any surgery done in the past. Her family history was negative for diabetes mellitus, hypertension, asthma, twin pregnancy, congenital mixed diet, moderate. She had good appetite. Addiction was normal. कौन connected था? अरे बाप, छाप भी गया. मिकी का वाईफाई हटाओ.
Arati, your presentation is going on.
Arati, Peter, we can't hear you.
Ma'am, there is some problem with connection. There is some problem with your connection, beta.
You use
Arati, we can
earphones.
see.
आरती सुनाई दे रहा है.
Arati, we can see you.
अच्छा ठीक है.
and
So
we are able-
patient her
Make it slideshow, beta. Again, make it
make it
slideshow.
a slideshow, and slide was stuck at personal history.
Her addiction, she had no addiction. She had adequate sleep and wake cycle. Her bowel and bladder habit were normal. Then her provisional diagnosis, she is primary gravida, 32 plus 4 week of gestation with singleton pregnancy in cephalic presentation with gestational diabetes mellitus on MNT with deranged blood sugar.
Can we interrupt you now and ask some questions?
Yes, ma'am.
Would you like to summarize your case, beta?
Ma'am, she is
Can't hear you.
primary gravida.
Your connection is not very good. I think we can't hear you.
32 plus 4 week of gestation and 2-hour blood sugar. Following which she was put on MNT, which it was raised since past 3 days. Hence, she was admitted in the hospital for
Arati, are you done, beta?
Please share your slide again.
अरे यार ये क्या हो रहा है?
Arati, your slides are not visible.
मैम अभी भी नहीं दिख रहा है क्या?
अब
दिखा.
Acha beta, tell me one thing. What was the test which was done at the first time, and was she registered in Gangaram Hospital since the beginning?
नहीं आ रहा है.
How will we do the thing when they are not able to hear? We are not able to communicate.
There's hotspot. Ma'am, can you repeat the question? Sorry for the.
Beta, I'm asking you at what period of gestation the first screening test was done, and what was the name of the test, and how will you? Yeah, and what was the finding of your? How do you interpret the result?
Ma'am, for her it was done at 28 week of gestation, which reported her fasting as 118. 1 hour was 120, and 2 hours was 190.
So what does this mean? Which is then what is the name of this test?
Ma'am, 75 gram glucose with OGTT.
No. What is the name of the test?
Oral glucose tolerance test, ma'am.
Beta, this is IADPSG test, International Association of Diabetes in Pregnancy Study Group test. And you do it 3 times. And what is the ideal time? Was she registered with you from the first trimester itself?
किससे कनेक्टेड है स्मृति यार?
बेटा तुम में से एक बच्चा अपना मोबाइल यूज कर लो ना. This way we cannot have the class. At least you will be able to hear and answer through that. We can't hear you and you can't hear us.
निकिता का फोन लेके आना. ये इस पे कनेक्ट कर. यार फोन इधर रख और ले. मैम 2 मिनट मैम सॉरी 2 मिनट.
कोई बात नहीं कर लो.
हाँ मैम हमारे गायनी ऑफिस
Ma'am, please share your slide. Are you audible now? Ma'am, are you audible now?
Hello.
Yes, are you audible now?
Yes, sir.
Please share your slide again.
Yes, sir.
So, beta, I was asking, can you hear me now?
Yes, ma'am. Yes, ma'am.
Arati, I'm asking you,
Yes, ma'am.
when was she registered in Sir Gangaram Hospital?
Ma'am, during her first trimester.
And routinely, what is the time when you do glucose testing for all patients, pregnant patients?
Ma'am, it is always done between during her first visit, followed by in second trimester between 24 to 28 weeks.
So why was it not done in the first trimester itself? You are showing here that it's being done at 28 weeks. So it was not done in the
Ma'am,
first
first
trimester?
trimester also. No, ma'am. Her first trimester, her fasting blood sugar were done, including her all ANC tests, which reported
Just
normal.
go back. Just go back. So in the first trimester, you don't do a OGTT. You don't do any screening. You just do fasting and PP. You don't even do a 75 gram.
Ma'am,
that is what you are saying? I don't think you are clear about it. Because you are writing here that OGTT is being done at 28 weeks. Now she is being admitted in view of deranged blood sugars, and the sugars are this 140 and 170. Am I correct?
Yes, ma'am.
So, beta, it should have been done in the first trimester. So what do you say when you see how do you interpret the results when you see on your screen these blood sugar levels of fasting 140 and 2 hours 170?
Ma'am, according to IADSP, 75 gram is given, in which fasting is usually less than 90. Her 1 hour is less than 180 and 2 hours is less than 153.
Please hear the question properly.
So her fasting is high.
I'm asking you, see the second one, 140 and 170.
Yes.
And now you are telling about
Yes,
IADPSG.
ma'am.
So how do you interpret this second result of 140 and 170? What does this mean?
Ma'am, this was after admission. She got this report fasting as 140 and 2 hour as 170.
So this means that she is a patient of overt diabetes. If at any time any
yes,
woman
ma'am.
gets a fasting plasma glucose of more than 126 or 2 hours post glucose more than 200, then she is said to be having overt diabetes. Okay, so your diagnosis of GDM is not correct after this value. That is what I'm trying to imply.
Yes, ma'am.
And the other
Yes, ma'am.
problem is that
Yes, ma'am.
IADPSG, you should know what test is being done in your institute, whether it is DIPSI or IADPSG, and you have to do it in the first trimester. If she's an overt diabetes by the
Yes, ma'am.
second test, you could have detected it in the first trimester itself. You have wasted a lot of time. The damage is already done. Okay, chalo, go ahead. So at 28 weeks, you find these blood sugars. So how do you proceed? You put the patient on MNT or what do you do? Would you admitted the patient? What did you do?
No, ma'am, we will start. We admitted the patient. We started the patient on insulin and we did 7-point blood sugar charting.
But you have written that you started her on MNT. Go to your conclusion of the history of your history.
Ma'am, it was during the first 28 weeks. She was started on MNT for 2 weeks, which reported like not much control. Hence, she was admitted in the hospital. Initially, we started MNT now.
Beta, at 28 weeks, if the blood sugar is 118, will you like to, and 190 is the 2 hour, would you like to start her only on MNT or would you like to do something else? Smriti, you can also answer.
Ma'am, we start on MNT and regular blood sugar monitoring. And
with exercise.
Metformin.
MLT with exercise, ma'am. Lifestyle modification.
Beta, there are certain indications, like when the patient's period of gestation is less than 12 weeks, 28 weeks or more, if the blood sugar fasting is more than 110, or she's an overt diabetes, or she's having any complication like macrosomia, polyhydramnios, you straight away start on insulin. You cannot waste time on MNT for 2 weeks. Do you think such a high blood sugar will come down? And especially after you admitted her, and you have not shown the 7-point blood sugar profile here. You have shown only fasting and 2 hours after breakfast. 7-point blood sugar profile should be done. And as per the record you are showing in the Niche Wala table, she's an overt diabetes. So you have to do a lot of things. You have to start her on insulin. Okay?
Yes, ma'am. Ma'am, after admission, she was started on insulin with 7-point blood sugar charting.
Why 7-point blood sugar charting is not shown here, Bachi? You have just shown fasting and PP, and I think this is not adequate, na? What times do you do the blood sugar profile? 7-point, may what are the point intervals where you are doing the test?
Ma'am, at 6 a.m. fasting and the postprandial and at 2 a.m.
Huh?
Every pre-meal and post-meal and 6 a.m. 2 a.m.
Ma'am, fasting, post-breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner, and 2 a.m.
Why you are doing at 2 a.m.?
To rule out the somogy and the Downs phenomena.
Correct.
If she's on insulin.
Okay, so once you admitted this patient, what was the blood sugar profile? First important thing is what was the blood sugar profile you were getting? The other thing is what are the other tests you would like to do? You can do it either at 2 a.m. or 3 a.m. 3 a.m. is a better thing rather than doing at 2 a.m. And do you know what you will get in the dawn phenomena and what will you get in the somogy phenomena?
Yes, ma'am.
Ma'am, dawn phenomena is when the blood sugar is stable at the night and there is hyperglycemia in the morning, which indicate that we need to raise the insulin, but we need to decrease the dose of insulin. But in the samogani,
What happens in the morning to the blood
decrease in-
sugar? I can't get you properly.
Ma'am, counter-regulatory hormone increases, which causes rise in blood sugar level. And in samogani, ma'am, there is decrease in blood sugar level at
2 a.m.
2 a.m. followed by rise in blood sugar level in the morning morning test. Hence, this indicates that we need to increase the dose night dose of insulin because the counter regulatory hormone try to increase whenever there is hypoglycemia at night.
So it is very important to do it at least once or twice in a week for at 3 a.m. And what other tests you did when you admitted the patient? Did you do any other routine tests for this patient?
Yes, ma'am. Yes, ma'am. We do the liver function test, we do the kidney function test, and we do the HbA1c and urine ketone and urine sugar and 24-hour urinary protein.
HbA1c, ma'am, fundoscopy,
and ultrasound for fetal well-being and the Doppler.
ECG also, because you want to rule out any kidney involvement, retina involvement, cardiovascular system you want to evaluate. All those things have to be seen. So you will go ahead with that. Okay. So which insulins? I think you can finish your examination and then we can continue. I was not finding these things to be okay. So that is why I asked you the question in between. Otherwise, it is not necessary to do a 2D echo in all GTM patients, because if ECG is normal, she's a young patient, S1, S2 is fine, then you can just do an ECG. And ultrasound for kidneys can be done. If you find any abnormality, then only you will go for Doppler or any other test.
Okay. On general examination, patient is conscious and well oriented to the time, place, and person. She is average build. Her height is 160 centimeters 160 centimeter and the weight is 60 kg pre-pregnancy, and the pre-pregnancy BMI is 23.4 kg per meter square. Present weight is 68 kg. She is average nutrition. There is no pallor, uterus, jaundice, pedal edema, and lymphadenopathy. There is no dilated veins. Thyroid glands is normal. Breast is normal. Changes of pregnancy is present. There is normal gait, and oral hygiene is fair. Her pulse rate is 78 beats per minute, regular, good volume, no radial and no radiofemoral delay, or peripheral pulse is palpable. Blood pressure is 120/80 in both arms in supine position. Her respiratory rate is 18 per minute and she is afebrile. On cardiovascular examination, apex peak is present in the fourth intercostal space and it's regular, and S1, S2 is normal. On respiration, air entry is equal on both sides. There is no added sound or Krebs heart. On abdominal examination, abdomen is longitudinally distended. Liquor is clinically adequate. Umbilical in midline and everted. Linea nigra and stria gravidarum is present. No scar, no dilated vein and excoriation seen. All quadrant moving equally with respiration. All hernial sites are normal. On palpation, fundal height corresponds to the 32 weeks period of gestation. Symphysis fundal height is 32 centimeter. Abdominal girth is around 33 inches. On fundal grip, broad, soft, irregular mass suggestive of breech. On lateral grip, a smooth curved surface suggestive of fetal back felt on the right side, and the knobby structure suggestive of fetal limbs on the left side. Clinically, liquor appear adequate. On first pelvic grip, a smooth, round, hard, palatable mass suggestive of head at the lower pole. And on second pelvic grip, both hands convergent below fetal head, suggestive of non-engagement. On auscultation, fetal heart rate is 140 beats, 140 per minute, regular in right spino-umbilical line. On local examination, there is no leaking, no bleeding per vaginum seen. On investigation in first trimester, blood group is for B positive and on viral marker is negative. HPLC is normal. TSH is 2.43. Fasting blood sugar is 84 and the 2R is 110. Urine routine micro is normal. At 28 weeks, CBC is hemoglobin is 12. Platelets count is 1,97,000. TLC is 11,000. OGTT is 118. Fasting is and the 1R is 121 and the 2R is 190. Urine routine micro is normal. Ultrasound on admission show the single live intrauterine fetus of 32 weeks, cephalic position, placenta is fundal and in the upper segment. AFI is 10, estimated fetal weight is 2.5 kg. And biophysical profile is 10/10. 10 Dopplers is normal.
You have not charted on a growth chart. What is, can you, interpret this ultrasound finding? Anything abnormal in this ultrasound finding? You should have ideally plotted on a growth chart, na? What is the percentile?
Yes,
At 32 weeks, she's already 2.5 kgs. What does that mean?
Ma'am, higher normal.
So, beta, you need to always, especially in a GDM or diabetic patients, you have to do on a serial growth chart. Okay. So she will come out to be, in the highest centiles, maybe 90th centile or something. So you have to be aware about the chances of macrosomia. Okay. And especially I told you, if any patient is having large for gestational age, baby weight, or she's having increased liquor, or she's having even FGR, any disproportionate fetal growth, ज़्यादा या कम or increased liquor, then you have to immediately start her on insulin. That means it's a serious metabolic derangement. Okay. Or if you get any of the other things, the profiles that we got, fundus, kidney, heart, anything abnormal, then again, vasculopathy means that you have to start her on insulin. Okay. Doppler is not very important because liquor is generally never compromised. and only when the Doppler flow is compromised, that will indicate the uteroplacental insufficiency. In these cases, unless you have uteroplacental insufficiency or FGR, or you are having chronic kidney disease or hypertension, you need not do a Doppler. It will falsely show everything normal. You have to do a serial growth chart. That is very, very important. And also see the serial abdominal girth. And if you can do a 3D limb volume estimation, that is a new this thing to measure for macrosomia. Okay, these things are very, very important. Go ahead. Have you finished?
Case summary, Mrs. Yes, ma'am.
Yeah. You can show case summary.
Case summary, Mrs. X, 30-year-old primary gravida at 32 weeks period of gestation with over diabetes on insulin with.
अब देखो यहाँ पे भी you have written MNT ना?
Yes, ma'am.
That is what I was saying in the summary. Also, you had written MNT. Now you have already started her on insulin, so you should not be writing this, no?
Yes,
okay, go ahead.
He is perceiving adequate fetal movement, and recent ultrasound and NST done for the fetal well-being was normal. Physical exam what showed the growth is more than 98 percentile. Physical examination did not yield any significant abnormality. Vitals are stable. Fundal height and abdominal girth correspond to the period of gestation by LNP and the ultrasound. Baby is in cephalic presentation and head not engaged. She has now had been admitted for monitoring the blood sugar level.
Okay, go ahead. You were showing the blood sugar profile.
Ma'am, after admission on insulin therapy.
Yeah. So you have done a 7-point blood profile. And what is the target blood glucose values? For fasting
on insulin, ma'am.
And you do it after 1 hour of meals, or you do it after 2 hours of meal?
Yes,
target for fasting is less than 95. For 1 hour is less than 140. For 2 hours is less than 120.
So are you doing at 1 hour or 2 hours?
2 hours.
2 hours.
You should never do it at 1 hour, because at that time the peak is there, and as a norm we are just taking 2 hours. So it's good you have highlighted all the values which are above the threshold. So how do you calculate the dose of insulin?
Ma'am, dose of the insulin is calculated according to the trimester wise. In the first trimester, the dose of the insulin is 0.7 to 1 kg per unit per kg, and in the second trimester, insulin is 0.8 to 0.9 unit per kg, and in the third trimester is 1 to 1.1 unit per kg. And after calculating the whole doses, we divide the doses into the
Just wait, beta. All patients will have different type of requirement for insulin, depending on their BMI, depending on their insulin resistance, depending on their genetic this thing also. So what you need to do is that you have to see how much above target this is. Like the first one, fasting, you said should be 95, but this is 118. So 118 minus 95. Utna आप करोगे, and just remember 1 unit is going to take care of 20 to 30 milligram of blood sugar. So accordingly you will increase, put the dose here. 95 के बाद देखो कितना बढ़ाएंगे, 18 plus 5 है ना? So 1 unit you will have to give here. Then 2 hours post breakfast is 151, which is it should be 120. So 31 ज्यादा है, तो 2 units बढ़ जाएगा यहाँ पे. ऐसे ही करके throughout you have to calculate the whole dose. After calculating the whole dose, now what you were saying earlier, now you can speak. You divide it into 2 doses, and 2/3 is given in the morning, and 1/3 is in the evening.
In the night.
Yeah. But the other good thing is you are in a private setup and where the patients are affording and well educated, you can put them on rapid insulin just before the meals. So in Gangaram, you are still putting them on regular insulin and NPH?
Yes, ma'am.
Okay.
Regular
So
insulin,
when is
what is-
insulin given, regular insulin given with respect to the meal? How
Ma'am,
long
30
the
minutes
action
before
will
the meal.
last? When does the peak come? You should be knowing all these things about the insulins that you
The
are using.
action will start in 30 minutes. It will peak in 2 to 4 hours and it will last for 4 to 6 hours.
For which one you are saying? For regular insulin?
Regular.
30 minutes to, okay, 30 minutes, then about 2 hours and about 6 hours, right?
6
And
hours.
what about NPH?
Ma'am, NPH onset will take place 1 hour after injection and will last for 10 to 14 hours.
It will last for about 18 hours. Okay, and the peak will come at about 4 to 6 hours. And what about the rapid insulins? Which are the names of the rapid insulins which are available? Which are safe in pregnancy?
Lispro and the ma'am, both are safe.
Very good.
Lispro and the Aspart.
Onset
Lispro
is
and
like
Aspart.
15
And
minutes
when
and
do
will
you
last
take
for
Lispro?
15 minutes before the
Before
You
meal,
can
ma'am.
take it at the start onset of meal. And when will the peak come and for how long the action lasts?
Action will last for 2 to 4 hours and the peak will be in 30 minutes to 1 hour.
Correct. So it is going to coincide with the postprandial peak and it will take care of which is the most harmful thing. It is the postprandial peak which is going to cause most harm to the mother and the baby. So this will be physiological rise and it will take care of that physiological rise. Okay. And the other advantage of these rapid insulin is what?
Ma'am, it does not change. It is not intervened with the inter-meal interval. Matlab, it does not causes hypoglycemia.
Yeah, because
if it causes,
the action
then
is going to go finish in 4 hours or 6 hours. So it will not cause hypoglycemia later on, which you see in your regular insulin because the action is going to be
regular
longer. Okay, and which are the basal
long
insulins
lasting.
or the long acting insulins?
Glargine and degludec. Glargine and degludec.
Glargine, is it safe in pregnancy? Which are the ones which are
no,
being
ma'am.
recommended to be used in pregnancy?
Detemir.
Very good. So detemir and
Detemir.
degludec recently has been approved. Glargine, if the patient is already controlled on glargine, you can continue. But if you are starting newly during pregnancy, then you start on either of these 2 drugs. Okay. Okay. And what about what are the advices you are going to counsel the patient before you are starting her on insulin? What are the important things you have to keep in mind?
Ma'am, we advise the patient. We advise the patient and tell the patient the sign and symptoms of the hypoglycemia. And
we will advise her on, apart from giving injection insulin, we will advise her for a lifestyle modification, dietary modification, exercise, blood sugar monitoring, as well as signs and symptoms of hypoglycemia. And in case if she has hypoglycemia, she has to take sugar immediately.
Yeah, so you will have to also explain to her how to measure the blood glucose on a glucometer and what are the signs and symptoms. Please explain. What are the signs and symptoms?
She will have, ma'am, sweating, tremors, palpitations, anxiety, irritation,
and dizziness.
Okay. It can be mild, moderate, severe. You should be knowing. And how much sugar you will give and how much glucose to be given if she has hypoglycemia. And what is hypoglycemia in pregnancy? What is the level when you say it is hypoglycemia?
Less than 17.
Okay. So what? How much glucose she has to take and how much sugar?
Ma'am, we can tell her to take 15 gram of glucose or 3 tablespoon of sugar.
Or glucose?
Ma'am, 15 grams.
What other thing you tell
15.
them?
Ma'am, we will tell her to always keep some biscuit or sweet thing with her.
After taking glucose or sugar, she can wait and then you measure the blood sugar level again. And if it is improving, then you tell her to take a regular meal also. So it is very, very important that when you are starting a patient on insulin, you tell her and her caretakers about how to measure the thing properly. What are the target values you should write down on the ANC card कि fasting इतना है and PP should be this much, and if it is above this you will have to come back to us, and also explain the signs and symptoms to her and her husband or mother-in-law, whoever is available with you. Okay.
Yes.
Okay. If next day you find that you have increased the dose of insulin and you find two values are still high, what will you do?
Ma'am, according to the मैम कितना हाई हो रहा है उसके अकॉर्डिंग इंसुलिन की जो डोज एडजस्ट करेंगे अकॉर्डिंग टू द स्लाइडिंग स्केल.
Beta, we can wait for 48 to 72 hours for the action of insulin to come. हमारे यहाँ भी बच्चे एकदम से next day they are trying to increase the dose, but you need to wait. And what other important thing is that if only 33% of the reports are high, then only you need to start. Increase the dose.
Yes.
Otherwise, you just see what she's eating. Most of the times you will see that she's not taking the diet properly. उसने छोला भटूरा खा लिया या कुछ मीठा खा लिया. So you please try to titrate the diet of the patient. Also see if she's taking, if she's got any infections, if she has any other stress, or she has missed her dose of insulin in case sugars are high, or if she's taking, if she's getting hypoglycemia, you have to see if she's taking adequate diet, because many of the times, I'm seeing that most of the kids are, babies being born are just 2.5 or even lower birth weight, because we are not giving them enough proteins. That is also very, very important. Okay, so diet is extremely important. And insulin, you will like to start insulin or metformin? You were in the history, you were saying metformin?
Insulin,
ma'am, insulin.
Initially in the history, you said we can give
Initially,
metformin.
No, ma'am. Insulin, ma'am.
Okay. So in which cases can you give metformin? Is metformin recommended for use in pregnancy?
Yes, ma'am.
Ma'am, it is recommended, but if patient is already over diabetes, it is better to start as insulin as a first line. But in case if patient is refusing, if she doesn't want injections, insulin injection, we should still counsel patient and then we can give her metformin.
She is not ready to, she cannot buy a glucometer, she stays far away, she is non-compliant. Okay, and she's very scared, patients get very scared कि आज तो हमने ज़्यादा खाया है, मीठा खाया है, so we are having high blood sugars. It is very important to counsel them at the first time. And especially if the patient is obese or the blood sugar levels are marginally high and she's just GDM, not having any other complication, then you can easily start her on metformin. Although you should know that the regulatory authorities have not approved metformin for use in pregnancy. But all the guidelines, now tell me which guidelines say that metformin can be used in pregnancy.
Ma'am, metformin in gestational trials.
I'm talking about guidelines. Yes, somebody has written nice guidelines. Nice guidelines say that you can use it as first line also. Now the DIPSI guidelines 2024 say that you can use it. The MOHFW, the Indian guidelines say that you can use it after 20 weeks of gestation. The American Diabetes Association and the American College of Obst and Gynae, both of them say that you can use it as a second line. Why there is so much controversy for metformin?
Because, ma'am, blood sugar control is better with insulin,
because it is a category B.
Something more important. Because metformin crosses the placenta, na? And it can cause epigenetic changes, fetal programming. Okay, so we generally, and you know, the babies who were born to mothers who were taking metformin.
Feed growth restriction.
What risk, beta?
Ma'am, it is said in the trial, it is fetus are born with growth restriction, not that much, but still it has been seen. But
Yes.
still they recommend matlab, you can still give.
So, beta, there are certain, what I was saying was that these babies were followed up for 10 to 14 years. Latest follow-up is till 10 to 14 years. And the babies whose mother took metformin had more amount of subcutaneous fat and visceral obesity as compared to the babies who had taken, whose mothers had taken insulin. But what are the advantages, in which conditions you will give metformin? And there are some contraindications where you should avoid metformin.
Ma'am, metformin reduces the dose of the insulin, which also
Very
causes
good.
weight loss in the mother.
So if very high doses of insulin
then-
are being required, then you can use. What is the other one?
Ma'am, it also
Obese
causes
patient,
weight
beta.
loss.
Yes. So if the woman is obese, then you can use, because it will reduce the amount of weight gain during pregnancy. And you were saying something about what are the conditions where you will not give metformin at all? It has to be avoided.
Ma'am, if patient
is suffering from the liver disease, it is contraindicated in the liver disease.
Right. What else? Over diabetes में तो देना ही नहीं है. And those 3-4 fetal complications I told you, उसमें भी नहीं देना. Less than 20 weeks पे government of India says you should not give. But the important ones are if the patient is having hypertension, okay, preeclampsia, chronic hypertension, or gestational hypertension, or she's having renal disease, or she's having uteroplacental insufficiency, okay, FGR. In those conditions, you should never give metformin. If she's already having B12 deficiency, okay, so again, you will not give. Juvenile onset of diabetes, beta, any type of diabetes which is preceding pregnancy, which is also known as pre-gestational diabetes, overt diabetes, diabetes in pregnancy, on sare conditions mein you will avoid metformin. So the safest bet is this one. In labor, what medicine you give? Labor,
Ma'am, in labor, Ma'am, in diabetic ketoacidosis, we give the insulin, and in labor, we also give the insulin.
Yes.
Sliding scale.
According to the sliding scale.
Yeah. You have to use insulin because metformin, the dose you cannot regulate and titrate depending on the blood levels. It will not immediately bring down the levels. And somebody has asked why you can't use in hypertension, because it has been seen that it interferes, you know, that it alters the pyridoxine metabolism. So it interferes with the DNA formation.
Yes, ma'am.
And it reduces the weight gain. That also you know. So in hypertension, there is already vasospasm and reduction in, there are chances of uteroplacental insufficiency. So it is going to restrict the weight even more, and it causes stillbirth. So a warning has been given in the American Diabetes Association and the latest papers, which are showing that it should not be used in these conditions. Okay. Somebody has asked, ma'am, can we give metformin with insulin? Yes, that's what I'm saying. In overt diabetes, if the patient is on very high blood sugar, insulin doses, blood sugar values are not getting controlled, or she's obese with overt diabetes, then also you can give this. Okay, and in diabetic ketoacidosis during labor, or when you are giving her steroids, dexamethasone for lung maturity, you will have to control with insulin. Some people ask, can we increase the dose of metformin? That is not going to take care. Within 12 hours of dexamethasone, you must have seen blood sugar levels go high, and it is going to stay high for 3 to 5 days. During that time, over and above what regular doses of insulin you are giving, you will have to increase the dose by 30 to 33%. Okay, so that way you have to do. And sliding scale is over and above what you are giving. This is the ones we discussed is the regular insulin dose that you are going to titrate. And you will have to increase the dose. At that time, you will not give the same dose. You will have to increase as per the blood sugar values. And you will have to do blood sugar values more frequently, not just 7 times. You will have to do it 4 hourly and also do ketones in the urine to check for ketoacidosis. And the maximum dose of metformin permissible
Ma'am,
in
2 kg. Ma'am, 2 gram.
So
2
how do you
grams.
start and what are the problems the patient faces when you start with metformin?
Ma'am, it has metallic taste. It causes nausea, vomiting, gastric irritation.
Lactic acidosis
It's
and
worst side effect.
Lactic acidosis
hypersensitivity
is
reaction.
extremely rare. Patients with kidney disease, liver disease, only those are going to get. But what you said very rightly is gastric side effects are there. So the precaution you can take is you can give her with meals, okay, or after meals. And if you give a sustained dose, immediately the levels will not rise. So that is another thing that can be done, okay. And along with it, you should always give B12 because it is going to cause otherwise B12 deficiency. That is very, very important. So, and in the beginning only you have to tell the patient that in the initial first few months or days, she is going to have this gastric problem, slowly it will improve. And you start with only 500 milligram SR dose and slowly increase it over 1 week. एक हफ्ते के बाद 500 BD, then TDS, and then maximum dose is 2 grams. But generally what I've seen is, in practice, if it is not getting controlled with 1 gram, please switch over to insulin. Okay? Because another problem with metformin is that about 40% of patients are not going to get controlled only on metformin. And anyway, you will have to switch over to insulin. The failure rate is so high, 30 to 40%. And the other thing is that 33% patients can go into preterm labor. So patients who have what history of preterm labor, or when you are doing a first trimester scan like you did in this patient, it's a good idea to see the cervical parameters also.
मेरे को
And
ना
also to do the uterine artery Doppler and see if the uterine artery Doppler is blood flow is reduced, then you can start them on aspirin. If the cervical parameters, the length is reduced, then you can, you should not put them on metformin and put them on progestogens or put a surclarge. Is the time over?
No, ma'am, we still have 7 minutes.
Okay. So, beta, what are the complications which are seen in diabetic pregnancies?
Ma'am, they have polyhydramnios, preterm labor, macrosomia, PPH, then shoulder dystocia. Then, ma'am, in fetus also there are a lot of complications.
Macrosomia and the fetal growth
Risk
restriction,
of stillbirth,
IUD.
then delay lung maturity, then congenital malformations.
And neonatal complications, we bolo?
Hypoglycemia.
Hypoglycemia, hyperproteinemia, polycythemia, hypomagnesemia, hypocalcemia.
Long-term problems?
Risk. Ma'am, what? Ma'am, they fetus themselves has the risk of developing diabetes mellitus in future, obesity.
Okay, somebody has asked, please repeat the how to calculate the doses of insulin. So what we have to do is, beta, you have to remember that the target fasting is 95 and 2 hours value should be less than 120. So whatever value, suppose you are seeing here, so it is 112. Okay, so this is before meal, so it should be less than 95, 95 or less than 95. So 112 minus 95, whatever dose is coming, 1 unit of insulin is going to take care of approximately 20 to 30 milligram of blood sugar. So jitna high hai, uske accordingly, you will increase the dose of insulin. Is that okay? Like it is 120 here. So 95 is the threshold that we are taking for fasting. So 20 plus 5, 25. So 1 unit. If it was 140 like the children showed in the first slide, if it is 140, then it is 20 units above. Then we can increase to 2 units. That way we have to see each and every one. Like here 120, 145 है, तो 120 घटाएंगे तो 25 ज्यादा है, तो इधर एक डोज मिलेगी. अगर यहाँ 200 होता तो it should be 200 minus 120 and you will need to give 8 units or so. So that way you have to do. And it is best if the patient is affording, give them Lispro. जितना postprandial आ रहा है उसके accordingly you give them Lispro or Aspart. If you are giving regular insulin, you have to give it half an hour to 1 hour before the meal and titrate it accordingly. 2/3 of the total dose that you calculate, जैसे इन्होंने 3rd January का किया है, ये पूरी dose calculate करके suppose it comes as 50. So 2/3 will be given in the morning and 1/3 will be given in the night. And 2/3 will be NPH. Out of this morning dose, 2/3 will be NPH and 1/3 will be regular. Because regular is going to take care of the post-meal, postprandial. And the NPH is going to take care of the pre-meal values and the post-lunch values. That way you have to see, and pre-dinner values also. So that is how you calculate. If blood sugar, I'll just see what question these kids have written. If the blood sugar is 130, kahan gaya wo? Then what dose we give, because 10 units is rice. हाँ, तो 10 यूनिट है ना बेटा, तो आप उसका डाइट कंट्रोल करने की कोशिश करो. अगर उससे नहीं होता तो 1 यूनिट इंक्रीज करोगे. 1 यूनिट से कम तो हम दे नहीं सकते ना. You can easily increase it by 1 unit. If the postprandial is coming as 130, either you titrate. Another very good thing that I've seen is that you split the meal. Suppose she is getting post breakfast values very high, please tell her to take chai and biscuit at 7 o'clock, and then she can split the breakfast, in 2 parts. अगर वो ज़्यादा खा रही है उसको 2 parts में divide कर दो. Small frequent meals are good because peaks are never good. Peak of high blood sugar level and low blood sugar levels, that is known as glycemic variability. So the peaks should be smaller and the blood sugar values should be average, not going beyond 140 and 120. 140 at 1 hour, वो तो हम कर नहीं रहे हैं, तो 120 से ऊपर नहीं जाना चाहिए. And as I told you, only 30% of the values are gadbad. Then you increase titrate the dose. Otherwise, try to adjust the diet, exercise, all those things are going to make a huge impact. Okay. So when do you terminate the pregnancy? I think that is a very important question.
If she is on MLT, then we terminate the pregnancy at 40 weeks. And if she was metformin, then after 38 weeks. And if she is on insulin, then after 38 weeks.
Because see, the Caucasian guidelines say that you can continue till 40, 41 weeks. But in Indian setup, the placenta of the babies are getting mature much faster. So in our setup, even in Lady Harding, we are not trying to take them to 40 weeks. We try to, if she's on diet, we try to terminate pregnancy at about 39 weeks. That is what the Indian guidelines are also saying. So you have to see, and if the patient is on insulin, you titrate between 38 to 39 weeks. Diet control 39 to maximum 40. I would say I would not go beyond 39. 38 to 39 is our threshold. And if the blood sugars are not controlled or she's having preeclampsia, then you will terminate it earlier. Okay. And if the, what about DEXA injection for lung maturity?
Ma'am, we will give only if we suspect, like
if we plan,
like in case of
if you are doing elective cesarean section, till what period of gestation will you give or will you not give?
Ma'am, we will give DEXA before
34 weeks, and maybe it is given 34 to 37 weeks, because in diabetes the surfactant is released less. That why we counsel the patient about the risk benefits and the risk of the DEXA, corticosteroids, and then according to this we can give.
Yes. So
And
that
at
is very, very
37
important. Till 34 weeks, there is no problem. 28 weeks to 34 weeks, you can give DEXA. But late preterm is a problematic period because it has been seen. There is a latest paper from Society of Fetal Medicine. They have said that you have to talk to the parents, both the couples, and tell them that the risk of neonatal hypoglycemia is there. The risk of diabetic ketoacidosis to the mother is there. So these problems, after explaining only, you give them this option of dexamethasone. Okay. And you can give it till 37 weeks. After 37 weeks, there is no point of giving dexamethasone to these patients. And somebody has asked how you titrate the dose. Betnisol beta you do not give. You give dexamethasone because the betnisol, the betamethasone salt, which has been found to accelerate lung maturity, is not available in India. So when you are starting the patient on DEXA, you admit the patient and you do 4-hourly blood sugars and you start insulin over and above depending on the blood sugar values. The sugar values are going to increase after 12 hours and they may stay high till 3 to 5 days. And you will have to also monitor her urine ketones because she has chances of going into ketoacidosis. And after delivery, how will you titrate the blood sugars?
Ma'am, if it is
Ma'am, after delivery,
over diabetes, we will stop.
Ma'am,
If patient is gestational diabetes, then we will do blood sugar monitoring, but we will not give her any OHA or insulin because it is expected that her sugar will normalize. If she is over diabetic, then we will take her insulin to the pre-diabetic values.
Very good.
Along with blood sugar monitoring.
ठीक है. And if she is IDDM, then you will have to titrate according to the doses and about 30% dose reduction will be there. So I think the time is up and thank you. So I think that's it. Okay. All the best.
Thank you, ma'am. Ma'am, we just have one or two questions left behind.
अच्छा मैं देख
Hello,
लेती हूँ.
Miki ma'am.
हाँ हाँ.
हाँ, एक तो था
Yeah,
ma'am,
Ruma.
how to take dietary history in exam. Please tell. And another was intrapartum and postpartum insulin titration.
Okay.
Is insulin drip used in labor?
Okay, insulin drip is used in labor if the patient is GDM and controlled on only diet or metformin. Most of them, 90% or 95% of them are not going to need insulin in labor because the mother is spending so much energy that the sugar levels are going very low. But if she is on insulin, high doses of insulin, then you have to titrate. I think the girls can answer and I can improve the answer. You have to keep what are the target blood sugar levels during labor? 70 to 126. Okay. So you have to keep a 10 unit, 100 ml per hour normal saline on flow. And depending if the blood sugar levels are going below this, you have to put her on 5% dextrose. If the levels are going above 126, then you have to titrate according the blood sugar levels. You have to start 2 units, 4 units, 8 units, depending on the blood sugar levels. In that 100 ml per hour wala NS drip, you will be adding insulin. That is how you titrate. Okay. And please keep the patients on oral clear fluids or start NS for these patients. Also keep on doing blood sugar charting by glucometer. And if it comes abnormal, please check it with venous sample because sometimes the calibration is not okay. That is also very, very important. And also do urine ketones because many times our patients you are not giving them anything to eat. You're not starting a drip. So they can go into hypoglycemia. Especially during second stage, you have to be very, very careful. And it is best if you can do a CTG for these patients or you do a frequent auscultation as per standard norms. 5 minutes after every contractions in the second stage, 15 to 20 minutes or half an hour at least in real scenario, half an hour in the first stage. That is how you monitor. And minimal number of PVs, ARM late karna hai, and asepsis maintain karna hai. Keep a low threshold for cesarean in these patients. Because even if the head will come down, if the shoulder gets struck, then you are born. And any patient who is having a delayed second stage or slow progression of labor or second stage arrest, it is better not to go for instrumental delivery. Please take her up for cesarean section. Pediatrician should be present, and the pediatrician will take care of the baby. Hypoglycemia testing will be done on the baby. That is very, very important. And at the time of discharge, please make sure that she comes back at 6 weeks. And as Dr. Smriti has told, we have to titrate the pharmacotherapy and continue lifestyle even after delivery. Please tell her that 50 to 70% of them are going to develop diabetes within 5 years. And their babies are also highly prone because epigenetic changes have already occurred in your patient beta. In Gangaram, I never expected this would be done. तुमने तो उसका इंट्रायूट्राइन प्रोग्रामिंग गड़बड़ करा दिया, पहले ही कराना चाहिए था. ठीक है, so that is it. And dietary history, Huma, it will take a long time. I think the time is up. It's already 7:15.
Yeah, ma'am.
So it maybe next time we should take.
Sure, ma'am. So thank you so much, everyone.
No, you don't
chairperson and
reduce the dose
presenters.
immediately by 30%. It is just an approximation. You have to do a charting. You don't have to do 7-point charting. Fasting PP करिए, या अगर ज़्यादा high है तो उसको post meal वाला कर लीजिए. But you have to titrate according to that. Okay. Thank you.
Thank you, everyone. Thank you, the chairperson and the presenter. It was a very well discussed case. So now we have to move for the next case, which is on primary amenorrhea. I would like to welcome the chairperson for the case. We have Dr. Abha Majumdar with us. Ma'am is emeritus consultant and director and head of Center of IVF in Sir Gangaram Hospital. Welcome, ma'am. Our second panelist, chairperson is Dr. Shweta Mittal. Ma'am is senior consultant, Center of IVF and Sir Gangaram Hospital, and she's also co-chairperson over here. The third panelist with us is Dr. Tanya Bakshi. Ma'am is principal consultant IVF reproductive medicine and onco fertility Max Super Specialty Hospital in Delhi. So welcome, ma'am, and I would like to welcome my presenters too, Dr. Nikita Sharma, a third-year primary DNB resident in Sir Gangaram Hospital, and Dr. Ritushree, she is second-year primary DNB candidate of Sir Gangaram.
Good evening, everyone. I'm Dr. Nikita Sharma. This is Dr. Ritushree. We will be presenting a case on primary amenorrhea. My patient is Ms. V. She is 15 years old, resident of Ranchi, Jharkhand. She is doing 10th standard, does well in studies. She belongs to upper middle class as per modified Fukusami scale. She presented with complaint of no onset of menstruation. There is history of onset of pubic hair and breast development along with axillary hair development at 11 years of age. There is no history of cyclical abdominal pain, heaviness or mass felt per abdomen, no complaint of headache, visual disturbances or vomiting, no history of any secretion from breasts, no history of any significant weight loss, vigorous exercise, stress or eating disorders, no history of increased facial hair, acne, heaviness of voice or hyperpigmentation of skin. No history of hot flushes, mood disturbances or vaginal dryness, no history of swelling in inguinal region, no history of weight gain, constipation, heat intolerance or cold intolerance, no history of evening rise of temperature or chronic cough, no history of any drug intake, chemotherapy or radiotherapy, no history of any skull injury or skull surgery, no history of any anosmia, No history of malnutrition and starvation. No history suggestive of chronic renal failure or chest wall irritation or liver. A past medical history, she is not a known case of diabetes mellitus, systemic hypertension, tuberculosis, thyroid disorders, or meningitis. No history of any long-term medication. Past surgical history, she has no history of any previous surgeries. Family history, her mother and sister attained menarche at 13 years of age. No developmental delay and menstrual irregularities in sister. No history of tuberculosis, diabetes, hypertensive disorders, asthma, thyroid disorders, or PCOS in family. In her personal history, diet is mixed pattern, appetite is normal, sleep-wake cycle is normal, normal bowel or bladder habits, no history of any substance abuse or smoking.
On general physical examination, my patient was conscious, oriented, moderately built and nourished. Height was 168 centimeter. Weight was 58 kgs. According to the calculation, BMI came out to be 20.5 kg per meter square. Thyroid was normal. Breast was Tanner stage 4 and no secretions were present. Axillary hair was present. No icterus cyanosis, clubbing, lymphadenopathy, or pedal edema was observed. No acne or male pattern balding and hirsutism was seen. Spine and gait was normal. Temperature was 98.4 degrees Fahrenheit. Pulse rate was 86 per minute, regular in rate, rhythm, volume. BP was 130 by 70 mm per Hg, measured in right upper arm in sitting position, and respiratory rate was 18 per minute. On systemic examination, CVS S1 and S2 were heard, no murmurs were heard. Bilateral on respiratory system examination, bilateral air entry was equal, no adventitious or added sounds were heard. On CNS examination, no focal neurological deficits were seen. On per abdomen examination, it was soft, non-tender, and no mass was palpable. On inguinal region, no mass was palpable. On genital examination, local examination of external genitalia was suggestive of pubic hair, Tanner stage 4. Labia majora was normal. Labia minora was also normal. External urethral meatus was normal. There was no clitoromegaly. Per speculum examination was not done. Per vaginal examination admits one finger. Vaginal dimple of 2 centimeter was seen. Per rectal examination, rectal mucosa was free and uterus and cervix was not felt.
To summarize, the patient is 15-year-old Miss V belonging to upper middle class, presented with no onset of menstruation, with well-developed secondary sexual characters with blind vagina on local examination.
What is your diagnosis?
Ma'am, she is a 15-year-old female with primary amenorrhoea.
What is your differential diagnosis? Okay.
Ma'am, primary amenorrhoea likely due to Mullerian anomaly.
So what are the two types of important classifications which lead to primary amenorrhea?
Ma'am, there are 4 compartmental defects. The first compartment is anatomical defects. Second involves ovarian dysfunction.
That is, we'll go later on in that type of. It is either hormonal or it is
anatomical.
Anatomical. So in yours, you think it is anatomical. What made you think that there is no hormonal along with anatomical?
Ma'am, patient had normally developed secondary sexual characteristics, which is suggestive of normal ovarian function. And for ovarian function to function normally, there has to be intact hypothalamic pituitary gonadal axis. This rules out hormonal.
You feel that it is normal. Now, one more question. You said the BMI of your patient is 20.5 kg per meter square. So what is the Asian classification for BMI?
Ma'am, in Asian classification, normal BI is 18.5 to 23.9 kg per meter square.
And in the WHO classification?
25, the upper range 25 kg per meter square.
So there is a difference of? 1.5. 1, almost 1. This is 23.9 and that is 25. So this is very important that she's normal BMI. And when you say tuberculosis, do you think primary amenorrhea could happen due to tuberculosis?
Yes, ma'am. Genital tuberculosis is.
Yes, very early genital tuberculosis could lead to primary amenorrhea. How would it lead to primary amenorrhea?
It might lead to adhesion formation leading to Asherman syndrome. That might
complete endometrial destruction, whichever way it is, but complete endometrial destruction would lead to primary amenorrhea. So in this case, did you do any hormones or any imaging?
Yes, ma'am. We did an ultrasound imaging. We did prolactin. We also did, since secondary sexual characteristics were normally developed, but we still did hormonal examination, hormonal assay, and we also did a karyotyping.
What was her FSH?
Ma'am, her FSH was in the normal range, it was 4.7 international unit per ml.
Okay. Do you do a FSH alone, or you would like to do it with one more hormone to know that this value is absolutely correct?
LH, along with LH.
No, along with estradiol also.
Yes,
LH may be important in some cases, especially testicular feminization and all, but otherwise FSH with estradiol is very important. Suppose your estradiol was 300 and FSH is what you said, 5 or 6.
Yes,
what do you infer?
Ma'am, it is a normal.
No, it is not normal.
Ma'am, estradiol is raised, so it might be some ovarian estrogen secreting.
So there are 3 situations. Here, if you say this is agenesis of the vagina and maybe it is Rokitansky syndrome, in that case, you do not know when she's ovulating. So this high E2 could be at the time of her ovulation. If it was a basal E2 in a patient where you knew that this is her phase when she would have menstruated in an otherwise amenorrheic woman, then if estradiol is high, then it shows that FSH is suppressed due to high estradiol. Negative feedback ho raha hai na? So it is very important in especially women who are menstruating to see the FSH and E2 ratio. If E2 is very high on a basal finding and FSH is normal, that means it is being reversed only because of the high E2. And once you bring the E2 down, you will see the true level of FSH rise. This is apart from your case. This does not apply to your case. So what will you do for this girl now?
Can I just take it back? For every patient, you do a vaginal examination at the first sitting, a PV and a PR?
Yes, ma'am. We made the patient comfortable and then we took an informed consent with her mother present at her side.
So you must say all of that as well, because when she is a young child, then that's very important. And in case she said she was not comfortable with the vaginal examination, then obviously you would see if she's comfortable with the rectal. And what ultrasound? You said you did an ultrasound. What type of ultrasound did you do?
Ma'am, we did a whole abdomen and we also asked for a TBS also, but we did a whole abdomen. No, ma'am, not TBS. Sorry. We did a whole abdomen to rule out any renal associated renal agenesis or renal anomalies or any other associated anomalies.
Yeah, I think this is very important because you have to take permission, you have to counsel, but a rectal examination may miss out a dimple in the vagina and an absence of cervix. It's not easy to do a rectal examination for a 15-year-old also. So the best is to take a consent very gently, separate the labia and go in with the little finger and see whether there is cervix or there's no cervix, whether there's hymen or no hymen, or whether there's a vagina. And all the ultrasounds in such girls are done per abdominally, the best, and with a full bladder. Rectal ultrasounds, these young children do not allow. The probe is too big for these children to be used comfortably. So in theory, you may say, we may not do a PV